advances in medical, life sciences, and AI-driven research. We are honored to have this opportunity to host our distinguished speakers, academic researchers, and students for this exciting event at Masa University today. We would now like to invite everyone to kindly rise and join us with singing our national anthem, Negaraku, and our Masa anthem. Thank you.
Kehidupan menggapai cita, mengutarakan impian. Kita sang juara, dengan raju cemerlang, merintis laluan gemilang, aspirasi negara dijulang. Semakan keyakinan seluruh warga, kita mendapatkan jaringan antara bangsa. Di sini lahirnya profesional berjaya. Kitalah pihak di pentas dunia, University Masa, lambang kejayaan. University Masa, satu kemegahan. University Masa, menuju kemakmuran. University Masa, bersih berdaya saing, berinovasi, berdedikasi, berintegriti, melahirkan insan berkualiti, bangsa jadikan satu yang ini.
We will now have a recital of Doa led by one of our students, Hussein, to bless this occasion. Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Mul kitab Al-Fatihah. Amin, amin, ya Rabbal Alamin. Bismillahirrahmanirrahim. Ya Allah, Ya Rahim. Praise be to God, the Lord of the worlds. Peace and blessings be upon our Prophet Muhammad sallallahu alaihi wasallam and his companions, and for those who followed his example to the judgment day. Allahumma ya Allah. On this blessed day, in conjunction with the MyMed Conference 2025, we beseech thee and grateful towards you in favor of all the infinite blessings to us, your humble servant, to live in safe and prosperous life. We seek your blessing for a flawless progress of this event from the beginning till the end. We seek your guidance to steer clear of events that would be detrimental to the progress of this event. Ya Latif, Ya Rahman, please bless us with your tawfiq and hidayah. Please guide us to greatness, peace, glory, and prosperity in this world and the hereafter. Make us a responsible intellectual. Grant us with a valuable knowledge that will be beneficial to mankind in order to gain your mardatillah. Make us your righteous servant that follow to your commands and neglect sinful act. Please forgive us for our wrongdoing. Ya Munzil Barakah, bestow peace to our beloved country Malaysia. Preserve us from any threat and disaster, neither man-made nor natural disaster. And to you, Ya Allah, we ask for security and prosperity upon us, our leaders, and our country. Bestow patience in us in order to face challenges from you. Please accept our deeds and please reward us accordingly. ربنا عليك توكلنا وإليك أنبنا وإليك المصير. ربنا أتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. وصلى الله على محمد وعلى آله وصحبه وسلم والحمد لله رب العالمين. آمين يا رب العالمين.
So thank you, Mr. Hussein, for the Dua recital. A very good morning to our distinguished guests, speakers, participants, and our fellow students. My name is Jesselyn. This is Ching Fan Shen, and we will be your hosts for today. Now, let us begin the opening ceremony of our event, a moment that marks the beginning of a two-day conference filled with knowledge, innovation, and collaboration. To commence the opening ceremony, I am pleased to invite our conference chairman, Associate Professor Dr. Venkata Suresh Chini, to deliver the welcome address. Please join me in giving a warm round of applause to welcome Dr. Suresh.
So good morning, everyone. So it is with a great joy and honor that I am welcoming you all for the MASA International Medical Science Technology Conference 2025, MyMed 2025. A special welcome to our students who make up the heartbeat of this conference and to our distinguished delegates. And a special guest today, Prof. Wali, Senior Director of RMC, MASA University, and faculty members and the international guests, thank you for being here and making this event truly global. So the theme of this conference this year is Innovation for Health, that is advances in medical life sciences and AI-driven research. So captures the exciting transformation happening in healthcare today. We are living in a time where technology, science, innovation are blending to solve real-world health problems, and you, especially the young minds here, the future leaders of the transformation. Over the next 2 days, we will be exploring the incredible research, hearing from inspiring speakers, and discover new ideas and areas such as artificial intelligence in medicine, regenerative therapies, digital health, and public health innovation, and etc. This is more than just a conference. This is the platform for learning, questioning, sharing, and dreaming big. So to our student participants, so I encourage you, don't hesitate to ask the questions. and network with our experts and soak in every bit of knowledge. And you are not just attendees, you are active contributors and future change makers. And the keynote speakers, session chairs, and guests, thank you for being here and sharing your expertise. Your presence is what makes this event meaningful and impactful. I want to express my heartfelt appreciation to the organizing committee and faculty of medicine team who worked tirelessly to bring my MIMED conference to life. A big thank you to all the volunteers, student committee members as well. This event wouldn't be possible without you. So let us use these 2 days not only to learn, to build the connections, to get inspired, and most importantly, enjoy the spirit of the scientific exploration and collaboration. So once again, welcome to MyMed 2025. Let's make a memorable experience for everyone. Thank you so much.
Thank you, Dr. Suresh, for the wonderful welcoming address. Next, we are honored to invite Professor Dr. Variapan Raju to deliver the opening remarks. He is the Senior Director of our Research Management Center here at Masa University. Please give him a warm round of applause.
Good morning, ladies and gentlemen. I consider it a privilege to be part of this MyMed conference. Basically, I am not from healthcare, health science background. I'm from social science background. So it's a privilege and honor to be part of this conference and to deliver opening remarks. On behalf of Masha University's Research Management Center, I welcome the distinguished guests, respected keynote speakers, fellow researchers, and my dear students. We at RMC monitor and support, facilitate all the conference, and we are proud that this MyMed has excelled our expectations in terms of quantity as well as in terms of quality. I was being told we have got like 100 papers total for next 2 days for presentation. Very good, and it's something because healthcare is our flagship in Masha University, and this matters a lot for us to have a good number of paper presentation as well as in terms of quality. So I was equally impressed in the diversity of research that are accepted for presentation today and tomorrow, from studies on neuroprotective agents and stem cell healing to innovations in radiomics, wearable technologies, and digital health interventions. These contributions showcase how academic community is not only responding to global challenges, but also leading with the foresight and creativity. At Masha University, healthcare has always been a flagship. Our medicine programs continue to attract nurture outstanding talent, and we are proud to share our investments in healthcare research have crossed beyond a million for the last couple of years. This is not just merely a number, it's a reflection of our unwavering commitment in terms of advancing sciences. The reason I spelled our investment figure is to make you all aware of Malaysia's stand. Let me just give a small statistics here about where does Malaysia stand and how Masha University stands in healthcare index. Malaysia spends around 4.4% of GDP on healthcare. To make this understandable, I will also compare with Australia and Taiwan, nearby countries, how much they spend for healthcare per capita. Okay, that is per person how much they spend. Australia spends around US dollar 5,940 per person. Australia spends 5,940 per person on healthcare. Taiwan spends 2,522 per person, and Malaysia we spend US dollar 346 per person. So like around like 17x they are higher Taiwan, and then 34x they are higher in Australia. We spend 346 US dollars per person on healthcare. Secondly, life expectancy is approximately 76 years, with infant mortality is 7 per 1,000 birth. I believe you all understand the language of infant mortality. That is, for every 1,000 birth, there is 7 live children mortality. This shows healthcare system is adequate and has good number of healthcare practitioners. Lastly, 29% of adults and 40% of Kuala Lumpur experience mental health disorders. 40% of Kuala Lumpur population experience mental health disorders, and only 20% receive treatment, meaning 80% people don't receive treatments. So the key highlight which was quite, very noteworthy is lowering investments in healthcare, higher workforce, but still many without treatment. There is some contradiction over here. When we have less investments in healthcare, another point, there is actually high workforce, but there is no any treatment being provided. So there is a contradiction. This contradiction, and we are in dire need to identify the problems and provide solutions as an institution. With remarkable journey in healthcare science, Masha University is committed to provide meaningful solutions to our policymakers and relevant bodies. This can happen only by constant research. And these research starts only if we discuss in this kind of forum. Therefore, to us, MyMed is very valuable as this becomes a platform to connect you all and engage for several collaborations. I'm sure Faculty of Medicine will be glad to host this impactful conference as this would catalyze more collaborations from pharmacology and diagnostics to AI and public health policies. Our gratitude goes to our esteemed keynote speakers, including Professor Dato Dr. Haji Abdul Razak Mutalif, Dr. Mahendran Shekhar, Dr. Shrikant, Dr. Jirat Suresh, and technologist Dr. Madhyati, among others, whose cutting-edge research insights on topics such as respiratory disease, drug discovery, AI diagnostics, emergency medicine represent forefront of modern healthcare. I conclude my opening remarks by assuring that our Research Management Center will remain devoted to providing all necessary support to healthcare researchers, be it from Masha University or elsewhere. We aim to deepen our support to all researchers and invite institutions, industries, and collaborators worldwide to join us in this mission. Whether you are focused on regenerative medicine, AI diagnostics, or sustainable health policies, there is a space for you in Masha. Let this conference not only be a platform for knowledge and exchange, but also a hub for enduring partnership. I wish everyone a productive and inspiring MyMed 2025. Our appreciation goes to organizing committee of MyMed, who has done an extraordinary job to make this conference successful event. A special thanks, special appreciation to Dr. Suresh, the organizing chair, and Prof. Rusli, the Dean of Medical Faculty of Medicine. Thank you for inviting me, and I wish you all have a great insightful session for next 2 days. Thank you.
Thank you, Dr. Valyapan, for his opening remark. We would now like to invite our organizing chairperson, Dr. Suresh, and our faculty dean, Dr. Rusli, as well as our head of scientific committee, Dr. Chin, to launch the MyMed 2025 abstract book. Please welcome them to the stage.
Okay. All right.
So here is the e-book version for our abstract book today. Please scan the QR code. Thank you, Professor Valyapan, Professor Suresh, Professor Chin, and Professor Dr. Rusli. We hope everyone has already received their copy of our MASA abstract book. Now we would like to invite Professor Dr. Rusli bin Nordin, the Dean of Masa Faculty of Medicine, to deliver his welcoming speech. Please give him a warm round of applause.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. And a very good morning and warm welcome to everyone. First of all, we'd like to thank God for having today's session in a very nice, congenial way for all of us, and all can attend this momentous occasion. Before I start, I'd like to send an apology from our Vice Chancellor, Dato' Ikram, for not being able to come for this opening of this conference. All right, so basically, to our distinguished guests and Prof. Bali and all our delegates and our keynote speakers from Masa and outside Masa, thank you very much for making time for this conference. And to all the our colleagues, staff, students, okay, and everyone that have come today to participate in this occasion of healthcare conference and AI. So it is with great pride and anticipation that I welcome you to the Masa International Medical Sciences and Technology Conference, MyMed 2025, scheduled to take place on the 24th and 25th of June, which is today and tomorrow. And the theme today is, innovating for health advances in medical, life sciences, and AI-driven research, which reflects the transformative journey of contemporary healthcare, driven by scientific progress and technological innovation. In the 21st century, the integration of biomedical sciences with advanced technologies such as artificial intelligence, machine learning, and precision medicine has fundamentally redefined the paradigms of diagnosis, treatment, and healthcare delivery. And MyMed 2025 aspires to serve as a catalyst for such transformation by fostering interdisciplinary dialogue, facilitating research dissemination, and nurturing global collaboration amongst clinicians, researchers, educators, and students. Our team addresses the urgent need to reimagine how we approach complex health challenges, from emerging infectious diseases like COVID-19 to the rising global burden of non-communicable diseases, NCD, and this by the World Health Organization, by the way. These challenges call for resilient health system underpinned by scientific evidence, innovation, and a commitment to equitable healthcare access. Conferences like MyMed 2025 provide a unique platform for exploring novel approaches that bridge the gap between medical theory and clinical application. The conference program promises a stimulating experience featuring keynote addresses, thematic panel discussion, and hands-on workshop. These activities will delve into current breakthrough and foster dialogue on critical issues such as digital health, genomics, regenerative medicine, and AI-enabled diagnostics. It is our sincere hope that this interaction will ignite new research ideas, inspire collaborative projects, and empower future leaders in the medical sciences. So I would like to express my deepest appreciation to the dedicated members of the organizing committee led by Prof. Suresh and team, our esteemed sponsors, and all participants who have contributed to the success of MyMed 2025. We are especially indebted to our visionary leader, Yang Berhormat Senator Tan Sri Professor Dr. Haji Hanifah, and Chairman of Masa Group of Companies, whose steadfast support has been instrumental in sustaining this annual international conference. Our heartfelt thanks also go to Dr. Shahril, Group Managing Director, for his unwavering encouragement and guidance. As we convene under the shared mission of advancing global health through research and innovation, I encourage every participant to fully engage, exchange ideas, and embrace the possibilities that emerge from this collective endeavor. Together, let us reaffirm our commitment to excellence and contribute meaningfully to the future of healthcare. Therefore, welcome to MyMed 2025. Let the pursuit of knowledge, innovation, and global impact commence. Thank you very much.
Once again, thank you to Professor Dr. Rusli for his opening speech. So now let us welcome Dr. Saumya to take over and introduce the Year 2 elective research.
Thank you. A very good morning, esteemed guests, respected judges, fellow colleagues, and my dear students. Today it's my pleasure to introduce our year two group of dedicated students who have been taken a significant step in their academic journey by conducting this elective project. Okay, over the past few months, these students have engaged deeply in their chosen areas, demonstrating critical thinking, initiative, and a growing commitment to evidence-based medicine. Today, each of them will be presenting a concise 1-minute pitch videos which are summarizing their work. With utmost enthusiasm, I invite you to listen in, be inspired by their curiosity and commitment, and support them with your insights and feedback. Without further ado, let me welcome the groups and their presentation.
I know, but I cannot do anything. Not.
Apologies for the delay. We are currently experiencing a brief technical difficulty. We kindly ask for your patience while our team resolves the issue. We expect to resume the conference shortly. Thank you for your patience and understanding.
A few minutes later. It's time, Dr. I really just spicy noodles. And then in a way, why? You know how unhealthy it is? You know, I went on street food taking pictures of something in this thing. And you're eating it in the morning. Wow, you put it up, why should I come here? These have yet to be analyzed. They have a lot of bacteria now. Yes, it's the way things you can say that's like actually, I can. Meat chili, powered by capsaicin and garlic, armed with allicin.
Step aside, garlic. Capsaicin burns bacteria to a crisp. I'm the hottest.
Oh, please.
Allicin disrupts bacterial system like an assassin. Science is on my side. At least I got spice. You're just stinky. Better stinky than ineffective. Meanwhile,
Cute little mugs arguing. You think you can stop me? I'm unstoppable. I'm off here multiply. Try and catch me.
no time to argue. I'll take the left. All right, I'll take the right.
Wait, you're not working together. This isn't fair.
Turns out, garlic and chili fight better on their own. Want to know why there's no synergistic effect between capsaicin and allicin? Come to visit us at Group A1 poster at my men. See you
So frustrating. What want to do? I thought I finished over last night.
You got the last class.
Just let me.
Oh, what's wrong with you?
Oh my god, I'm bleeding right now. I'm on my period.
Just a period. What's wrong?
It's just a period. It's just a period. You are lucky because you have uterus shedding in you. Okay? Oh, it's a man. Doesn't know what food is going through.
What do you
Bro, this is a very good time, bro. We are still having. I think now is a good time for this. Just take it, bro. Good luck.
Let's see.
Oh, you take it. You can't even eat it.
Why can't I eat it?
You're on your period.
Oh my god, I'm so done with it. A journey soon begins, its surprise reflected in another's eyes. When what you see is what you lack, a quick understanding will change you back.
What is this? Waste of time.
You know what? Let's just finish it, okay?
Guys, do you feel the earthquake? The flush shaking? You guys feel anything? Why is my stomach so pain?
Oh my god, that was the best meeting in my life though. Oh, this is not mine. Is that black? I look good.
What happened? Why am I coughing?
What do we do now? I don't know what to do now.
But today we just pretend to be each other.
Bro, it's not that simple. I haven't even gotten a period before.
Don't worry, I got you.
Okay.
Yes? You got it? And
Huh?
I was supposed to come back here after it. I thought we need to relax space for group meetings. No, it's okay.
Hi, ever wondered how healthy our little superheroes in orphanages are? Well, we did too. So, we went to find out. We measured their height, their weight, their arms and head circumference, and yes, we did scientifically grab a measuring tape around the tiny bicep.
Bayar masuk Dewi. Ini, お前はもう死んでいる。
We also asked them some friendly questions through a simple questionnaire because health isn't just about numbers, it's about voices too. where you have to visit our poster booth below.
In a world where thumbs never sleep and TikTok never ends, "63 chosen participants. 32 experimental 31 screen time activated. A 1-week digital detox from 8 hours gradually to 3. Will they survive? Coming soon to a thesis defense. Are you ready?
Wow, this seafood is so good. It's time to toss the shells.
One hour later.
Hey, I was just getting comfortable around here.
You only meet the lightning, but no. Only miss the sun when it starts to snow. Only
Sugar, spice, and everything nice. These were the ingredients chosen to create the perfect little girl. But Professor Utonium accidentally added an extra ingredient to the concoction: chemical X. Thus, the Powerpuff Girls were born! Using their ultra superpowers, Blossom, Bubbles, and Buttercup have dedicated their lives to fighting crime and the forces of evil! is PCOS? PCOS? Oh my god.
PCOS, new phone model? Close, but not really. PCOS stands for polycystic ovary syndrome, and no, it doesn't come with Bluetooth.
Hi, we are year 2 medical student from group B1. Do you know about PCOS? Because we are on a mission to find out how much do university students know about PCOS.
So we hit campuses all over Klang Valley with one goal: find out what students know or don't.
PCOS? Is it about sugar level?
It's Aviator?
PCOS? PCOS. Is it a programming code? Yeah!
What do students actually know? What are the biggest gaps? How can we break the stigma?
Another infection? Antibiotics help. I worn out, doctor. They don't respond to me anymore.
Yeah, that's right. I'm resistant now. I even got my own resistant gene, my own backup plan, and even my own TikTok account, thanks to all these useless antibiotics. Yeah. Who are you guys?
We're probiotics. We have to protect your gut and bed bugs before they start. Wait. So less antibiotics and more probiotics? Yay! Finally someone gets it.
I hate to help you, microphone.
We're your backup dancer and your cat bouncer. My name is Joanne. My name is Nurul.
Nama saya Amir.
My name is Junior.
You can call me Uncle Mutu.
Yeah, I was at the heart of it, but you know, I don't believe in hospitals. It's going to get
1 eternity later.
Definitely, I have stress. Like, I don't have 3 children, so I have to take them everywhere.
Stop it. Get some help.
I think I'm ancient. Really?
What kind of a lie is permitted?
Of course, I'm to see I literally exercise every day in the morning.
Now, no, but in my heyday, I used to be very active.
I'll tell you, it is Shaitan.
Abang rasa abang tu bagi rokok.
Your prescription. Oh. Yes. This is for your asthma. Oh, I have asthma. Yes. You have asthma.
Every journey begins with fuel, and before meeting Luciano, Zul made sure he was ready, unbothered, focused, a man on a mission, one bite at a time.
I think I feel good.
You look so good.
Breathe in, breathe out. In, breathe out.
Hey, last time.
Hey, did you know there are some vegetables that actually carry bacteria that are resistant to antibiotics?
Wait, what? So you're telling me that my vegetable could be hiding superbugs?
Yes, look at this. These are AMR microbes. They are bacteria that survive even the strongest antibiotics. Don't believe it? Let us show you.
Behind every result was a process. Hours in the lab, countless samples, and a teamwork that brought our research to life. This was more than just data, this was dedication.
So have you seen the bacteria on agar plates? Where antibiotics are overused, especially in hospitals, farms, and even in the treatment of contaminated water, they encourage the bacteria to evolve. Some of them become resistant.
So this resistant microbe can somehow end up on the vegetable, especially if they are exposed to untreated water. So want to know more about NDR? Stay tuned for our presentation.
It's never worse. The symptoms you are experiencing in kids during the onset of a symptom of diabetes. Worry not. There's a way to prevent or to delay the onset of diabetes. Let me walk you through it step by step. Follow me.
Firstly, you need to be physically active. And as for me, I usually go to the gym and target 150 minutes of moderate exercise. Secondly, reduce processed food as it is high in refined sugars and unhealthy fats. Include fruits, vegetables, lean protein, and whole grain in your diet. Furthermore, quit smoking. Smoking increases the risk of type 2 diabetes, and quitting can significantly reduce the risk not just for diabetes but other chronic diseases. Last but not least, limit your alcohol intake. Excessive alcohol consumption may also increase the risk of type 2 diabetes. If you consume alcohol, do so in moderation. Remember, life is better without alcohol.
So that's about it. Remember, folks, each sharing, be your share.
This is Amira. It's week 12 of the semester. She hasn't blinked in 40 minutes. Her only source of vitamin D is the laptop light. Her coping mechanism? Panic.
If I close my eyes, maybe the assignment will distribute itself.
And this is Ali. Same assignments, different nervous systems.
Hey Amira, wanna walk a lab on campus? We have to reset.
Bro, I haven't walked since week 5.
Oops, this is not burnout. This is charcoal. It began with curiosity. It ended with 97 tabs open and emotional damage. Just kidding. They asked the students, all types, all faculties, all states of stress. They ran real stats, got real results. Excel nearly called in for sick.
The data is steady.
Oh, guess moving your body actually does help your brain. I don't know about you, but I definitely want to know what they actually found out. Let's go have a look.
Wondering if one walk a day keeps the breakdown away?
We did daily 6, so your mental health era can begin.
Come find out.
They said med school would be the best years of my life. Saving lives, learning miracles, becoming a legend. Instead, I became a professional rapper. Oh, it's 7:30. I'm so excited to go to today's class. Okay, let me just go and get ready. Oh, the stupid alarm. Oh, it's just 8. Let me just wait for another 10 minutes.
A few moments later.
Oh, okay, the alarm. Oh my god, it's 9:30. It's okay now. I'll just text my friend. Let me sleep again.
What?
Yeah, do you want to have some quick?
Yeah, sure, let's go.
Let's go. Video, you have some quick?
Sure. Oh, wait. Actually, no, it's fine. I already have good food.
Oh, I see. Are we good?
Thank you.
This is so cool.
Yeah, because I'm already prepared.
Oh, well, I'm so nervous.
It's okay, now it's just easy.
Are you okay?
No, I'm so stressed. Nothing is going into my head. When you thought med school was all about saving lives, but now you're just saving yourself from crying in the library.
Thank you, students. Well, those were impressive 1-minute video presentation showcasing your elective projects. We understand that it was not easy to distill all your ideas and passion into just 1 to 2 minutes. And you have done that. You all rose up to the challenge. Once again, thank you all for your efforts and best of luck for your poster presentation tomorrow. Over to them.
Thank you, Dr. Samia. With the opening ceremony marks the official opening of MyMed 2025. We will now begin our first technical session. Please give a warm round of applause for our chairperson for this session, Associate Professor Dr. Shir Zaman Safi, to introduce the keynote speakers.
Good morning, everyone. So it's now time to welcome our first keynote speaker, a distinguished figure in respiratory medicine, a pioneer in both clinical practices and research, and a national icon in pulmonary care, Professor Dr. Haji Abdul Razak. Dr. Razak is consultant chest physician and a professor of medicine at Masa University, Malaysia. He earned his medical degree in University of Malaya and then went on specializing in internal medicine and at Royal Brompton Hospital, London. With over 3 decades of exemplary services in the Ministry of Health, Dr. Razak has not only contributed to the advancement of respiratory healthcare, but has also led the medical team for the Malaysian Hajj mission for 20 consecutive years. So a prolific speaker and a passionate educator, Dr. Razak has delivered over 100 lectures on asthma, tuberculosis, and pulmonary embolism, and has presented and published his work in numerous national and international journals. Today, we are honored to have him share his insights on research and updates on respiratory diseases. Ladies and gentlemen, please join me in giving him a warm welcome to Professor Dr. Haji Abdul Razak.
Thank you, Prof, for your kind words and encouraging me for these talks. I'd like to thank Prof. Suresh for inviting me again this year to talk about AI. I see all the young people here, and I think the AI should be for young people to present, not me. But the thing is, whatever age you are going to, AI is coming to you in different forms. You can never escape AI in any way. And I think we all should be prepared to know something about AI, whatever age you are into. This is my topic. I'll be talking more on respiratory disease, and I'm very happy to see lots of students here know about lung diseases in the future. When I saw you presenting about your research, I just crossed my mind. I was in Geneva last month, and there was a TB conference in Geneva. And you're talking about students involved in TB care in the world. And he said student power is very important for TB control in the whole world. And I just crossed my mind that I should be taking out to do a research next year maybe on students against TB. Because every student play a role for TB control program in the country. And if you all can take part in TB control program, one student, one patient. Malaysia got 26,000 patients with TB. If one student can take care of one patient in that kind of country or state, then the patient will never stop TB treatment. If they're having a personal care by someone who cares for the person. Maybe I can talk to the dean about this thing in the future, because this is what WHO is going towards. One student, one patient for TB control. Because TB control program is not just a KKM program. It is every one of us we are affected by TB. So, Prof. Suresh, maybe next year we can think about this thing. It is not moving. It's not moving. It will be on. Okay, thanks. Still not moving. Not moving. Okay, this is AI. This is the fault of AI. All the technology, but the AI sometimes just give you all the problems in the world. And it's still not moving. Okay, AI is something very interesting. Okay, and then it's really gone involved in every person's life in every aspect. And again, for respiratory medicine, it's got a lot of good things about respiratory medicine and AI, and it's still not moving. So there's a role of AI in every lung disease. If you look at lung diseases in the world, we got COPD, we got asthma, we got lung cancers, we got lung fibrosis, and it's coming soon, I think. So there's AI for everything you can actually think of. Yeah? And now we're talking about AI in diagnostics, AI in treatment, and also AI in future. What's going to happen in the future? Okay, so why do I press? Okay, good. Yeah, this is my topic. I'll be talking more lung diseases for AI. Okay? Look at that figure from WHO. A lot of people actually got COPD, got TB, and also what they call COVID-19. They all die every year of this disease. So what is AI? Once the AI comes to respiratory, diagnosis is very much faster. Number two, decrease patient waiting time. And number three, facilitate medications. Number four, the treatment is still made. Right now, we are treating patients just accurately, by experience. But with the AI, the treatment become more specific for the patient. Okay, let me just give you some example of some diagnosis. X-ray and spirometry for lung disease. You're a year two, I'm sure you've seen spirometry in your practice. And again, AI can be helping you in these many ways. This is Ronjan. Ronjan found the X-ray in 1895. And that hand belongs to the wife, his wife. That's the first X-ray done in the world. And the wife wearing the wedding ring over there. And this is how to do X-ray those days, no? Surprisingly, no one knows that there's radiation. But they just simply do the screening in the open and everything, and people are exposed to radiation. And this is MAPTB. There's the only NGO for TB in the country. Okay? And they started the mobile X-ray before the government started. Very interesting. The government started TB only in 1961. But they started in 1948 when the British were here. And they got a machine for X-ray screening for free. I remember seeing this when in Penang when I was a young boy. So they go all over the skin for TB those days. But now look at this. This KKM bought their own big van and big bus for mobile X-ray. But it was a failure, you know. Very sadly, it was a failure because they put a very big bus, they put a very big machine inside there, and they cannot go to the kampung. The kampung roads are very small, and the big bus just can't go in. So they actually had a bus, one in Sabah and one in Sarawak. Because Sabah, Sarawak, the roads are very bad. People are staying very far deep in the jungle, everything. The bus can't go in. The bus just can't go in. But now with the AI, look at how small the X-ray is. You can just like a Grab driver bringing the food for you, you know. Okay. They can bring the X-ray to your place. No matter where you stay in the world, they can just carry the X-ray to your place, do an X-ray for you. You don't need any big machine. You just need your laptop over there. You do an X-ray, put in, they call it CAD, Computer Aided Diagnostics. So with a small portable X-ray in your backpack and a small laptop, you can just do an X-ray, and the radiologist will be staying miles away looking at the X-ray you took thousands of miles away. This is AI. It's already here. It's already here. Malaysia, not yet. But all over the world, they're already using this for screening for TB anywhere in the world, you know, where the patient can't come to you. And these are June 2025. WHO said that they already approved 6 of the studies for AI in X-rays and CAD. CAD means computer aided diagnostics. It's coming, you know, it's already coming, it's already in the world, but not in Malaysia. We hope the young people like you here will take it out in the future. Again, for HRCT, I'm sorry, HRCT is a technical word. HRCT stands for high resolution CT, just like a phone. Some of your phones got 25 or whatever it is, resolutions. You can see better pictures, you can take better pictures and everything, and you can see clearly. So HRCT is just a CT scan. But a scan, we're cutting very small slices of your lungs. Normal scan cut 1 cm, 1 cm, 1 cm. HRCT cuts 1 mm of your lung each time you take a picture of your lungs. So very small cutting of your lungs, you can see everything very clearly, and they are good for diagnosis of your ILD, cancer, and also for COVID. Yeah? What does it do? So again, it is for lung diseases. Okay? And very fast, very accurate, and very clear kind of pictures you can get. And they get clear images and decrease wasting time. They can do things very fast. This is one example. This is 2020 when COVID was there. When there was COVID in the world, thousands of people, millions died. You know? Millions died of COVID in the world. Why? Because they can't diagnose COVID early. But with the AI, look at this. The AI can get very clear pictures of your lungs. The first panel A is COVID-19. The panel B is pneumonia.
and the panel C is no infection at all. So with the AI and HRCP, they can diagnose your lung disease within a few seconds. You don't have to train in your eyes. You don't need specialists. You need specialists only when the things are a bit confusing. So AI came into COVID time and they can diagnose COVID very fast and they can treat the patient effectively in a very good place for recovery. Yeah? So again, during monitoring, accurately detect COVID-19 very fast and accurately. One of the examples of COVID-19 AI, they can identify COVID very fast. COVID is already gone, but it's going to come back again. I was not feeling well the past few days. Now I was having flu and headache and really severe body ache. I got worried because COVID is coming back. And I took my COVID test. Negative. My HOD is there. It is negative anyway, yeah? But COVID is coming back, okay? So just be careful. If you're not feeling well, check your COVID and just isolate yourself. And again, they can try it. Once you can do AI, you can see a patient with COVID, you can send them away or treat them effectively. And again, drugs. COVID is one disease when it came to the world, we don't know how to treat COVID-19. We don't know. You're trying every drugs in the world, one by one, by trial and by error. And with AI, they can do things very fast. And then you find the patient actually can survive longer and then they can have less mortality. And vaccine, this is the only disease in the world they found a vaccine so fast. I'm a TB specialist. The only one vaccine we have is BCG for TB. And it's 100 over years old. Up till now, we can't find any new vaccine for TB. But COVID they found so fast. And maybe with the AI coming in the future, we can find vaccine for every disease, hopefully, inshallah. Okay? And again, we can demand, we can know how many places are empty in the ward, how many patients in the ward for COVID-19, what activity we can do. We can plan everything nicely and also research about social activities. Okay? So it's a role for everything about this AI and COVID-19. This is another example. Lung fibrosis are due to many causes. I'm sorry, it is a bit technical. When you say lung fibrosis, lungs are shrunken. There are many causes for that. Drug cause, infection cause, or whatever causes. But with the AI, they can see everything so nicely. I don't know if there's a light there. Yeah, the light cannot go there because LCD projector. So we can see different types of changes in the HRCT. But with the AI, they can tell you within a few seconds what's wrong with your lungs. And they found that this is really fantastic. They find it reliable, effective, and very fast for diagnosis for AI in HRCT. The next thing I'll give an example is spirometry. Again, I'm sure you've seen spirometry in year 2 when you go for your posting. And spirometry is very important for diagnosis. This person, Giovanni, was the first one to study about lung physiology in 1681, long ago. And then the first person who found spirometry is Hutchinson. He found Hutchinson in 1846. And look at what he said. He found a machine where you can do a lung function test and see how good your lung function is. And then the insurance company get benefit and they can do lots of things. But he was actually very depressed because no one believed him. No one took the machine and all his money was gone. He became depressed. He committed suicide. Very sad. He committed suicide. Only after he died, they found that this is a fantastic machine to look at the lung function. And look at the machine those days. Look at the ECG was found only after 60 years. And every clinic got ECG machine. You go to any GP clinic, probably your son's clinic, I'm sure will give you an ECG machine, but no spirometry. No spirometry. So look at that, and so it's very sad. And look at the size of the machine. This is Hutchinson, and there's a machine, the size. But with technology, the size became small. When I became a specialist, it was this size. These are the machine I was using when I became a young specialist about 30 years ago. Still big, as big as this. But now you don't have to carry any machine. You just get your phone. Just bring your phone, your iPhone, put down the software, and then get the plug, blow into the mouthpiece, and you got your reading for your spirometry. That is technology, okay? That's AI. So we are all moving towards something much more simple, much more accurate, and much more portable for you can do anywhere in your house. And again, for some doctors who are a bit, one thing seems a bit easy. I always tell my students, you're year 3, year 4, year 5, you're paka like me, only 2 lung sounds you must remember. One is called crepitations, and the other one is called wheezing. Only 2 sounds. For lungs, only 2 sounds, you know. Even if you become a consultant like me, only 2 sounds. So crepitations and wheezing. But it's until year 5, many students can't differentiate wheezing and crepitation. I'm not joking. I'm not joking. So, but now they got computers. They got AI. They can give you the sound. So you can learn from these computers, learn from these particular stethoscopes, how they make these 2 sounds. Okay, again, it makes you lazy. Okay, but the thing is, this is how you learn nowadays. Nowadays, we learn a lot by technology, and we use less of the thing. A bit too sad. Okay, a bit too sad. Okay, again, this is algorithm. Again, cough is interesting. Now they can do a cough analysis. They can tell you whether you got asthma, TB, or even what you call COVID-19. What they do? They select thousands of sound of cough, 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 cough. Everyone, TB flu come and cough. COVID come and cough. You know what they call cancer come and cough. They collect all those sounds and the computer analyzes them by deep learning, and then they classify into either it's healthy cough, a TB cough, or other disease. Just a cough analysis. You know? These are things you all can actually look into. You know? You all are younger people here. Look at this kind of project in the future, maybe next year, or year to come. You know? Do cough analysis, everyone coughing in the university. And then go to the screen and see whether people are coughing the normal cough, asthmatic cough, or TB cough. Why is it important? No sputum. You don't check the sputum for TB or COVID. And again, no swab, no blood test, and works in any smartphone if you got the things inside the software. And again, screening in a large population. You can screen thousands of people for cough by just bringing your phone for analysis. And ideally, it's good for your telemedicine rural setting. And again, you can use AI in many things. Okay? For asthma, it's very, very interesting. Diagnosis is very fast. You can tell what type of asthma the patient is, allergic or non-allergic asthma. And again, whenever you see a patient in the clinic or in the ward, they have all the records. The records, we can see, oh, this person can have asthma attack very, very fast. So to be careful. Or that person has asthma well controlled. I don't have to worry about him. So you can tell you how bad the asthma is. You can monitor these patients and also give them good drug for this asthma. Okay? This is interesting again. Okay? Look at the graph. 3 colors. The blue color, red color, and your brown color. Again, we can do spirometry anywhere. You don't see doctors anymore. You download the app into your phone, you do spirometry every time. You got COPD, asthma, whatever it is, do spirometry every time. They can monitor your lung function from miles away. And from there, they can tell you your lungs are getting better or they're getting worse. So they can monitor you very well. So look at the graph. So the computer will monitor your lung function test, and they can tell the doctor miles away. They say, oh, the doctor says, good, your lung function is improving. So continue the same medication. Or your lung function getting worse, it's becoming brown color or the red color over there, come and see me very fast. So this is technology again, AI. Okay? They can come and see one and treat them effectively. Okay? Again, this is something I don't want to tell all of you. You all are wearing watches, which is a smart watch. I'm an old man. Mine is all mechanical watch. No smart watch. Okay? But many young people, almost all of you are wearing a smart watch. You can check your heart rate, check oxygen, check your sleeping pattern, check what's happening to your body by the second. That again is AI. Okay? These are some examples. I wouldn't go through here. Monitor your heart rate, oxygen, everything, your order, your sleeping pattern. And then they can also do your lung function at home. Okay, they can detect your COPD asthma very well. And then anything goes wrong with your spirometry or what, you just tell Dr. Smiles away. Yeah. Now these are the other things in the future you can look to. Okay. Okay. Last few slides here. When I became a doctor and a specialist in the early 80s, any person do a chest X-ray, and then they found something in your lung, and they think, oh, Razak, this one looks like a cancer to me. How diagnose cancer? They have a big surgery done for your lungs, remove the whole thing, and then they will take away the cancer and check for pathology. This is about 40, 50 years ago. It happened. Okay? Any person got a 50 cents coin of mass in your lung, surgery. No other questions. It may be cancer, may not be cancer. We know so sure. But that's how they go to. Then the doctor became cleverer. They got smaller scars. They go to one specific area to give it a lung and they can check for it. And they get much more cleverer, they go to scope. So they can do this video scope. One scope is to look at the cancer, one more probe to go and fold the cancer cells, and sorry, the lung, and the other one is for you to cut the lung cells. So they're getting smaller and smaller and smaller. But it did not stop there. They got a thing called bronchoscopic robotic navigation. This is something new again now. So they just like a GPS. I came from KL just now to SPC. And I was looking which road is the best road for me to come here without any traffic jam. That was the base. And base told me come by this way, that way, turn left, turn right, and everything. I came here by 40 minutes. So this is what the same thing they're doing right now for lung cancer. You take a scan for your lungs, you put in the computer software, and the computer will tell you where to go and do the scope and where the cancer is and where to take a biopsy. This is technology. This technology. We have navigation biopsy in Malaysia, but not robotic. Not robotic yet. So the navigation biopsy is done in 3 or 4 places in Malaysia right now, where they do a scan for you, you put in the computer software, and the computer will tell you where to go for the biopsy. And it's very accurate. It's very accurate. You don't account your body at all, you know. And you can analyze very well, and you identify where the mass is, and you can go by the safest and fastest way, navigation by real time, and continuous positioning, and again, the target is never missed. It's never missed. This example. So it's all navigation and it's all robotic, and you know where to get the biopsy for one cancer. Good benefits, the patient benefits. There's no big cut in the chest at all. No admission sometimes. And then there's no complication at all by cutting the patient up to get diagnosis. It's very easy. And this is now robotic. Not in Malaysia yet, but in Western countries, they already use robotic for your diagnosis. So things are changing. Things are changing for lots of things in life by using AI and also by using all these new technology. Again, once diagnosed the patient with lung cancer treatment now is fantastic. You know. Again, when I was a young specialist, there was only chemotherapy for lung cancer. Very simple. VAC and VAC. There are 3 types of cancer drugs for lung cancer. That's all, 3 types of chemotherapy for lung cancer. But look at this. There are so many cancer drugs nowadays available. So many, you know. And there are so many studies that say this is good, that is good, this is good. Different cancer, different kind of treatment. But laymen like you and I, without thinking properly, it's difficult to get a drug. But somebody with the AI, they can choose carefully and then choose which drug is good for which patient. So it's more precise, more accurate, and more effective. But more expensive here. It's a bit more expensive. So again, they can profile the patient's cancer very well. And then they can choose which drugs are good for you, and they can go and target the drug therapy very carefully, and they can also cross-check the trials, and they can also know the response of the patient's cancer. So things are changing here. And for old people like me, I cannot actually catch up with these things. When I was young, I was treating lung cancer in Penang. Penang, there's only one oncologist for the whole hospital. He can't handle lung cancer. Razak, you take care of lung cancer. I took care of lung cancer when I was in Penang DH. When I came to KL, so many drugs came for lung cancer. I don't know what to choose. I just gave up. But that's where AI came in. AI can help you decide which drug is good for which patient. So it makes your life easy in many ways. And then I also make you lazy sometimes. And again, there are many things about genomics, and then also things about gene therapy, and also about these are what we call support system here. So these are all coming in the future. My all slides. I mean, AI will never end. AI will never end. So people like me must catch up with AI. People like you can learn AI for the meaning itself. So it's something good that we all have to learn together here. So I always believe that young people like you must teach old people like me about AI in the future. So I thank you for coming here this morning. I wish you all the best, and thank you, my good solution.
Hello. Thank you, Prof. Razak, for your inspiring and enriching talk. Now the floor is open for Q&A session from the audience.
Thank you, Tatu, for the talk. I just asking on behalf of the student. You mentioned just now about the initiative by WHO.
Correct.
How our students can enroll into that program to assist in that.
To tell you what, the thing is, WHO started this in 2019 in the whole world, where the students empower the TB control program. So I can actually get one of them to come and talk to all the students, and definitely will talk to the dean, and make sure that MASA takes active role in this students, what do you call the student power about TB control. I'll get back to you.
Thank you. Prof, can you stay for a while to give you a token of appreciation? Prof. Rosli, can you please come on the stage?
Once again, thank you to Professor Datuk Dr. Haji Abdul Razak. So now we would like to invite Associate Professor Dr. Surah to introduce the second keynote speaker. Please welcome Dr. Surah.
Thank you. Good morning, everyone. So the second keynote speaker, it's my immense pleasure to introduce Associate Professor Dr. Mahendran Shekhar, who is currently working as an Associate Professor at the School of Pharmacy, Monash University, Malaysia. So with extensive experience in academia and research, Dr. Mahendran is a very important member. He's contributed towards the drug discovery, natural products development, and green technology innovations. So Dr. Mahendran has received numerous national and international accolades for his outstanding work in academic research and innovation. So currently, he remains a key figure in pharmaceutical research, shaping the future of natural product-based discovery and drug development. So without further delay, so I would like to welcome Dr. Mahendran Shekhar.
Yeah, good morning, everyone. Thank you very much for the
kind introduction. Is it audible? Hello. Yeah. Fine. Okay. Thank you very much once again for the kind introduction, and I take this opportunity to thank the organizing committee for inviting me for this MyMed 2025 conference. So the topic I was selected for today's presentation is innovative strategies in drug discovery and development, harnessing the power of natural products. So why I particularly chosen this topic is because as I came to know, most of participants are from medical background. So you know the drug discovery process. So to bring any new drug candidate to the market, it takes 10 to 15 years of time minimum. So start from the disease target identification, then followed by biomarker identification and also validation process. Then it moves on to the lead molecule identification. Then later slowly we move on into the preclinical trials, which including in vitro studies. We usually use the chemical methods and the cell lines to test any drug molecules to find the biological activities. And after that, we move on to the in vivo studies where we use the animal models to test any drug candidate or drug molecules, whether it shows any potential activity against disorders. Then only we move on to the clinical trials, which is phase 1, phase 2, and phase 3. Then only the drug candidate may be available in the market. Then post-marketing survey also there. So this whole process, it takes minimum 10 to 15 years of time. So due to now the technology developed and AI tools are available for us to minimize this duration, so that maybe now we can at least bring the drug candidate in 3 to 5 years of time with available technology and innovation methods. And why I particularly choose a natural products? As you know, the currently available drugs in the market, almost 40% of the drugs which are derived from natural products. Not originally obtained from the natural products, it is derived from natural products. Means the original skeleton, the structure of the molecule from the natural product. Then later, the synthetic means the medicinal chemist, they found they did the structural modification of that skeleton and they come up with a new molecule to treat against various disorders. So that is the reason I choose natural products, and my background is I'm doing more research on drug discovery and development related to natural products as well. Yeah, and most of them are might be thinking natural products means it is mainly from the medicinal plants. That is not correct. Natural products means it obtained from the natural source, which including plants, microorganisms, also from higher order animals. As you know, penicillin, where it is obtained from Penicillium chrysogenum, that is from microorganism. And also insulin, you know, that is from animals. So these all comes under natural products, not only from the medicinal plants. And discovering a new candidate from the natural source is time-consuming process. As I mentioned, it takes 10 to 15 years of time to bring any new drug candidate to treat against disorders. And it is very expensive as well. As you know, you have to spend millions and millions of ringgit or US dollars to do all the preclinical and clinical trials. And due to this reason, many scientists, they usually select the synthetic method to synthesis some small molecules or the molecules which can be used for the treat against some disorders. But however, if you look at the natural world, natural compounds offer structurally diverse and biologically active molecules. And they serve as inspiration or direct sources for numerous clinically approved drugs. That's why, as I mentioned, almost 30 to 40% of the drugs which are currently available in the market that are originally the skeleton obtained from the natural source. So naturally isolated compounds remain at the forefront of modern therapies for cancer treatment and also infections, inflammation, and metabolic disorders treatment. So our researchers usually they put a lot of effort actually to bring the new drug candidate to treat against disorders. and many institutions, including Masa University and many universities in Malaysia, the government agencies, and also Ministry of Health and Ministry of Higher Education. Usually they give a lot of fund actually to do research on natural products, especially for drug discovery and development. So now this slide onwards, what I'm going to cover, what is the traditional research of doing by researchers in Malaysia and all over the world on natural products. And later I will tell about the innovative technologies, how we can minimize the time to bring the molecule into the market. Okay. So usually any natural product researchers, usually they select the medicinal plant based on the ethnomedical information or traditional users. Usually they get information from the traditional practitioners. They ask what is this plant, what for it is used for. So based on that, they usually select the plant. So after the selection of plant, what they do? They collect the medicinal plant and they go for authentication, because authentication is very, very important. Maybe the medicinal, the practitioner, they might be telling different plant, but you might be collected the different one. So to avoid that reason, you have to authenticate with the help of botanist. So you need to identify and confirm whether you collected the right species for your research. Then after the authentication process, we go for drying the plant material and grinding into small particles and do for the extraction. So extraction, we usually select some solvents like polar solvents to extract all the phytoconstants which are present in the plant material. Because you know, plant material containing both primary and secondary metabolites. And mostly the secondary metabolites are biologically active when compared to the primary metabolites. But as a researcher, our responsible is to isolate all the phytoconstants which are present in the medicinal plants. Then after the extraction process, so we usually go for the isolation. So where we use the column chromatographic method, where we isolate the single individual compounds, which is responsible for the biology. Because as you know, medicinal plant means it is containing hundreds and hundreds of molecules. Later, when you do the biological testing, you cannot directly prove that which molecule is responsible for that pharmacological action, because that is containing hundreds of molecules. So as a researcher in my research lab, we are doing work on isolated pure compounds, which is having the structurally identified chemical molecule. Okay. Then after the isolation and purification, we do the characterization to identify the chemical structure. We have the NMR, mass spectroscopy, FTIR spectroscopy to determine the chemical structure of the molecule. Then followed by, we pass the molecule for the in vitro and in vivo studies, where the pharmacological studies will be carried out. Okay. So as you know, discovering a new drug is becoming more complex and time consuming. As I mentioned, starts from the drug discovery process. Here I mentioned it takes minimum 10 to 15 years of time. And if you follow the steps what I have been mentioned, that is what the most of the people are doing all over the world. They collect the medicinal plant, they do the extraction, they isolate some phytoconstituents, they do in vitro or in vivo studies. But later, even sometimes they cannot go for in vitro or in vivo studies, because the amount of phytoconstituents which are present in the medicinal plant, which may be very low in quantity. You may get 10 milligram. If you take 1 kilogram plant material, you may get 10 milligram of that compound. That may be enough only for you to identify the phytoconstituents, but you cannot carry out the in vitro or in vivo studies. Okay. So we need to optimize all these procedures to bring to minimize the time duration of this drug discovery and development process. So here I'm going to tell about what are the challenges that we are facing in the natural products isolation and how we can overcome by using the latest technology which are available right now. Okay. So the main problem with the natural product research is quantity, because if you, as I mentioned, if you collect 1 kilogram or 2 kilogram of plant material, you may get only 10 milligram of that phytoconstituents, which may be responsible for the pharmacological action. But with that 10 milligram, whether you carry out any in vitro or in vivo studies, pharmacological studies, because you need to give dose to the animals and test the molecules against disorder, right? So definitely it is not possible. So my suggestion is we have to synthesize that particular molecule, because we already currently having so many molecules already isolated from the medicinal plant which are available in the library, chemical library. It is not necessary that you need to select again a new plant and isolate a new molecule. Then finally, because of quantity, you cannot pursue further for the in vitro or in vivo studies. To avoid all this, once you directly choose the chemically isolated compound from the natural product, and you can get the help from the medicinal chemist who can do the synthesis of that particular molecule in high quantity. So if you get 1 gram or 2 gram of synthesizing that particular compound, then directly you can move on to the pharmacological studies, where you can find whether your compound is biologically active or not. So another technique to improve natural product compound development may involve the creation of natural product and natural product like libraries that combine the features of natural products with the combinatorial chemistry. It is like a computer-aided drug design method. So maybe, for example, if you know the chemical structure of one molecule, now the AI technology, through that, we have the software where you can make thousands of new molecules with one single molecule. And previously, I think 10, 15 years before and all, even during my PhD time, I completed my PhD in 2010. So 15 years before, the people who work with me, so they usually do synthesis of 50s and hundreds of compounds actually, without any background work. Just simply they modify the chemical structure. But now currently we have the softwares where you can make thousands of molecules virtually. So that virtually, whatever the compounds that you make, you can also check the biological activity virtually with prediction before you do the in vitro or in vivo studies. Because for example, if you are having thousands of molecules, you cannot test thousands of molecules. That means you may need so many years, and you need lots of money fund as well to carry out all those research. So to avoid that reason, we have the AI tools nowadays where you can predict the biological activity. Even it is not necessary that you have to go for the software which is paid version. You can go for the open source version. So that is more than sufficient for the undergraduate and postgraduate level students. So you can predict the biological activity without using any chemicals, without using any animal models. You can predict. So prediction, as you know, prediction is just a prediction only. We cannot say 100% that may correlate well with the in vitro or in vivo studies. But so far, whatever the studies carried out by using the models, as I mentioned, the AI tools, the results is more or less almost 70 to 80%. It is well correlated with in vitro and in vivo studies. So why not we can use those technology to predict the biological activity before you perform in vitro or in vivo studies, to avoid all these hurdles in the natural product research. And as you know, this chemical structure, morphine and codeine, are given as an example. So if you look at the chemical structure of morphine and codeine, so what is the difference? There is a difference in the hydroxyl group and methoxy group, OCH3 group, right? But here, if you look at the biological action, morphine is 10% more potent analgesic when compared to codeine. But if you look at the chemical changes, just only one functional group, that is hydroxyl group, is changed to methoxy group with that small minor changes. But if you look at the biological activity, huge difference. So that is the reason, if you know the chemical structure from natural product, you do the visual screening and come up with the thousands of molecules with modification, then you can do the biological testing with visually. And another example, levodopa and dextrodopa. So at least morphine and codeine, you can look at the structural difference, hydroxyl group and methoxy group. Levodopa is a well-known drug for the treatment of Parkinson's disorder. But dextrodopa is inactive against Parkinson's disorder. But if you look at the chemical structure, both are similar. Only the three-dimensional, the stereochemical, the shape, that is different. So this also play a major role in the biological action. So as MBBS students, you know how the chemical structure is related directly to the pharmacological action. Okay, so that is what in our laboratory we are doing more related to finding new molecules to treat against disorder. And another challenges in the drug discovery process, the medicinal plants has traditionally been time-consuming method. As I mentioned, it is you need to collect the medicinal plant, then you need to do the extraction, isolation. It takes a lot of time. Isolating compound from one plant extract, it takes 3 to 6 months of time. Even during my PhD time, I faced so many things, so such kind of hurdles. It took almost 1 to 1.5 years to complete all the extraction isolation process. But nowadays we have the new techniques, the instruments, which is attached with the machine learning and AI technology. So where you can do the isolation of those compounds by with the machine. I think with the chemical libraries, even you can predict the compound as well before you isolating from that by using flash column chromatographic method. So there are so many innovative strategies and technologies are available nowadays for the researchers who can carry out work related to natural products. So another big challenge is the in vitro screening, in vitro or in vivo biological screening. So challenges in bioassay screening remain an important issue in the future drug discovery from natural products. And that is the reason I told you the in silico studies. So where you can use this computer-aided drug design, you can predict the biological activity without doing any in vitro or in vivo studies, without using any chemicals or animal models, you can use it. So here the use the drug ability laws like Lipinski rule of 5. As you know, as per the Lipinski rule of 5, the rule number 1 is the molecule is supposed to be less than, the molecular weight is supposed to be less than 500 should be. Then the second rule is the log P value, the partition coefficient value. So the ratio between the lipophilicity and hydrophilicity. As a medical student, I think you all know the importance of lipophilicity and hydrophilicity. Okay. So any drug molecule or drug candidate must be soluble in the bloodstream. Then only you can get some pharmacological action. If there is not dissolved in the bloodstream, no pharmacological action. So hydrophilicity is very important for any drug molecule. The second thing is lipophilicity. So why lipophilicity is very important? Because lipophilicity in our body we have so many lipid barriers or fat barriers. The drug must pass through that barriers like blood-brain barrier. So lipophilicity also very important. So both lipophilicity and hydrophilicity is important. Okay, that ratio is the partition coefficient value, which is the log P value is supposed to be less than 5. And apart from that, the hydrogen bonding donors, hydrogen bonding acceptors, and rotatable bonds. So this all comes under the Lipinski rule of 5. So that all we can predict before you do the biological activity of in vitro or in vivo studies. But here the in silico models, what we will do, once you know the chemical structure, you can include that chemical structure into the software. So where you can predict the binding efficiency of the target proteins. So you can target the proteins which is responsible for that particular disease. So you can directly link with the compound whether it is having the binding efficiency with that particular protein target or not. If it is really binding, then binding efficiency is there, then for sure there will be a higher chance when later when you conduct in vitro or in vivo studies, you can get similar kind of results. So the correlation will be there. Okay, so there are many softwares are available nowadays, okay, which can be used to predict the biological activities and proper estimation of drug likeness features and profiling of potential toxicity. Even you can predict the toxicity without doing animal models. You all might be thinking without doing animal models, very difficult to predict. Based on the chemical structure, this software will predict whether that can produce any toxic effect to the humans or maybe animals. So you can identify, you can predict earlier. No need to go for any chemical methods or in vivo studies. It is necessary, but later part you can do it. Directly if you do it or in vivo or maybe in vitro studies to predict all these, you need to spend a lot of money. So instead of that, you can predict earlier by using this AI tool. So in silico studies of natural products strengthen the drug development platform. And another important thing is metabolomics. As you know, the importance of metabolites. Okay, so how we can predict the metabolites in the natural products? So natural product extract is containing so many phytoconstants as I mentioned, but usually the researcher, they do the qualitative phytochemical analysis to predict in general what are the phytoconstants are present. But if you use the instrument which is called the GCMS, so where you can get the molecular weight of all the phytoconstants which are present in that particular extract or natural source. So from that, based on the database library, you can predict what are the constituents or drug molecules which are present already in that. From that, you can have a kind of assumption what molecule may be responsible for that biological activity. Okay, so that is the metabolomics. So you can identify the new targets. You can also elucidate the mechanism of action of new drugs and develop the safety and efficacy profile of new drugs. And also you can also find the ADME properties like pharmacokinetics properties that also can be carried out based on the metabolomics profiling. And more importantly, the toxicity is a leading cause of attrition at all stages of drug development process, because any drug development, usually the researcher, they do all the research, then finally they do toxicity related things. But by the time there are many drug molecules or drug candidate failed in the toxicity study that might be having good efficacy, potential efficacy to treat against disorder, but the toxicity might be there. So to avoid that reason, we can use all the latest tools which are available to predict the toxicity as well as the efficacy of the drug candidate. And we have other instruments like LC-NMR, LC-NMR-MS, which is the latest instrument where you can do the separation of the constituents or the drug candidate which are present in the natural source. And at the same time, you can also identify the chemical structure also. What maybe the constituents are present. While doing the separation itself, we can identify. So that is the latest thing. Otherwise, you have to spend at least 6 months to 1 year of time to complete work. Now with all this machine learning and AI tools, you can predict the compounds present in the plant extract or maybe any natural source within 1 or 2 months of time. So you can minimize the time duration. Okay. So you can detect the bulk drug impurities during drug stability test. That also can be done by using this particular instrument. So my suggestion is actually in my laboratory, I'm not doing work on plant extract. I'm doing work on the pure isolated compound where that can be bring later into the drug discovery and development process, because extract means which is containing thousands of molecules. You cannot say this is because of this compound, this is responsible for this pharmacological action like that. So target major compounds. So there are so many major compounds which are already available in the natural products library. So as a young researchers, you can choose this kind of molecule, and you can use the in silico AI tools where you can predict the biological activity, and you can move on to the drug discovery process. So these are some of the molecules which actually I'm not working on these molecules. So the molecule which I'm working on, I didn't include in this slide because those are a little bit novel compounds, because we do not want to show to everyone. So here I given some general compounds which are already available, and many researchers are working on all these compounds. Okay. And apart from that, the other disadvantage of the natural product is the macro particle, the size of the natural products. So due to that reason, these are the disadvantages. The first one is in vivo instability. For example, if anyone is working on natural product extract, if they do pharmacological activity with animal models today, similarly, if they collect the medicinal plant again after 6 months and they do the in vivo pharmacological studies, the activity will be totally sometimes different as well because of the so many factors. Because today, whatever you collect, the medicinal plant, which containing different constituents, next time when you collect, the proportion of the phytoconstituents may be different. So due to that reason, the pharmacological activity will be different. So that is why in vivo instability will be there in the natural products most of the time. So that is the reason you have to target only the pure isolated compounds rather than the plant extract. And low bioavailability, the amount of drug which enter into the systemic circulation, so that also very low. That is also one of the major disadvantages of the plant material or maybe the natural products. And poor solubility, as I mentioned, lipophilicity and hydrophilicity is very important for any drug candidate. And poor absorption in the body, and problems with the target specific delivery. Sometimes if you target brain, but it won't reach it to the brain due to the macro, the size of the natural product. So how we can avoid these disadvantages? So there we have a nanomedicine by using nanotechnology where we can convert those compounds into nanoparticles. So we can prepare either metal-based or non-metal-based nanoparticles. So here this is inorganic nanoparticles, which is non-metallic origin. So where we can use zinc, silica, calcium, zirconium. And my suggestion is mostly this is more better when compared to other inorganic nanoparticles, iron oxide nanoparticles and silica nanoparticles. Then apart from that, metal-based nanoparticles where we can use metals like platinum, copper, palladium, nickel, cobalt, silver, gold. And among these silver nanoparticles are very cheap and which can be used to convert the drug molecule, the molecule into a nanoparticles. Okay. So my the take-home message from my presentation is, so natural products, have provided numerous clinically used medicines. As I mentioned, already 30 to 40% of the drug molecules are already available in the market. So even with all these challenges we are facing, the drug discovery natural products isolated from medicinal plants can be predicted to remain an essential component to such new medicines. Even though there are many drug molecules are available, even though there are many hurdles are in the natural product, but still we have, that is a major source to find the new drug candidate to treat against all the emerging disorders. With advancing technology, as I mentioned, nowadays there are so many innovative technologies and AI tools to predict the biological activity, and machine learning with attached with some instruments, major instruments, where you can predict the molecule, where you can predict the toxicity related profile. So that all increasingly being employed to isolate natural molecules and enabling efficient high throughput screening. So as you are undergraduate students, some may be postgraduate students. So this all you have to keep in mind when later when you do any kind of research related to drug discovery and development process. Okay, so natural products, back to the future. I think now already there are many researchers and from many universities are working on natural products and having a bright future where we can bring the new drug candidate to treat against all the emerging disorders. Yeah, with that, yeah, thank you very much. And if you have any questions, feel free to ask. I'm happy to answer.
Thank you, Dr. Mahendran, for the excellent talk. So the floor is open for Q&A. So any questions, please, you can ask Dr. Mahendran.
So first of all, excellent talk, Prof. Mahendran, and thanks for joining us today for the keynote. So it was excellent presentation covering from the natural products, which is, there is a saying that there is no plant is not having any medicinal property. So actually the one I like this back to the future. So actually we are known for having the drugs from the natural source, and we are so many synthesizing. There is no more accidental discovery like penicillin anymore. So we have to go this way, and excellent presentation that leads optimization from the natural products and standardizing. So my question is, there are so many studies are going. I think every day thousands or hundreds of papers are publishing the natural products and its activity at the early stages, and it is not going to the further secondary and tertiary level to find the exact molecule and which is having a therapy. So what could be the reason?
Yeah, the reason, that's why now previously there was not much technology developed things where you can move forward to the drug discovery and development process. Due to that reason, people usually they spend a lot of time for the isolation and identification, then later they do the in vitro or in vivo studies. But nowadays, as I mentioned, the tools are developed. Now we can predict the biological activities little bit earlier when compared to the olden days, how we need to go for all the laboratory models and everything. So through that, I think now the things are moving faster. I think in future, definitely you can expect more related to the drug candidates in the market, which are related to natural products. So that is what's going to happen in the future, because with this present the thing with AI tools and everything, we can bring so many new molecules. Okay, and maybe in the market also, as I mentioned, you might be seeing many drug candidates. You might be thinking that is originally maybe synthesized. It is synthesized, but the original, the drug skeleton may be obtained from the natural source only. That skeleton, they find how to synthesize that molecule as well. Yeah.
Thank you, Prof. So one more question, Prof. I think once you found potential leads and optimization for the drug target, the target, and it is working fine in vitro and in vivo also fine. It's good. Okay. So possibly the same lead could have multiple targets. May not be positive, could be negative. There is any way we can do clearance of the which is not having any effects on other molecules before we proceed further?
Yeah, that's right. The drug target sometimes natural products. That is one of the disadvantages as well. You cannot target the particular organ for sometimes the disorder. So as I mentioned, nowadays the nanomedicines are available, encapsulation. So those kind of techniques that can be used to avoid all those targeting the other portion. Maybe our target is brain, for example, it's supposed to cross the blood-brain barrier. So apart from that, maybe you can avoid it based on by using some new techniques like nanomedicine or nanotechnology encapsulation technique. And there are plenty of drug delivery systems also nowadays. We are developing. Even I saw today's video also. I think some students they worked on capsaicin, right? That is a chronic pain that is used for treatment of chronic pain. And one of my PhD students, even currently we are working on microneedle patch actually by using capsaicin. So to avoid the irritations during the injection or something. So we are more working on drug delivery related things also, which is towards formulation and development. So where you can avoid all these kind of disadvantages as Professor H just now mentioned. Okay.
Assalamu alaikum. I am Alia Nasir. A very interesting presentation related to utilization of natural resources. We have learned about the Eastern medicine and homeopathy. So how you foresee the integration of homeopathy and allopathy utilizing this products?
Yeah, actually, allopathic medicine also it doesn't directly comes. It is direct from the natural product only. As I mentioned, it comes from the original skeleton from the natural source only. There are some new molecules even in my laboratory. There are people are working on pure synthetic molecules. They directly choose the small molecule. They do lots of derivation and they do the biological activities. That is the other part of the work as well. So allopathy also very important because emergency situation and all we cannot go for this natural product. Like treatment by using the natural product or isolated candidates. So that time allopathy is very important compared to the natural kind of things.
Thank you for Henry. Nice talk. I've been exposed to certain things that were very, very clear previously. However, I have this question or this concern, and I think over time, this has become a point of discourse in terms of isolation, because in your talk, you did mention that you do more of the isolation. Now, in most cases, some school of thought believes that when you have an extract, there are some components in the extract that also help either the solubility or the absorption of certain active compound within the extract. So by the time you isolate, don't you think you may be risking not just in your own case? I'm talking about generally. Okay, don't you think you also be risking losing the biological activity of certain active compound within an extract? What's your thought about this?
Yeah. So those are doing isolation of any molecules from the natural source like a plant material. So my suggestion is we should not avoid not even a single molecule which are present in the medicinal plant. So to avoid all those things, we have to choose the proper solvent which can isolate both polar and non-polar compounds, both primary and secondary metabolites. Even though if you do the literature review, secondary metabolites which are more responsible for the biological activities compared to the primary metabolites like other steroids and terpenoids, those kind of compounds. So my suggestion to the researchers, those who do not want to lose any phytoconstants from the medicinal plant, you have to use a mixture of solvents like polar and non-polar solvents. But you should not use highly non-polar and highly polar. So definitely those two solvents not immiscible or miscible each other. So you have to use the medium polar solvents. Like you can use dichloromethane and methanol. So together 50-50%, like 1:1 ratio. You can isolate all the phytoconstants like which are present in the medicinal plant. So you don't lose any phytoconstants which are present in that particular medicinal plant. So once you isolate everything, then you can predict which may be the responsible for the biological activity, and that every time we cannot depend on medicinal plant also. We cannot collect tons and tons of medicinal plant and do extraction, and from that we cannot go for it. So later we need to go for a synthetic method, how we can synthesize that particular molecule in the laboratory. So that is where the medicinal chemists play a major role to synthesize, and they prepare a synthetic scheme how to synthesize that compound.
Yeah, that's
Thank you very much, Mahendra. Very interesting talk. No, I just want to share something. Maybe you can comment. Because specific areas, for instance, like I have a researcher from Monash, Dr. Farouk. We did a study on tocotrienol, okay, and the study was in fact published as a PhD publication with 10 papers. So the things that, like example, tocotrienol, it was derived, I think, from alpha tocopherol, and it was in that study, in that PhD, we claim that it is able to prevent atrial fibrillation in those patients with the post what call this after cardiac bypass. Yeah. So example, this is example of a case where is there any advancement on this kind of discovery? Because as you said, there's so many. We talk about products, so thousands of products. We cannot afford to go through, very expensive. But if there are already studies done at that stage, where they have even done randomized controlled trial, is there anything forward to say that this compound is it only atrial fibrillation or something else? This one. The other one regarding treatment of cancer, for instance, one of the products currently in vogue in Malaysia. This is from this plant called soursop, durian Belanda, soursop. It has been claimed that it's very powerful. Not only the fruit but also the leaf. Some of the researchers are even, I don't know what stage they have done the study. Some have encouraged people to take leaf extract from leaf for therapeutic as well as for preventive and as well as therapeutic. Then the third one, a compound like lycopene, you mentioned, for prostate cancer and so on. So I was just wondering, because these are already targeted compound and in fact already been selling now in Malaysia. You look online, this kind of product is selling like hotcake. People do not know actually many of things, even toxicity study have not been done. But anyway, it's been selling, and because they are sold under the context of traditional medicine. So if Bapa said the IPRA rule about being drug, okay. So just your comment, because you are involved in this. What are your thoughts about it? Because the compound like this already being tutored in the market, but not actually being put to test in terms of. So what's your thoughts on this?
Yeah, the first question is related to tocotrienol. That is one of the very good example actually. That compound is mainly isolated from the palm oil actually. And even some of my colleagues who are doing research in Monash University, so they developed, and nowadays I think if you look at, there are many products are available which are related to tocotrienol. Avanstar, I think they are producing a lot of products related to tocotrienol. So that is a very good example. So similarly, we have plenty of phytomolecules which are responsible for the pharmacological action. So slowly, due to now the technology is improved, so for sure we can bring so many new products by using all this natural. So same like a tocotrienol as well. And another question is related to lycopene. Prof mentioned that there are many the isolated compounds are maybe directly available in the market, in especially through maybe Shopee or Lazada like that. But the thing is, without any proper toxicological studies, don't rely on all those information. Even though I'm doing research on natural products, all the natural products are not safe. There are some toxic effects because of natural. Even high poisonous natural products are also available. So it is not truly, don't think that that all the natural products are safe. That is not true. So without any proper approval from NPRA, so don't trust on any products which are available in the market until otherwise, if you know the toxicological profile is already updated and get approval from the NPRA. Okay. And what about the other question from? Oh, sure.
That's also for cancer.
Yeah. Yeah, even there are many researchers, even in my laboratory also, they're working on cancer-related studies, including, Prof mentioned, there are some natural products. So our aim is we have to isolate the phytoconstituents which are present in that. Don't trust on the extract or maybe the whole medicinal plant, because that may be containing some are active compounds, some may be produce toxic as well. So our aim is we have to trust only on the pure isolated compound. Don't trust on any plant powder like traditional or complementary medicine related TCM related products and all. Until otherwise, if they really tested for the toxicity and they have the data related to those things, then only you can trust on it. Apart from that, don't trust on with the medicinal plant extract, or maybe if they're selling in a powder form, don't trust on all those products. Okay.
Yeah, that's the end of the Q&A.
Yeah, maybe I want to show a little bit about the Monash University, maybe 2 minutes only. So this is our, because I know some participants from overseas as well, and some they might be aware of Monash University, Malaysia. This is our beautiful campus, which is located in Sunway City. And Monash University have 7 campuses all over the world. And our main campus in Australia, and Monash Malaysia is one of the main branch campus where we offered all the undergraduate programs and postgraduate programs. And we also have a tie-up with IIT Bombay in India and many other like Italy and Indonesia with some universities where we are offering some postgraduate program. And if you look at the world ranking, Monash is currently 36 in the world in the QS ranking. It's one of the top 50 university in the world. And I'm from the pharmacy discipline, so we are actually number 4 in the world. And we are maintaining this ranking for the last 10 years, 10 to 15 years of time. So we are in the top 10 positions all the time. And even we reached to number 1 in the world also. We compete always with Harvard University as well as the University College London, UCL. And we also compete with Oxford University. So the ranking will be, every year will be 1 to 5. We will be competing with them. And apart from that, we have other disciplines, like more than 20 disciplines. We are top 50 in the world as well. And as you know, Monash University established in Malaysia 1997. It's almost 25 years plus. And this is one of the third largest campus of and one of the Malaysia's most respected university as well. So if you all find any time to visit our campus, if you want to collaborate with us in any terms related to drug discovery and development, feel free to contact us. Even preclinical studies, even there are researchers are working on clinical studies. So if you are interested, you can feel free to contact us, and I'm more happy to connect with the people because I'm the one person in charge for the external engagement, where I usually connect with other university people to the researchers who are in Monash University, Malaysia. So with that, yeah, thank you very much, and I given my contact details. So for you to contact in future, if you want, if you need any help and related to research, feel free to contact. Thank you very much.
Yeah, thank you. May I request Prof. Mahendran to be on the stage? Okay. So and Prof. Husli, can you please come to the stage and give the token of appreciation? Thank you.
Thank you, esteemed speakers, the chairpersons, and all the students for your, with a lot of time and patience that you have listened. Okay, now we will have a 10-minute tea break. And during this tea break, I would request the students, the staff who are scheduled for this afternoon's poster presentation to kindly display your posters on the poster boards. And the presenters, oral presentation presenters, kindly pass your slides to our IT team, which is here, so that for the fast flow of the presentations once we begin. So we catch back at 11:30 after the tea break for the oral presentations. Thank you.
After this.
No. Back here.
Bagi daripada jalan.
Kita just tahu voice actor dia Anus. I don't know.
Chat dalam video juga.
Apa jadi open yang hyper lah.
Apa ya? Yang saya nampak tu.
Dia buat sebenarnya macam by the time our reaction segala dia kembali.
What was your name in the video? Doctor what? I don't know. Doctor what?
It was like very intriguing.
What was he talking about again?
It was so yeah.
No, it was quite fun. No.
It's okay, like half an hour.
Wow.
Yeah.
Oh yes.
Joe, you DP? No. Only continue attending. Not the whole day. No, you can listen. 11:30 to 1 o'clock. There's a what's after the
We need to do it though.
They started walking.
So what did you do? Just do this. Yeah, you know. We need to ask you.
Salah nama pula dah.
So actually answer the question by saying,
What's right wrong with it? There's no Irfan, there's no Muhammad.
Bisa Jono.
I know GF is good.
if I see that
That's true.
It's hot.
Wait, give me.
How you got food? How you got food? Kalau ada food, boleh ambil tak? Ambil ya?
Oh ya. Nak sikit, nak sikit.
I don't know if it's solid. That's the Netflix.
Boleh panas tengok. Okay, yeah. It's the same.
Oh yeah, I saw this one.
Nice. Oh,
Nice, man.
I think.
Do you want? Are they giving food? Yeah. Really? I don't know. Good thing. We went. I ate porridge. So those are possibly everyone.
What do you say? What do you say?
No, besides you got no one sitting. Besides you got no one sitting. Berat dari barang dulu. Tapi I heard about this year.
Actually, right. Wait, so now I'm obese. Thanks for clarifying. You know, that just makes me feel a whole lot better.
I wasn't able to go to I was from Mac.
Depan tak ada?
Bukannya ada orang tak? I wasn't able to speak to how. Hi. Lewat. Ada tangan aku dalam tu. Ini. Ada tangan aku. Ada tangan aku yang tekan yang lupa aku pakai.
Sorry, bicara. Boleh dia kita kat kau buat. Sabar. Oh ya. Abang telur je. Tak faham.
Orang buat. Tapi my parents now stay in Malacca. Oh my goodness. Yes.
Others.
Hindu.
Dah Azura benci, aku benci gak?
Belakang, aku belakang siapa?
Kat luar.
Nah, I want it.
Oh, pasal duit.
What's your name? Somebody contract your name there. I look up all accept. When I look all the track, all accept them there now. You might just accept for friends. Oh, which part they no, I show you very popular.
Bayar dah 10 ke atas. Kita tahu. Kalau aku ni nampak. Kan 2000 aku dapat kredit ni. Sebab aku dah pakai anti-conservation. Kita try tu kita dah nasib
Bayar depan.
Bayar depan.
Tak ada. Tak makan. Tapi kan sedap. Look, baju lah. You take my portion. It's okay, I have to watch it.
Yes. So welcome back, ladies and gentlemen. We hope you enjoyed the refreshments provided. We will now proceed with the oral presentation, which will be conducted parallelly. The physical oral presentation will be organized here, while the online session will be at level 7 of Unity Building. We will now invite the chairperson to proceed to their respective venues. Our chairperson for this session, Dr. Sudha, will now take over. Please give her a warm round of applause.
Okay, good morning, everyone. So we start now our first oral presentation for today. So for this session, we have around 4 oral presentations. So as we are already running late, so without any further delay, I would like to invite the first oral presenter. So the first oral presentation will be by Kwan Fu Gan. And the title of the study is Harnessing IGF-1 to Enhance Stem Cell Mediated Tissue Healing.
Okay, so this is correct. Okay, good morning, everyone. I'm Gan, and this is a project by me, which is on harnessing the insulin growth factor to enhance stem cells mediated tissue healing. Okay, so we are mainly doing on regenerative medicine. Okay, and this is all our partners. Next slide. Yeah. Okay, so I believe everyone know this product, which is what we call the insulin growth factor. And not to say everyone, especially those gym enthusiasts, okay, they use this for muscle growth, okay, and this product is actually a critical role in growth and development. It's essential in childhood, and it is present during the healing process particularly on the phase 1 and phase 2, and even phase 3, it is involved in tissue in remodeling of the extracellular matrix. Okay, it has anabolic effects, okay, which influence the muscle strength, bone development. And in my project, I'm focusing on using this, okay, to enhance tissue regeneration. Okay, so I use it to culture the mesenchymal stem cells, and we call them as activated mesenchymal stem cells because we use this to activate, which is a growth factor to activate them. Okay, so it is involved in fibroblast activation and collagen synthesis. Okay, next. Yeah, so why do we do it? Now, based on our findings, based on current perspective, okay, we have limited studies and understanding on the specific influence of insulin growth factor, okay, on Wharton's jelly mesenchymal stem cells. And we obtained these Wharton jelly mesenchymal stem cells by our sponsor from CryoCod, okay? And also we have limited understanding on how, okay, whether insulin growth factor enhance the Wharton's jelly mesenchymal stem cells, okay, and the standard medium, okay, how is it different, okay, which one is better, okay, and also how this growth factor, okay, change the immunophenotype expression of the cells, okay, and also the collagen 1 and 3 expression, particularly important during ligament regeneration. As we know that ligament contains about 60% of collagen 1 and about 10% of collagen 3. Okay, and collagen 3 will remodel into collagen 1 if it's dry weight, okay, not to count the wet weight of the ligament. Okay, and it has a translational potential for organ-specific regeneration. And we know that most of our tissues are made up of collagen, including the skin. Okay, so that's why this is a first step. And the study of objective for my project is to evaluate how this insulin growth factor influence the Wharton's jelly mesenchymal stem cells culture in relation to cell proliferation, phenotypic modification, and the expression of collagen 1 and 3. And we do it we generally use the collagen 1 alpha 1 and collagen 3 alpha 3, okay, for this evaluation. Okay, next. Okay, so for the methodology, first, we obtain the cells from our sponsors in CryoCod. We expand them to Passage 4. But then when we obtain the cells, of course, we need to, is it working? Oh, okay, never mind. It's okay. Yeah. Okay, I think it's too bright. Okay, never mind, no problem. Okay, so we obtain it from CryoCod, and of course, we confirm the cells to be mesenchymal stem cells. And how do we do that? We do the immunophenotypic analysis using a flow cytometry to confirm it with the ISCT guidelines. Okay, and we expand them to Passage 4. And at Passage 4, which is the ideal passage, we actually culture them with different concentration of growth factor, namely the 0 nanogram per ml, 5, 10, 15, and 20 nanogram per milliliter. Okay, and after we culture them for 5 days, we actually take these cells for MTT assay to evaluate the cell proliferation. We actually do this MTT assay daily so that we can see the growth curve. Okay, and on the day 5, we take these cells for immunophenotypic using a fast scanto flow cytometry, and we do a PCR analysis on the gene expression. Okay, next. Yeah. Okay. Yeah, I think this is right. Okay. Now, so this is the cell that we received from CryoCod lab. They mainly fulfill the criteria set, the immunophenotypic criteria set by the ISCT. okay, which more than 95% express CD90, more than 95% express CD73 and 105, and about 2 or less than 2% expresses CD34, okay, which is what we call the cluster of differentiation. Okay. Okay, so based on the concentration, we found that we achieved the highest optical density value, which is what we call the OD value, on day 4 and day 5 in 10 those cells that culture with 10 nanograms per ml of insulin growth factor. Okay, and it is followed closely by 20 mg per ml. And we suggest that the optimal dose for cell proliferation is 10 mg per ml insulin growth factor. Okay, so which is the optimal dose for cell viability, okay, and metabolic activity over time. And if we look at the immunophenotypic changes, we note that higher dose of insulin growth factor reduces the CD90 and 105 expression, okay, which possibly influence the Waters jelly mesenchymal stem cell identity and differentiation potential. Okay, so in terms of collagen 1 alpha 1 expression, we note that the highest expression of collagen alpha 1, okay, occurs at 10 mg per ml. But at 15 mg per ml insulin growth factor, okay, the collagen 1 expression significantly declines. And that will suggest a potential saturation effect or a negative regulatory feedback mechanism, which is an indicator for future study. Okay, and also for collagen 3, these are dose dependent. So you see as the dose increase, the expression increase, and though this response is less pronounced compared to collagen 1. You can see collagen 1, the the fold change is so much higher than collagen 3. And this is what we expect in tissue healing, because if collagen 3 is increased, it might lead to fibrosis. Okay, unwanted fibrosis as well. Okay, so what does our preclinical findings prove in terms of soft tissue repair? First, it talks about regulatory imbalance at 15 nanograms per ml. Insulin growth factor may downregulate the collagen 1 while continue to upregulate the collagen 3, altering the extracellular matrix composition. Okay, and Waters jelly mesenchymal differentiation shift at higher insulin growth factor dose might influence the mesenchymal stem cells towards a fibroblastic-like phenotype, favoring collagen 3 expression over the collagen 1. As well, the optimal threshold for tissue healing is at 10 nanograms per ml concentration, which is ideal for a strong tensile support by collagen 1, while higher doses prioritize elasticity, which is the expression of collagen 3. Okay, so that's all. This is our reference, and thank you.
Any questions? Okay, so now we open to the judges for questions. And sorry, I rushed up earlier to start the session. I forgot to introduce the judges. So the judges for this oral presentation would be Prof. Razak and Dr. Manikantan, our two keynote speakers.
Yeah, thank you very much for the nice presentation. So you have been used IGF-1 for cell proliferation study, right?
Yeah.
So actually there are many studies already carried out on IGF in related to cell proliferation. So how that is differ from the study that you carried out in your research? Yeah.
Well, if we talk about IGF, yes, many studies has been carried out in the sense of the user secretome, the cellular secretome, such as PRP. but we can find limited studies which directly culture insulin growth factor on the water-stealing mesenchymal stem cells.
That is a novelty in your
Yes.
research. Okay. So you determined that it is concentration dependent, right? Or
Yes, it is concentration dependent.
in all the types that you have been tested, or only one?
For collagen 3.
Collagen 3. What about the collagen 1?
Collagen
Not-
1, yeah, after 10, if we increase the dose after the 10 mg per ml, then you can see there is a decrease. So that we suggest that there might be some negative feedback mechanism. But then that warrants for future studies. So we need to know how is the.
Yeah, but anyway, you have been tried with the lower concentration, like nanogram per ml. So that means
We tried 5, 0, 5, 10, 15, 20.
maximum 20. That is the maximum concentration. Okay. Nice. Thank you. Yeah, I think that's all. Thank you.
Thank you, Ms. Ran. So I invite the next presenter now. But before that, I will just remind the presenters about the timing. So each presenter gets 10 minutes, which is 7 minutes for presentation and 3 minutes for Q&A. So before 7, we will give you a reminder at the end of 5 minutes that your time in 5 minutes are up, so that you can wrap up your presentation by within 7 minutes. Right? So 7 minutes for presentation and 3 minutes for the Q&A. So now I invite the next presenter, Dr. Myokita, who will be presenting his study on developing a tool for customizable PubMed metadata PubMed export to.
Thank you. Good morning. I'm pleased to present our project, that is the tool for customizable PubMed metadata export. It is a lightweight solution designed to streamline and personalize the PubMed metadata extraction for researchers. Disclaimer, we both authors are just the clinical lecturers, but the first author has some background in programming, and we used a little bit of generative AI tools in coding, but all the conceptualization, coding, debugging, and testing were all done by both authors. Okay, a little bit of background. All biomedical lecturers are familiar with PubMed. It has more than 38 million citations, and we are using this almost every day. And when we search PubMed, we normally use the search box in the web page or advanced search box in the web page. After searching, we save our search products in 6 file formats: summary text, PubMed format, PMID, abstract text, CSVN, citation manager. We can save our search results in 6 different file formats. But the problem is the user cannot customize which fields to be downloaded. We have to use, for example, if you use abstract text, it is only in the text form, which is not structured format. You cannot filter, you cannot search. If we use the PubMed format, there are nearly 40 metadata fields, which is so structured, it is not human analyzable. So we have to select from predefined format with fixed metadata set. We have no choice. For example, if we do systematic analysis, Cochrane advised us to use 2 fields. Number 1 is the title and the abstract. There is no downloadable native PubMed format, which is constructed of both title and abstract. This is the limitation of PubMed, for example. To assess beyond the constraints, there are R and Python libraries. there are many, more than 10 libraries. But the learning curve is too steep for researchers without computational training. The ordinary day-to-day lecturers cannot use these R and Python libraries. So even though PubMed provides rich metadata, the native export formats at the web interface often lacks flexibility. Programming tools lack usability for lecturers without programming expertise. So our aim is to develop and evaluate a browser-based tool that enables users to select custom PubMed metadata feeds and export formats without requiring programming skill or software installation. This is the landing page of our tool. The user needs to enter PubMed API key. That is the good practice by NCBI. They suggest to use API keys so that you can have a faster download rate and ethical use of their website. And then the user needs to enter the query stream, choose the field you want to download, and in a single click, you fetch the data and download in any of these 6 formats. Number one is CSV type, which is useful in spreadsheet tools, Excel, filtering analysis and spreadsheet tools, PPX and RX for reference managers, JSON for further automation, PubMed text for bibliometric analysis for reference managers. In our tool, the first core citation and the last publication characteristics are the native PubMed metadata fields. The middle one for the information is the fields our tool pass. So when we evaluate our tool with a very simple query string to a very complex query string with 1-digit articles to nearly 10,000 articles, the fetching time is linear, averaging about 0.2 seconds per article. However, when we increase the number of parallel requests, even though the fetching time decreases, the number of failures increases. In number 8 and number 10 parallel requests, the failure rate is higher. So for these failed articles, we have a safe backup. The PMIDs of the articles which we couldn't fetch can be downloaded, and you can search it in PMID tools again. But we found that absolute failure is only in non-journal contents. So this is an example of other affiliation party. For MASA, until now, there are 788 articles as of last night. Institution affiliation party was a success, no error. So when we do country-level analysis of MASA researchers, to United States, the furthest to Thailand, Indonesia, Singapore to the nearest, that is the collaboration analysis of MASA orders in the past from the beginning of MASA University. So find compatibility, all 6 files can work with all the downstreams, Excel, citation managers, Python libraries, and bibliometric analysis softwares. So the findings, metadata of all journal articles were successfully fetched. Higher parallel request settings improve the speed, however, they introduce failures. Default configuration, that is 5 parallel requests, provide a reliable balance between speed and robustness. Affiliation parsing needs the contribution of the academic community because this is still a problem for all the bibliometric softwares. There is no incompatibility in the downstream analysis. So in conclusion, PubMed Export Tool allows the users to customize both metadata fields and export formats. And we intend it is not to replace the existing tools, but to complement them. And it's particularly useful for the beginner researchers with low to medium volume projects without institutional support. So this software will be the open source software when we publish it. For the time being, as of today, it hasn't been publicly available. Thank you.
Over to judges for the Q&A session.
Yeah, thank you very much for the nice presentation. So, actually, this tool, how far this is different from the tool which is already inbuilt with the PubMed software?
PubMed native is you cannot choose the metadata field.
Okay.
In only 6 formats, you have to download this metadata. You have no choice. The other tools, you need at least programming skills, how to use R or Python. Ours is only the front end. There is no skill needed. Your day-to-day stuff, enter the query screen, choose the metadata field, click, will be downloaded.
So that means this is a little bit basic and simple for the early researchers who want to download the materials from the PubMed, like metadata collection and everything. This something it is useful actually, yeah. Because we usually do search on PubMed, but this tool even first time I'm hearing that we are.
Yeah, because this is PubMed Export 2. I have one for our own project. So I thought that other researchers may need this, so we extended and we'll share the code and open source.
Oh, that's great.
Very interesting for me, and thanks for the nice study. Yeah? For this, for someone to use this new research tool, do you ever get the permission? Or?
No problem. We will make it open source.
Okay. So
the coders, they can improve, they can use it even for the commercial purpose.
Okay. Thank you very much.
Thank you.
Thank you, Prof. Neo, for enabling all the young researchers to do efficient metadata analysis. So now I request the next presenter, Dr. Saravanan Jagadeesan, to present his oral presentation on Centinella asiatica attenuates acetylcholine esterase levels in hippocampus of chronic stress-induced male Vista rats.
Yes, good morning, everyone. All of you can hear me, right? Yes, good. So today I'll be talking about something related to stress. Okay. Now, when we talk about stress, already my friend Garner told about the IGF expression. So many of the expressions have changed because they get stressed up when they listen to a lot of technical terms. So here I have come to reduce your stress. All right. So we'll see about Centinella asiatica, which is an herbal extract, and it attenuates acetylcholine esterase in the hippocampus. Okay, so my acknowledgements to my professors from all the 3 universities. So what is stress? Stress is with the psychological and the physiological reaction of an organism. And stress can be divided into acute stress, subacute, then we have chronic, and we have acute over chronic. To put in simple terms and not to complicate much, when a male and a female, when they are in love, it's acute stress. All right. When the date for marriage is wedding is fixed, it becomes subacute stress. When they get married, it becomes chronic stress. And when they have the kid, it is acute over chronic stress, already existing stress. Simple as that. So remember, acute stress, that is always more adrenergic. Chronic stress, it is more steroidal, it's more glucocorticoid effect. So chronic stress occurs mainly because of an external stimuli. Okay, so all the unwanted things that come from external part, the external environment disturb us so much, and the stimulus should be repetitive and it should be prolonged. So that becomes chronic stress. So chronic stress can affect all the systems in the body, directly and indirectly. The most important being the nervous system. Okay, Now, recently, 5 years back, there was an article in BBC which said chronic stress has got direct link to Alzheimer's disease. So it's better to stay calm. Stress can come through many forms, starting from family, childbirth, home, when you take a lot of loans, then job losses, then education. Students always say, I'm stressed out, stressed out. Then, of course, when you drive in a traffic jam also, you get a lot of chronic stress. Now, when you talk about pathogenesis of chronic stress starts with the secretion of cortisol. So when glucocorticoids increase in the body, it creates an imbalance. Technically, steroids always come to save the neurons. But when the same steroids go beyond a limit, it becomes more damaging for the neuron. So there is always an imbalance in oxidant, antioxidant levels. Then we have, this leads to microanatomic changes in the neurons, like loss of mitochondria, myelin sheath synapses, and so on. So that's called as ultrastructural changes. Finally, when all these things are changing, synapses also undergo damage. So naturally, there is a change in the levels of acetylcholinesterase, and this leads to depression. Okay, so this is one of the pathways for depression. So depression can present in many forms, starting from emotional and loss of cognitive function, healthcare burden for the society, and also it can produce physical symptoms. Depression in Malaysia is still very less diagnosed. It's only around 8 to 12%, and the need for survey is important, and the number could be higher. What we see might be just a tip of the iceberg. Current medications, normally there is 4 groups of medications, starting from TCA tricyclic amines. Then we have monoamino oxidase inhibitors. Then we have SSRIs. This is serotonin, selective serotonin reuptake inhibitors. This is serotonin and norepinephrine reuptake inhibitors. But what we are going to look at, we are going to use for validation is the fluoxetine, which is the most commonly prescribed antidepressant. We selected the Centella asiatica. This is part of a big project. So we selected Centella asiatica because it is easily grown. It has been known for centuries in all traditional medicines throughout the world. And most important, it has very, very low toxicity. Okay. Now, Malaysia has always had an advantage because of its tropical position. So you can see prevalence of depression is still low. So we can prevent depression. Soil is good, climate is good, so that it can be grown. Centella asiatica can be grown throughout the year, and most important, people have welcomed herbal products into their lives. So the neuroactive components of this Centella asiatica, all the components which we are going to see, like bromosides, asiaticoside, metacoside, pentacyclic tripenic acids, and also centelloside. All these compounds, all of them have effect on the neurons. Okay, so like what our previous Prof. Magendran had talked about, that any new compound in the herb, it has got effect on multiple organs in the body. So here, all these components also have effect on the neurons. So extract of Centella asiatica, we took the plant, both the leaf as well as the stem, because one of the study in Malaysia has already told that this particular extract, this particular herb, all the parts, roots, stem, leaves, even flowers, everything has got nutritive values. So we took a aqueous extract. There are 2 types of extract we can take. We prefer aqueous extract. It's a stable powder, and it's a crude extract with a long shelf life and very low toxicity. And ingestion of this is usually not the components are not degraded by gastrointestinal enzymes. Why acetylcholinesterase in this pathway? Because it is just changes in this can produce depression. So it is involved in synaptic function, and then it is cognitive function is also based on this. That's why in case of Alzheimer's disease, acetylcholinesterase active drugs are always given. So it is elevated in chronic stress, and finally It's an important enzyme for memory. So what are the stressors we give? Poor fellow, we gave so many stressors. Huh? We gave 9 different stressors, starting from restraint, force women, 4-degree water. I don't think we would have done it. Then we wouldn't have slept on a bed which is wet. So then cage tilt for 45 degrees, tail pinch, very painful. Then no food, sometimes no water, but given food. Or this is for 24 hours. Then change in cage mates. This is very, very important. Huh? Tie up, break up. So I did this. We didn't leave anything. So finally overcrowding. So when we started this experiment, we didn't know that all these things one day would also become something related to COVID. Okay. So during COVID period, people underwent restraint because they were inside the house. They didn't get food. Many people were on the streets with bedwetting, with the bed which is wet, and so on. So the study design was we took male Vista rats, 36 rats, and divided them into 6 groups. So the first group was control group, who were happily munching all the food we gave. The other groups underwent the stress for 8 weeks. So at the end of 8 weeks, we had to euthanize them. So the dosage was, for the stressor group, we gave only normal saline. Then we compared with fluoxetine, which is at the dose of 10 milligram per kg body weight. And then we have Centella asiatica, the dosage of 200, 400, and 800 was selected based on the previous literature. Centella has got a very low toxicity. About 4 grams per kg body weight can bring about toxicity. So we took the hippocampus, then homogenized, we get the oligard, then we did the ELISA, we got this result. You can see the control result. This is the group which was the stress group. So where we gave only stress, no other drug. So you can see the acetylcholinesterase level at the level of hippocampus very high. Then we have fluoxetine, which has reduced this change. Then at the dose of 200 still, the acetylcholinesterase levels were very high. Then we have at 400 and 800, the levels were very, very similar to fluoxetine. So this is what we saw now. So in conclusion, simple. Every time we eat lunch or dinner, we should have Pegaga with us. That's what Central Asia has called in Malaysia. So chronic stress can induce depression. So this stressors covers all the various aspects of human life. That's why we selected the 9 stressors. That is the specialty of the study. Then we have Centella asiatica, which is known for as being a neurotonic. And then the study shows that it attenuates acetylcholinesterase. So these are the reference, and these are the partners in crime and torturing the animals. Huh? So these are the people. Okay. And finally, to say thanks to all the rats who sacrificed their life for this presentation. Thank you.
Thank you, Dr. Jagdishan. So over to the judges.
Yeah, thank you very much, Jagdishan, for the nice presentation. So Centella asiatica is already well known for its neurodegenerative. It has been used for the treatment of neurodegenerative disorders. There are plenty of study has been already reported as well. So how that is different from the one by which you have been done?
Most of the studies that were done were done on maximum 4 or 5 stressors. But when we decided, we thought that it should cover almost all aspects of human life.
Okay.
So we selected 9. So that was one of the novelty for this.
Okay. So did you identify what is the phytoconstants that might be responsible for this acetylcholinesterase inhibition?
We took up crude extract because that is what we are going to consume as a normal layman when we talk about Pegaga. So that's why we selected aqueous extract, and it's a crude extract, so that it will match with that of a real life situation. So everything that we planned in the study was more towards being close to what is happening in day-to-day life.
Okay, so you found that dose dependent activity.
Yes, it is a dose dependent one.
But when compared to 400 and 800 milligram, not much difference, I think so. So 400 may be the ideal dose, I think so, when compared to 800 milligram.
So recently also, just 2 years back, we had a article in Star Paper. How many of you read Star Paper? Huh? Okay, that's fine. So in Star Paper, one of the topic was longevity, in which people told we take fish oil to prevent Alzheimer's. Then another lady was interviewed. She told we take. She was around 92, so she's very healthy. She told from the time I know I have been taking Pegaga every day, that is Central Asiatica every day. Okay, so I think we should replace some of the food dish with the Pegaga also, so that nobody gets stressed up.
So the 400 milligram dose more or less
Yes,
very well correlate with the positive control that you have been
That's
taking.
correct.
What is the dose that you have taken for the positive control? The dose of positive control?
Fluoxetine,
Oh,
10 milligram per kg. That's a standardized for all experiments.
okay, that's fine. So what may be the future work, because now you already
We are looking into microglial cells and blood-brain barrier for the same stressor, and we are also doing studies on Alzheimer's disease. In the same lab, we have created an animal model using aluminum chloride and D-galactose, and we are doing the same, continuing the same studies.
But is there any TCM, the product which is available in the market, something related to by this plant? I think I might be seeing some products.
Lot of products
like
are there.
powder form.
We have taken this from UITM Punchakalam.
Okay.
And we did it. We didn't take any products that is available. Maybe future studies might be to compare these products with the extract from.
Yeah, that's great. Thank you.
Yeah, very interesting. Professor Lee was telling me that the Malays take this every day, the Gaga. And that means the reason why they are always healthy.
True.
But is there any dose related, the side effect? What are the things you worry about?
No, for this particular that's one of the advantages. The dose is very high, nearly 4 grams per kg body weight. Then we can see side effects. But the side effects, as usual, liver is one of the major detoxificating center, right? So liver is always affected above 4 grams per kg body weight.
Thank you very much.
So this is an edible plant, right? Which usually people are taking in their daily.
The only thing is we should wash it well before consuming, and it is edible straight away.
Okay. Yeah. Okay, thank you.
Thank you very much.
Actually, I was wondering how we can give the stress which the humans face to the rats, but looks like we can do that also. So now we invite the next presenter, Dr. Madhu Katyani. She'll be presenting her research on
Good morning, everyone. So my topic of presentation today is about the molecular mechanism involved in the wound healing activity of polymyxide. So regarding the introduction and the problem, so wound healing is required for the restoration of the skin tissue, and that it will be preventing the infection and all those things, and that it also the main problem with this wound healing, especially the chronic wound healing, is that because of the existence of the comorbidities, just like diabetes or vascular diseases or trauma. So that is the main thing, and that if we have an accelerated healing, then the quality of life of the people will be better, and that the expenses which are incurred for the health aspects will be reduced. So what is the problem here is that even though there are advances in the wound healing, the main problem is that there is it is very expensive. First thing is it is very expensive. Second thing is that the wound healing treatment is usually slow, and that why? Because of the vascularization or inflammation or poor because of the infections. So there is a need for a therapy which is affordable and which will be targeting mainly to the molecular pathways to enhance the repair and reduce the complications of chronic and hard to heal wounds. So our study is about the polymocyte, which is derived from the plant source, which is Chucrium polyum. The Chucrium polyum, it is having antioxidant, anti-inflammatory, as well as antimicrobial activities, which are already in the literature, and that so this polymocyte is a phenyl ethanoid glycoside, and this polymocyte is also having an antioxidant activity because it is scavenging the reactive oxygen species, and anti-inflammatory activity because it is inhibiting NFKB cells, and also it is suppressing cytokines, as well as it has got antimicrobial activity and on bacteria and fungi, as well as cytoprotective activity because it prevents the oxidative damage, and also it will be upregulating the VEGF alpha genes, which is helpful in the angiogenesis. So because of all these things, biological activities that this polymocyte is having, this we have studied for this polymocyte for its own healing activity. So what is the research question? How this polymocyte is exhibiting the wound healing property, and to determine the molecular mechanism involved in the wound healing properties of this polymocyte. So our hypothesis, null hypothesis and alternate hypothesis. So the alternate hypothesis is that it would be mediated with the regulation of the gene expression with one or the other key wound healing genes, and that homeostasis process of wound healing, which includes homeostasis, inflammation, neovascularization, granulation, reepithelialization, and tissue removal. So regarding the methodology, we have purchased this polymocyte from Cayman Chemicals. The purity is more than 95%. It is solubilized in DMEM because it's water soluble, and that it is also studied. It is the cells that were used is 3T3 cells, which are cultured in DMEM, supplemented with 10% fit and boil serum, and that at 37 degrees centigrade, and that humidified at 5% carbon dioxide chamber, and that the cytotoxicity studies were conducted by using this MTT assay, and scratch assay was also conducted, and we tried to find out the wound closure and migration rates, and that we have done the statistical analysis using GraphPad Prism 9 to perform the statistical analysis, and also the gene expression studies were conducted, and we have utilized 17 wound healing genes by keeping a housekeeping gene as a reference, with data analyzed by double delta CT method, and that the what we have studied, what we have understood in the MTT assay is that even 1,000 micromoles, the viability is still existing. That means it is safe, and that then wound healing studies, we have conducted this wound closure studies using that is 2 million cells per 6 cells, which are grown for 24 hours in a monolayer, and we created a uniform scratch, and that these extracts were given, and that the total surface, the wound closure is calculated by this formula, and wound migration rate is also calculated like this, in this way. So what we have found is that the polymocyte is having a dose dependent, and also here time dependent. Time also it is, you can see that there is you can see the wound closure like 24 hours very much you can see, and that it is almost 48, it is almost done, and that Here also you can see the different concentrations, 10 micromoles, 100 micromoles, and 1000 micromoles in dose dependent and time dependent fashion. It is closing the wound closure and migration rates were performed, and this is the thing. And that gene expression studies are also conducted by using this qPCR studies, Thunderbird SYBR, and that these are the conditions at which this is conducted. And GA, as I mentioned before, GADPH is the housekeeping gene which is used as a reference, and the relative gene expressions were calculated, and that you can see here the CXCL10 and CXCL11 and also the CECL2. These are upregulated, and here also you have VCAM1 and ICAM1 are upregulated, and here BEGF alpha is very much upregulated, and then here in this case CIMP2 tissue inhibitor of metalloproteinases is also upregulated. Others are also. So this is the PI, that is plasminogen activator inhibitor 1 is upregulated. So you can see these things. And then regarding the conclusion, so polymercide is showing very potent wound healing activity, and that this the genes that were upregulated are CCL2, CCL10, CCL11, VCAM, ICAM1, collagen, and PAI1 as well TIMP2. So these are the things. So in essence, it is a very interesting compound. So this is regarding it, and we would like to conduct further clinical studies upon like first the in vivo studies and later move on to the clinical studies for further usefulness of this compound. So that is regarding this. Thank you very much. You are very good.
Questions from the judges?
Yeah, thank you very much, Madhu, for the nice presentation. So in your literature, I think you haven't mentioned clearly about this particular compound. Polyumoside is already reported and well known for its antioxidant, anti-inflammatory, and other properties. There is no report related to wound healing reported so far.
That is not being done. That's why, because it is having all these things, we thought that this would be a right choice for observing about the wound healing activity, and that we try to find out the molecular mechanism by which this wound healing can happen.
Okay, is there any study reported on this plant where this compound isolated from?
Yes, polymercide is
The plant I'm asking, that already well known for its wound healing properties.
Yes.
That already reported.
Yes, it is not like the wound healing properties are not being reported, but antioxidant, antimicrobial, and anti-inflammatory other properties, cytoprotective action, and all those things were reported.
Okay, so based on that, you chosen this for the wound healing activity. So, what is your suggestion? How we can bring this into the market? What may be your future direction of this particular compound, or maybe the plant material?
That's why from next step, if it is in vivo, also if it goes successfully, we can go for the
Formulation.
clinical only where if clinical studies we go nearer to the clinical studies, and if it is successful, it will be very useful. And comparatively, it is affordable. Is also the price is also not so much high. Is what I think.
And the activity you got, it is concentration dependent here as well. Okay, thank you.
Again, a very interesting study, Doctor. Can I just find out? I'm sorry, I'm a bit ignorant. Is it good to be consumed orally or for local application for your wound healing?
This is a
It may come to practice later, in the future, yeah.
So, here, this one is a compound that we have studied, and it is an in vitro study, that is laboratory study only upon the cells we have done. But in vivo, when we are doing, we can get more clarity, and if it is gone to the further, if it is orally, it can be taken. We have to do this toxicity studies and find out whether it is useful.
So what do you think will be better, orally or by local? If there's somebody with a wound? I'm just curious. Yeah.
by maybe further studies can help, bro. But further studies can locally would be better because if it is
It's safer, isn't it?
systemically, if there is a chance of more adverse effects, or if at
sure.
all, if it is safe, good, bro. But if at all, if it is only a local application, it will be much more comfortable for the patient.
Sure. Thank you, Dinesh. You go for different dosage forms, like you can go for oral administration form, or maybe you can prepare in terms of ointment or something like that. So then you can apply on the animal's wounds. Then you can check whether it is really healing and how long it is taking to. So those kind of study will be interesting in the future. Okay. Thank you.
Thank you, Dr. Madhu, and thank you, judges, for this for the session. So now we will break for lunch, and I request all participants to return back before 2 p.m. because in the afternoon we have 3 more keynote speeches and further oral presentations. So in the afternoon there will be parallel oral presentation and poster presentation going on outside, which will start around 3 after 3:30, right? So 2 p.m. to 3:30 p.m. we'll have the keynote speeches, and 3:30 onwards we will start the oral presentations and the poster presentations outside. So for all those who are going to present the posters, please you can display your posters on the poster boards. So the numbers have been assigned on each poster board. You can display the posters accordingly. Right? Yeah. Thank you, everyone. So we can all discuss.
Rubbing on those chocolates, Salvo. They're good.
Hey, thanks, man.
No worries, man.
Tengok kita YouTube live. Oh, no, no, no.
Smile again, smile.
Okay, smile.
Kalau kau hari ni
Apa yang dia
ada tanya. Nampak rasa sini je tak nampak. Atas sini.
No, because like you cannot figure out the orientation. And then when we do, it's okay, the thing is not okay.
At least something like prediction.
Timeline.
Are there any oral presenters here? If you are here, please give your presentation slides to the IT team. Anybody here who's going to do the oral presentation? Oral presentation.
2:30 come back. Quality will drop. You upload from you download and upload inside. Because if you go out and see the poster, right? If you go outside and see some poster, like memang real like this tau. Some poster, tapi yang ni semua clear. I thought later you have to go out and see the poster. Dah banyak kat luar. Yeah, and like I don't know what you guys say cannot find me. I'm still driving. Oh wow. Dia masak apa? That what? I see that image. What? I don't know why it's still like that. Dia want us datang sebab dia dah buat banyak keynote, lepas tu banyak orang datang. Later you go out, there's this paling depan lah. Go out here paling depan. There's satu sebab You go and see the table, it's still clear. Walaupun isi mana, dan duduk kat belakang, dia ada lelaki yang belum sangat lah. Tak boleh. So like this word, I type here, I type on Canva, then this bar I take from macam tu. So tak apa. You can upload Can. Tapi blur. You see? It's also blur.
What? Yes, you want to give someone. The face is right.
iPad kena 2%. Maybe lah. Ada. Do like this one. Why to become more blue? Oh no. Okay what? See? On my laptop okay. But I don't know about like okay lah kot. This one copy paste lah. Okay. Tapi kalau on phone tak okay. Oh my god. I feel like ni okay. I feel later when it's like poster presentation yang then esok you have to go out and see how the result. Faham tak? Yang present itu you Saha and Sonia right? One again. Saha kat mana? Oh. Especially like that time kan we meeting dengan doktor kan you tak ada data yang complete lagi dah. Dia asyik kata just go we did nothing okay. Just tell them we did nothing. We don't have anything. So always like okay so yeah. But yeah. And then she always keep things to herself. Tak bagi tahu pun dia nak buat apa. Keluar. Yes. Okay, ada metodologi. Bukan dia buat yang malu dalam poster. Dia kan international kan. So dia buat. Lagi present apa? Without consideration
Oh, dekat sini eh?
But you see outside, right? They don't have also, and then I saw a poster. Their reference is QR code. They scan for our reference. Tak, you pergilah tengok sekarang. Pergi. Pergilah tengok. Tak apa, you go and see first. You go and see first, and then like. Tak lah, I mean like you go and see what I try to tell you guys. Kan outside already have a lot, right? So you can go and see. Kalau tak. But then like some of that is like the one I tell you that and Keynote, right? They put like important reference, they put very damn big. Because that one is like budget around what? About that lah. And some people they just put reference like scan. It depends on. But at the same time, I feel it's like got pro and cons.
Why she can, I can.
Clear sangat. Damn small, you know, but damn clear. Like this okay ah.
Kang nanti kan? Wih, dah konsert live tu, gempak bagi aku. Masih live? Live ni? Tak answering ni? Dia balik lah laptop tu. Ni, laptop aku tu. Dia? Dekat. Lagi sekali tu. Nampak headline? Tu dengar? Headline tadi. Ada 2 orang tu. It is very informative and great learning. Dia target. Siapa tak ada join.
We're having our lunch break today, right now.
Okay, nampak. Okay.
Stay tuned.
Sekali.
Tak apa.
Aduh, aku nak buat video.
Ada masalah kan? Ada masalah. Boleh lagi?
Aku kau ni. Kenapa tak ikut aku? Aku ni lah.
Bodoh probiotik bodoh ni.
Ni.
Like that one is so.
Orang tidur je.
Mana bawa kereta ni?
Bodoh kan aku lah.
Okey lah, aku buat gojek. Aku buat gojek ah. Aku jogging. Mari aku hantar balik. Okey. Ya.
But then Chinese need a lot of their oral practice. Something very nice. I don't know how to do it. Maybe you got too many words to it. That's why I want Dr. Mark. Oh yeah, no, because it's the same education. And now she's but like she still can yeah, like she did it right, but then they want her to like complete like do you think it's better like that or yeah, like how would she make money like later then like you know the class should like oh yeah because yeah, he also. Like she cannot stop before they yeah. He also but then the professor, the one that solved the one, he's using because the same as a good open source. Especially if you get like and then you're like, okay, so how am I going to get like the data? Like, where am I supposed to read like the article? When it comes to
Not only for the judges. Judges yang pernah banyak. Hello? Yeah, I just wanted to make
but then right you saw right that one important reference boom super big but then you see the table damn small because they do analysis but that topic is just nothing plus I love you.
Where did you get your lunch? Let's go there. Okay, let's go there. I'm talking to you. Go to lunch together. Kita talk over lunch. Really? Aku tidur nanti makan lunch. Bukan kat research kan? Betul. This is our last day of research kan? She's watching lunch together. Okay, doctor. I have like no self-respect. Yeah. Yeah. So should we start organizing the last day of our research? She's supposed to lunch early.
Why not we go lunch together?
Yeah.
For real?
Yeah.
Jangan dia tak bawa kita.
Dia kata siapa tak? Dia balik.
Oh. Ya, kita dah cakap apa? Cakap. Tiba-tiba lagi.
Bro, it's weird. I cannot.
I mean, like, I cannot plan with her. It's too much. On the rabbit hole.
Oi, takut. He's supposed to lunch at us.
I don't want to see.
I'm ready at home.
It's like, finally, this monkeys are done, you know?
Just get her. Oh, but she's at home. Oh, but sure. Okay,
You know what's my flex this one?
Kadang buat tak pas-pas lah. Lepas tu dengan SPF tu lembab sangat.
For some reason, it's not there.
What not? Memang kita lupa lah letak air.
Bukan saya pakai mat. Ada dua yang
Oh, nak kasih.
Oh, yeah.
Yes. Nak ada kasih. Jadi kalau juga saya that's the thing. That's the thing.
Just ikut Jerman. Ano po yun?
Salah, ano yan? I don't know why my eyes are my husband and my sister. No, I want to go to the evidence and it's a month.
Bro, what is wrong with this wine?
You know the before the one sama ada table one. Dia buat dulu lah. Tapi I go for this one. Semua ada.
So which one you want?
Yang tidak diperlukan.
Kita tak mana.
You know last time the Google Sheet we did like all the
No,
Google
this is
everything.
the
Then after that one more sheet like Sarah asked us to correlate like demographic and non-correlation. So she gave us the computation and then we have to do out. So we got like two what. And then this one rather than you don't tell me when you're gonna start try to start
which brother?
yeah, which brother is
Which brother?
which brother A ber K ber K tu lepas tu I cakap I say I'm doing this now and then I say aku is in another tab in the same this tak nampak siapa masuk ya link pun dia tak ada It's hard to find the date because like there's no physical activity. By social economics.
Tak bisa dia. Bilang lagi. Ada orang tengok 5 orang.
5 orang tengok jadi kan. 5 orang tu tolak.
Dapat duit ke kalau buat live?
Banyak dapat.
That's like
Dia tak tahu buat apa-apa. Actually, because dia dah buat
but this is I get results man. But like nak alih this thing we do and then what are the what you don't understand?
You don't understand, right? There's even a few minutes where it's actually you don't understand answers, right? Exactly. No, you don't look at other people's posters. You don't understand.
Yeah, you don't understand also.
You don't say like, we make it in a way that people don't understand. It's better to keep track. Right? I don't see what's wrong with it because if you want certain things, you're supposed to be able to explain it if you don't understand. People have to understand. Yeah.
The girl just take that off down this like
Literally, your lecture no I understand. Tak. Tapi bila I nak explanation tu, bila I lecture tu, okay faham. So it's the same thing that applies here. Right. You have chosen the book.
is this poster than this? No, right? Yeah. Oh, and guys, you know, we must mention Pearson Chi-Square and Pearson this one. And then well,
So I say very better for you, very better.
This one you want one? This one. This one also don't want.
When you get checked out?
What size will I do for that? Even one I don't do this thing. Right. I'm already scared for our group of like because like they don't give feedback like ASAP.
The book A and the book A and the book R.
Exactly. That's what I tak senang hati sekarang. Kita ada orang buat pun tak boleh sebab dia tak tahu.
That's why also I tak nak jangan kira bukan bagi dia don't hesitate walaupun kita tahu place tu tak but I'll try lah.
No, if you cannot explain, you will help me. And like, I feel like I mean like can explain now because
dia macam kawan ni.
oh yang sorry.
Tapi kalau ada jadi tapi kalau ada tapi dia ada jadi yang saya nak mau yang kena betul doktor. The video that I made also I made during the like during one day.
Why you never ask the guys how to do it?
Laki-laki tu buat apa ni? Bro, ini mah I refresh pun dia refresh macam budak tadi. Refresh is fine. Bila ni apa dia? Dia tak refresh. Dah ni apa refresh ni? Dia kan?
Okay.
So why is like this? You wanna put this here? This one Indian here. Oh my god, it looks so good. My phone is dying. Where's my phone now? What one is this? Dia nampak lah macam dia punya cakap kan. I hate it lah. And then sorry. Especially when you talk to him, right? I like the face to face. Ten. Okay. Yeah. But what I did? No, my picture. Like the things is same, tapi we rearrange. Oh, we rearrange like 1,000 times. Like 1,000 times. I think the barang ni suddenly remove 40%, rearrange again. One more time. And like girl can't give you feedback. Yeah, nak buang laptop dah. It's possible that the answer is girl. There's nothing you can buy. It's not that. I know, right? Why you see yourself that? Yeah. Wait, I cannot unlock this one. Siapa yang letak ni? Aku nak unlock now. Oh. Tak delete kan tak boleh. Why ah? Who locked it? I don't know. Oh, kan ready. I can unlock it. But then we can we choose like another child or landscape? Last, and then we can find我们还要去找老师It's never ending It's never ending 我应该没有吃午餐啊什么啊你去吃呢我应该吃我的早餐的然后你就boleh. Tak ke lah, please lah. Tak boleh. Allah, berapa banyak itu? Yang saya suka ada, yang suka dah cukup. Semua bukan penting. Landscape. Semua bukan landscape. Saya memang tak menampak kesan lagi. Just drop. Ada cuma gambar kita orang ni lah. Why you stand like that? And then you stand like lagi semua. But give me the one. Ini pun boleh lah, tak apa. Okay. Delete for everybody.
It's nice when they do.
I got memory satu. Tapi tak ada Malaysia. Ada gambar di Malaysia. Ada Malaysia, boleh aku. Orang yang ada gambar tu bukan orang Malaysia pun. Everything lah, just everything is. Jom. Bawa pun, jom, lari. Tak ya. Saya kita main balik, lepas tu tapi takut lambat. Jadi dia nak charger. Dia dah unlock with chip dia. Nak edit. Bawah. Ya. Waiting for suggestion mistake or if something to edit at least. If something happen, kalau tak clear ke, aku macam edit here straight. Okay. Ada tu call you. Really ah? Okay. 你要坐在前面嘛？我不知道啊，可是我为什么不跟berterabur? Tak lagi. Aku dah macam aku dah berterabur. No.
Hold on, and then the you okay? You stay here. Full done. Oh, the line, yeah. Okay.
You should be an nature's medicine man. No. You should never realized that.
Ini kena kaget. Si dari Majan kali. Wis. Kam masih dari Majan ni dah. Tidak.
ஹலோ, என்ன இங்க வந்துட்டீங்க?
ஒரு நேரத்தை நான் ப்ரெசென்ட் பண்ண போறேன்.
வீட்டுக்கு போகலையா?
We sitting together. You want to join Malaysia? You know, in Chennai, there's a one chicken rice stall run by Chinese. Yeah, when I see them, I say Galama. And they give me just 50 you know my chicken like this now. Few more time, okay. Every time I go there, pick the portion. I call them Nicola. But funny thing is, there are 5 of them. They speak Cantonese among themselves. No, they don't speak about your Burmese language. They speak about, they're also from Burmese, but they speak Cantonese. Then I said, what's wrong with you? You see, the different parts. Burmese they speak Cantonese straight away. They know myself. I told them, only these 3 sentences is Kong lah. Mingalaba, just 1 year, no? 1 year. They've done the Popo A. Like me.
Oh no.
Welcome back, everyone. Before we begin, can Group 10 and 12 of our presentation please submit your slides to IT now? Thank you. Good afternoon, ladies and gentlemen. Welcome back to our conference. We hope that all of you has already enjoyed your lunch. So we would now like to invite the chairperson for this session, Associate Professor Dr. Venkata Suresh, to introduce the next keynote speaker. Please welcome Dr. Suresh.
Okay, good afternoon all. Come back after the lunch. So today the keynote speaker 3, I would like to introduce Dr. J. Srikanth, who will be talking on zebrafish and beyond. Sustainable models for ethical and efficient pharmacological screening. So let me give some brief introduction about the Dr. J. Srikanth. And J. Srikanth is M Pharmacy PhD, PGD PRD and PGD SBSA, and serves as Associate Professor in Pharmacology and Assistant Dean for students at Sri Ramachandra Faculty of Pharmacy, Srihar. It is in Chennai and it is in India. So with over 15 years of academic experience, is widely recognized for his contributions to innovation-led education, alternative models in drug discovery, and sustainable academic governance. As a certified innovation ambassador under the Ministry of Education's Innovation Cell, MIC, Government of India, Dr. Srikanth plays a critical role in promoting translational research, technology development, and ethical experimental practices. His pioneering work on zebrafish models and in silico methodologies has offered practical alternatives to the traditional animal testing, aligning with the 3 R's principle, that is replacement, reduction, and refinement, and supporting global efforts to reform preclinical research. Dr. Srikanth's academic output includes over 60 peer-reviewed publications with a focus on neuropharmacology, natural product, drug discovery, and computational pharmacology. He is also served as a principal investigator and co-investigator in multiple funded projects supported by AICTE, INTI Malaysia, and Srihar. His innovative mindset has led to the filing of 9 patents, including novel lab apparatus like Franz diffusion cells, Murray's waterways apparatus, and non-invasive insulin delivery devices, and several of which have received Indian and UK's design patent recognition. His excellence in academia and innovation has been acknowledged through numerous national and international awards, including AICTE Vishweshwaraya Best Teacher Award in 2021, Career Award of Young Teachers by CAYT, and the I-Class and CALAS Young Investigator Award. Notably, he received a silver medal at ITEX 2021 for collaborative innovation in lab design. Beyond research, Dr. Srikanth holds strategic administrative responsibilities at Srihar as Assistant Dean for Students and NCC Caretaker Officer. He fosters students' engagement and discipline. His influence extends to the institutional development as a board management member and a core committee member of IQAC, helping shape policies and quality, safety, and academic standards. Importantly, Dr. Srikanth serves as a secretary of the university's UN Sustainable Development Goals, that is SDG, committee, where he spearheads initiatives aligning teaching, research, and outreach activities with the global SDG benchmarkers. His leadership has played a pivotal role in preparing the institution for THE Impact Ranking, that is the ranking, and particularly under SDG 3, SDG 4, SDG 9, and SDG 17. As an institutional research fellow at INTI University, Malaysia, and invited speaker at our conference, Dr. Srikanth exemplifies global academic collaboration and innovation also. So his integrated approach to research ethics and sustainable education continues to inspire the next generation of pharmacy educators and other scientists. So with this, I would like to introduce, with my pleasure, so Dr. J. Srikanth to talk on zebrafish and beyond.
Respected ladies and gentlemen, I thank the organizing committee of Masha University, especially Dr. Venkata Suresh Chinni sir, and the team, the dean, the professor of biochemistry, and all the students, especially of Masha University, so where you hold of positions in different constituent colleges. So it gives me immense pleasure to stand in front of you to deliver some of the basic pathways which I traveled in my research career, and just to throw a highlight of what has to be done in future by the young student scientist. And as a innovation ambassador and a SDG secretary, my focus of my presentations would be on how in future the research would be possible, basically focused on the alternative to animal experimentations and how the experiments in animals are going to take a drastic shift in the near future, coupled with AI and other technologies, what is being done. So with this small introduction, so thank you. So the topic for today's presentation is the zebrafish and beyond, the sustainable models for ethical and efficient pharmacological screening. So once upon a time when I started my pharmacological research, so most of the times it is going to be performed in experimental animals where mice, rat, and the higher animals are used for any type of behavioral, pharmacological, or uh, genetically modified disease models. But now coming to the upgrade trend, how it is going to be entering into a sustainable practice. So whatever we do research should be of sustainable nature. So what do you mean by sustainability? So most of the speakers in the morning sessions were saying about the introduction of natural products when it comes to allopathy or nutraceuticals or homeopathy. So, but the concept here is when it comes to sustainability, it's not that the research output we are going to identify a molecule and we are going to develop it as to the next level. But the concept here is how we are going to use this in our day-to-day life, trying to promote our day-to-day activities like prevention is better than cure. So that's the most important concept when it comes to sustainability. Because if you take a nutraceutical product in your day-to-day life, like a flavonoids, like vitamins, like spinach, so that's going to help you in the process of preventing a particular disease or disorder. That is sustainability. But when it comes to scientific based evidence medicine, the vice versa is opposite. So we are on the two extremities trying to find a way which is going to be of better quality. Like I just try to identify a person most familiar to the Chinese system of traditional medicine, Su Yu. Can anybody let me know who is that person? Su Yu. Queen? Sir? Yes, sir. Queen Hasu. Yeah. She's other name is called as Queen Hasu. Any idea about that? Okay, let me tell you that. She was a B Farm graduate who did an isolation and characterization using the basic TLC method for identification of a particular isolated compound during her 1980s. for which she has received the Nobel Prize in 2014. Any idea? Nobel Prize in the discovery of medicine. And she also shares the 50% of the Nobel Prize along with the two other scientists. Can you guess what is that medicine is all about? Artemisia salina. So it's the artemisinin derivative, which is presently used as the anti-malarial drug obtained from a plant source, for which she has obtained Nobel Prize in 2014 for her discovery in 1984 when she was an undergraduate student. At present, she heads the Chinese system of traditional medicines. So here comes the sustainability. When compared to the same discovery of a drug in 1984, statins, which is produced a 3 billion market over the entire 30 years time, in 2014, it was withdrawn from the European Union market, and most of the countries try to ban those drugs because of producing rhabdomyolysis or muscle weakness, which is leading to diabetes. Where is the sustainability now in research? The entire generation from 1984 to 2014. This is how the exact process of future scientist student should be. Whether it is the research, what you're going to do is sustainability, or it's going to just give you a revenue for that particular product. So those kind of social, sustainable entrepreneurship is the need of the hour. So with this short notice, let me go to the brief introduction of my today's topic. So I'm going to just throw you a highlight of how this zebrafish as a model organism can be taken for your research, how each and every disease modeling can be done according to your need, and how to integrate this in vivo models using computer tools, using your in silico studies, and for a few case studies of what I have done and whatever publications our team has produced, and how you need to align your research with SDGs, and last but not the least, the challenges and future directions for the upcoming student scientists. So now, introduction, the zebrafish. Why zebrafish? Why not others? So zebrafish shares 80% of the genome with that of the human disease model. How? So it has been emerged because the genetic, physiological, and anatomical similarities are there to the humans, and 70 to 80% of the human gene, which is responsible for most of the diseases, are correlated directly with the zebrafish, and 84% of human diseases associated genes are represented in the zebrafish genome. So same like the human database genome library, it has matched exactly with the zebrafish genome. And rapid development, because most of the stages of zebrafish, especially the starting 0 hour to the 72 hours, can be done without the institution animal ethical approval for developmental toxicity studies. So those kind of alternative approach is what is the need of the hour for sustainability. And organ systems like specific organ toxicities can be studied for zebrafish. And the most important point in this slide is exposomics. Exposomics is one of the important parameters which you should be aware of, because the environment with which we are exposed to has a most important influence on us. And those particular exposomics is directly correlated to our ecotoxicology. And this ecotoxicology starts with the organisms that is surrounded by us, and most importantly, the fish, and most importantly, the zebrafish. So that is the concept with which this particular zebrafish models have been developed. So coming to the transparency, so the embryos are most of the time they are favorable for performing any kind of examinations and external fertilization. Example, you can develop it in a large scale when compared to the other supply chain demand which we have with rodent models like mice or rat, and facilities of large scale and high throughput screening can be done at a very low cost. Suppose if I say if it's going to cost you around 1 lakh MYR for any research using mice or rat models, these kind of research using zebrafish and their setup can be done within 1/10%. I mean the 10% with 1000 RM. So those kind of research is possible when you do some kind of exposomics or ecotoxicological research with zebrafish. And moreover, it also requires less maintenance than rodents and allows easy observation in the microplate when it comes to developmental toxicity studies. And coming to the 3R, why sustainability and why we choose zebrafish is mainly due to the replacement of higher vertebrates, reduction in the number of animals used, and refinement of the experimental techniques. And moreover, the most important point is when you communicate your research paper to any journals, the problem what we face is the authentication of the work what we have done. And these kind of zebrafish studies can be videographed for a 10 minutes or 15 minutes simulation for the entire 10 fishes in a group, and each group can be identified with the tracking software. So there, the authenticity of your research value increases. So those kind of things is possible using zebrafish models, which is not directly proportionate in or possible in higher animal models. And compatible with live imaging and fluorescent markers is also possible in the zebrafish models. And apart from that, we also have high throughput screening. The complex behaviors and organ systems can be analyzed. So we have specialized in the neuropharmacological evaluation of zebrafish models, especially trying to evaluate its learning process, the memory process, the anxiety behaviors of the zebrafish. So translational relevance are there because we have the human mimic pharmacology and the 80% genomic match. And now coming to the scope. So as a pharmacologist, a basic life scientist, I just want to let you know that there are 3 models by which the disease can be incorporated in any experimental animals. The first model is the behavioral animal model. Each and every animal has its own behavioral evaluations by which it can be assessed. For example, a model of OCD, obsessive compulsive disorder. Humans, it is categorized as a DSM-4 or 5 classifications where you are producing stereotype-like behaviors. Whereas those kind of inducing agent is not required in animals because they have it in the inbuilt character. So those kind of behavioral animal models are more suitable to evaluate those kind of CNS pharmacology. The next one is a pharmacologically induced model. You try to induce a chemical which is responsible for producing a specific disease or disorder. And the third one is obviously the genetically modified, whether you genetically knock in or knock out a particular gene which may be responsible for a disease or disorder. So coming to that, it is possible to develop the various disease models in zebrafish, since we are trying to cope up most of the time with the neuropharmacology. We have developed few models like epilepsy, Parkinson's disease, Alzheimer's disease, behavioral assays, which is trying to correlate with each of the disease like Shaolin test, light dark test, T-maze, locomotion tracking. So which is directly correlating to measure anxiety-like behaviors, exploratory-like behaviors, cognition, hyperactivity, and how you try to correlate with each disease model is most important. And moreover, the validation part is necessary, but most of the times it has been previously done and it has been proved that this plays a crucial role. Now, coming to the my lab highlights where we perform. So we have performed novel tank test, predator avoidance, the showering test, the mirror biting test, the social interaction test, especially for the flavonoids that is produced from the natural products, which is a isolated compound, and which we try to expose it to the zebrafish. And then we try to identify the ADME properties, including the toxicity profile. And then we try to identify the physicochemical properties of that particular flavonoids. And then we try to do the network pharmacology analysis, where we try to correlate the target identified is matching with the ligand profile of the isolated compounds, which is most important in any disease model, because without the lead optimization techniques and the target identification techniques, you cannot correlate a structure or a ligand profile to a particular target. So you need to do that in order to validate your disease models at a computational level. So apart from that, there are also the toxicity studies which can be performed in zebrafish models, where we have the neurotoxicity, cardiotoxicity, hepatotoxicity, and endocrine disruption. Most of the times we have come across the endocrine disruptor chemicals which we use in our day-to-day life. And most of the time, you know what is the endocrine disruptor chemical present in this bottle? Can any one of you let me know? You'll be traveling with this bottle in your car, keep it in fridge, take after 2 months, 3 months, drink it for some perspective. Can anybody let me know what is the endocrine disruptor chemical present in this bottle? Sustainability, I'm speaking about sustainability. Any idea? Bisphenol A. So we have bisphenol A, the endocrine disruptor chemicals, which is trying to produce the microplastics, as I said. So those kind of exposomics, knowingly or unknowingly we are getting exposed to it, can be evaluated using these kind of disease models. And there are accepted test guidelines according to the Organization of Economic Cooperation and Development under the ICH, which has been proved that these kind of exposomics can be performed under 203 guidelines. So we have been focusing for experimental testing chemicals under 423, 420, 407, 408. But we have forgot that 203 is directly correlated to 423. So those kind of sustainability is more important when we perform this kind of research. And apart from that, the embryo toxicity assays, the behavioral biomarkers, and last but not the least, integrating your research with in silico tools. That obviously is the AI correlation. So you need to predict and validate your disease model with the ligand and with the target selected in order to get it to the next level. So we have more research being performed. I just try to produce few of my research publications. And the concept of computational combination with the zebrafish research is put it in a nutshell over here. So you try to identify an active ingredient and discover a particular compound, which may be a natural source or marine source or a allopathic drug, or you synthesize it in your chemistry lab. And next, you try to identify the bioactive substance of the TCM, and you try to develop a new drug. You try to identify the toxicology and safety. You need to test it for the mechanism of action. So morning I was remember or recollecting a topic, a drug which has its multiple targets on any of the mechanism of action it produces. Yeah, definitely. See, when you take a drug, the therapeutic index is directly correlated to the targeted receptor enzymes transporter ion channels where it acts, and you try to desire a therapeutic effect. But when it comes to the pharmacological action, it also produces the adverse effects and the side effects in other organs. So obviously that can't be reduced, and the dose can be adjusted like salbutamol. If you give it in higher dose, it goes and acts on your heart. If it gives at a lower dose, it acts only on your respiratory tract. So from cardio toxicity to bronchodilator, the action varies depending upon the dose. So those kind of correlations can be studied with the mechanistic approach when you try to identify the active ingredient along with the drug mechanism using network pharmacology analysis. So, and moreover, when I speak about sustainability, I'm more worried about the side effects and the adverse effects rather than the therapeutic effects. There, the narrow therapeutic index drugs comes into play. So using this integration with network pharmacology, we are able to correlate the ligand what we evaluated in the zebrafish model in the computer model, and then we go for the docking where we try to predict the binding site and the target site, which most of you will be doing, and then your dynamic simulations where the stability of the ligand and the target is identified at a few nanoseconds level, and then you go for the ADMET profiling. So there you comes the absorption, distribution, metabolism, excretion, toxicity profiling, which most of you would be doing that. And next, so how you integrate it? So you need to have an AI-based machine learning integration where minimum 8 softwares are used for this network pharmacology analysis. So I would like to post few things, right? So we have ligand, thousands or lakhs of ligands which can be obtained from the PubChem compound database. And next we have the targets that can be identified from the gene cards. Using Venn diagram or software, you try to take the ligand, take the target and identify which are the compounds that is correlating. Then you go for the ShinyGo software where you try to identify the Keck pathway analysis, giving you a mechanistical approach for the particular disease or disorder what you have chosen. So at the end of the day, you have the various mechanisms that is correlating the ligand with the protein structure. So there, it gives you an idea of exactly what mechanism and through what target the ligand is going to produce the particular action. So this is the Animaze video software, so which is freely available and with which we have tracked most of our research papers. So this is how the tracking does, and this is a Shaolin test, the time spent in the lower model, the middle layer, the upper layer, so which is trying to exhibit and give a clear picture or pattern of an authenticated data for your ligand. And this is how the tracking software works, and this is how the labeling is done, and this is how the reading or the recording of that particular zebrafish is getting evaluated. And coming to the case studies, so this is one of brine shrimp lethality assay which we have performed in our lab, and this IC50 was evaluated using the thing, and these are few papers which we have communicated with most of the collaborations from international collaborators. And obviously many scientists put their ideas because each and every patch here are correlated in one way or the other to get the best outcome. And if you see here, it is going to be the bisphenol A. We are working under the exposomics or the environmental toxicology, but these kind of induced models are trying to play a major role, and how the standard drugs or the isolated compounds from herbs in one way or the other is helping in our day-to-day life. We are living a sustainable life, but still how indirectly without our understanding all these kind of bisphenol A's and endocrine disruptor chemicals, we are forced to have it. So these kind of studies is what we produce in a sustainable manner. And next, the bicalin, the another one, stress-induced anxiety behavioral models we started, and this is a part of a PG project which is being extended to the PhD, and we analyze all the parameters which is directly correlated to chronic stress, which is both unpredictable chronic stress as well as the acute stress. And then we have this being published in Frontiers in Pharmacology. So those presentations are directly correlated to this particular sustainable research where this bicalin was able to relieve the stress-induced anxiety behaviors, and it has been proved with the tracking softwares and the videos what we submitted. And last but not the least, even though you publish in a high impact research journals, one research always stays close to the heart, and this is from my country, the first zebrafish paper which he published in the Indian Journal of Pharmacology. So that it nearly took 2 years to publish this one paper for impact factor of 1, but still it is my close to the heart paper. So coming to the point, what is the outcome? I'll tell you the aim and objective of each and every student scientist over here, which should be the take-home message for you. So apart from that, papers, we have next moved on to the patents. And all these projects, papers and patents have come from the previous projects what we have got, the fundings what we have got. So we developed many patents, especially the design patents out of our lab, and we have a patent clinic. Patent clinic for each and every student as an innovation ambassador through our institution innovation council. If you have an idea, that product or that design can be converted into a patent. So from the patent, what has to be done next? So this is one of a product what we are trying to develop in the near future. So we found out of the studies done so far and approved CCSE models, experimental animals which are being used in our day-to-day life is completely banned in most of the countries. So now in this stage I created the advisors and board members for this particular startup, which we have received the starting fund, a minimum of 10,000 rupees for performing the VR-based experimental model, which is going to give you a clear picture of a 9D origin of each and every experiment. And the prototype of one experiment is going to roll out in the next 3 months. So in the near future, in India, in National Medical Commission and Dental Council of India and all the pharmacology experiments oriented subjects may have this kind of future projections or experimental animals in each of the pharmacology and pharmacy subjects. And coming to the 17 sustainable goals, so whatever paper, patent, product you try to develop, please try to match it with any one of the sustainable goals. And most of the research what we do in pharmacy or pharmacology or medicine is directly correlated to the good health and well-being. So the third one, and to most of the students we have the fourth one, because you always seek quality education. And apart from that, we need to always have the 17, the partnership for the goals. So whatever we do, there should be sustainability. And last but not the least, all this is basically correlated to the life below water and life on land. So these kind of correlations in all your research papers, patents, publications would try to improvise the values of humanity. And most of our research in one way or the other is directly correlated, and even to SDG 12, where we have responsible consumption and protections, and SDG 9, where we are trying to build industry, innovation or infrastructure, and challenges and future directions. So as I said, most of the studies, the challenges what we are going to face is new every time. It's not going to be the old, and we can't expect the solutions to be given by the older generations. So it is you, the younger generations, who can identify the problem and try to modify the problem according to your need. Every time technology advances, everything goes to the next level. But without your commitment, without your focus, nothing can be done. And last but not the least, we all are here for knowledge, skill, and attitude. But with this aim and objective of knowledge, skill, and attitude, please see to it you develop the wisdom. So if you develop wisdom in whatever you do, automatically that translational research will definitely go to the reach of the entire world. So with this short note, so these are the members from my lab, and I'm thankful to my principal, Dr. A. Gerard Suresh sir, who will be taking up the next session and who is a guiding or motivating force for all these kind of products, patents, and research publications, what we do in our entire fraternity. So with that, this is my contact, and most of the time I'm open to any kind of discussions through online mode at any time, especially for the students, because I've been there for the students for most of the time. So I know, as a PhD scholar, as an administrative profile, as a student who's trying to find ways and means to come up in life, definitely you would come to me at any point of time. So I'm there for you. So with this short note, I thank the organizers for the wonderful opportunity, and especially during this post-lunch sessions, I can see many of the faces sleeping. But anyway, thanks for the faces which were brightened and which were attentive to me, and thank you organizers for the wonderful opportunity.
Thank you, Dr. Srikanth, for a wonderful talk. So, do you have any questions to Dr. Srikanth? Yes.
Thank you very much for that wonderful presentation. But I have some concerns and questions. Okay, over time, we know that in preclinical research, animal models have been used, mice, rats, name them, cats, and after a couple of years, animal lovers came up, and all the issues with animal ethics start cropping up from every direction. And today, in most countries, you rightly said, do not allow the use of animal in research. The question is, you make presentations on the zebrafish in some set of some set of preclinical studies. What is the translational potential? Because that's one of the main aim in preclinical research. Because for mice, rats, the genetic similarity is about 85 to 90 something, about 95 or 97, depending on the source you want to quote. But the zebrafish only has 70 to 80%. So, and we do know as well that even with such animal studies, in certain kind of toxicity study, they do not correlate with human toxicity data. So, in terms of using zebrafish, what is the translational potential to human applications? That's my question.
Yeah. Thank you, sir. That's the question I was expecting, really, because whatever we do with the zebrafish as of now, all the research is already made translational. The concept here is translation in the sense it should reach the entire community, the larger population, so that it can be used in a various group of people, right? But whatever we have done is adding value to the translational research, because these kind of ingredients in one way or the other is present in our day-to-day life as a food. For example, silibinin, naringenin, it's present in the spinach, and the flavonoids, bicalin and other things. It's also present in the fruit what we had for the lunch. So those kind of things, we don't know that is naringenin, this is bicalin, this is silibinin, but we are using in our day-to-day life as food. So what the concept here we have done is to add value to the translational research, stating that these kind of intakes, the foods and other things, would try to activate the oxidative stress parameters, relieve it, and try to produce a immune system which would be triggering us in the future. So instead of an evidence-based medicine where the allopathic treatment plays a major role, we are most concentrated on Ayush. So Ayush is a ministry which is working under the Indian system of traditional medicines, where we have Ayurveda, Yoga, Unani, Homeopathy, Siddha, where the traditional system of medicines with the whole plant or a desired portion of the plant or a specific portion is being done in a specific formulation that will be administered for a specific disease. And most of the time, you know, what the concept of Ayurveda is, prevention is better than cure. Food as medicine rather than medicine as food. So those kind of things in a sustainable manner, if it is posted, so to live a healthy life is more important in order to take a medicine to live a healthy life. So that is the translational value which we already add to these kind of research, stating that these phytoconstants, instead of expecting these phytoconstants to be developed as drug in the near future, sir.
So thank you, Dr. Srikanth. Any
Yes, sir.
further questions from the audience?
Either they must have understood fully or they have understood nothing, sir.
I think they may have understood too much, maybe.
Sure, sir.
So thank you, Dr. Srikanth. I think it's a wonderful talk. You covered the majority of the areas what we can do with the zebrafish and pharmacological.
Sure.
So, and also you covered the talking, how we can do the various softwares to finalize the lead. And it's wonderful information. I think they're still digesting it. So thank you so much.
Thank you so much.
Thank you, Dr. Srikanth, for the wonderful presentation. We will now like to invite our organizing chairperson, Associate Professor Dr. Venkata Sureshini, and also Associate Professor Dr. Chin, to join him on stage to present the token of appreciation. Thank you, Dr. Srikanth, for the wonderful and insightful presentation. Very informative. So next, we will like to hand over back to Dr. Suresh to invite the next speaker.
Okay, so let me introduce the next speaker. That is Dr. A. Gerard Suresh. So Dr. J. Gerard Suresh, also in pharmacy and PhD and MBA, is an acclaimed pharmacy academician and institutional leader, currently serving as the principal of Sri Ramachandra Faculty of Pharmacy, Sri Ramachandra Institute of Higher Education and Research, Chennai. With over 2 decades of impactful service in pharmacological or pharmaceutical sciences and the public health system, Dr. Suresh has played transformative roles both nationally and internationally in pharmacy, education, healthcare, logistics, and pharmaceutical policy advisory. So Dr. Suresh academic distinction began with a university rank in B Pharm and junior research fellow during M-Pharmacy with the GATE examination of 91.3 percentile, reflecting early excellence in pharmaceutical education. His profound academic and administrative services has been recognized through the Best Teacher Award in 2010 by the Tamil Nadu Dr. MGR Medical University and Dean Special Award in 2018 for the exemplary academic leadership. He has contributed more than 150 publications in national and international peer-reviewing journals and co-authored several key pharmacy notebooks, textbooks, including Principle of medical chemistry and practice with the purpose a student's companion for community and hospital pharmacy internships. Dr. Suresh's global recognition and policy level contributions are underscored by his long-standing association with international development organizations, particularly the World Bank, UNICEF, UNFPA, and European Commission. He has served as an empaneled consultant to the World Bank, completing two critical assignments in Bangladesh in 2015 as well as 2020, focusing on the pharmaceutical logistics and essential drug assessment. His strategic evaluations for urban drug distribution systems, logistics, and reproductive and child health (RCH) and essential medicine procurement have informed policy reforms in multiple Indian states, including Andhra Pradesh, Rajasthan, Gujarat, Kerala, Madhya Pradesh, Orissa, and Bihar. These are all the states in India. And at the national level, he has served as a technical expert on drug procurement for the World Bank assisted ICDS project and Tamil Nadu's Social Welfare Department. Dr. Suresh also held leadership roles in the professional regulatory bodies, notably as a chairman and member of Board of Studies in the Tamil Nadu Dr. NGR Medical University for multiple consecutive terms from 2010 until 2018, shaping academic policies for pharmacy education in Tamil Nadu. As a thought leader within the international pharmacy community, Dr. Suresh actively participates in the global academic forums such as the International Pharmaceutical Federation and Indian Pharmaceutical Congress, having chaired the pre-conference workshop of the 64th IPC in 2012. His research primarily focuses on the design and evaluation of the novel chemical entities, particularly the treatment of tuberculosis, integrating synthesis, pharmacological screening, and translational applications. Dr. Suresh's dual expertise in academic excellence as well as international health system consultancy makes him a uniquely positioned global contributor to the field of pharmaceutical education and healthcare delivery. His efforts continue to inspire the development of ethically grounded, globally competent pharmacy professionals and health policy reforms of tomorrow. So with this introduction, I'm glad to introduce the next speaker, the Dr. A. Gerard Suresh, to talk on innovative oral thin film technology using vitamin C for tobacco detox, a non-nicotine based cessation approach. So floor is yours, Dr. Suresh.
Good afternoon to all of you. First, let me thank my organization, Sri Ramachandra Institute of Higher Education and Research, for permitting me to come all the way from Chennai. And very importantly, for Masa to have invited me in the first place, so without which the first one doesn't come. So I'm very grateful for the kind introduction. And from the introduction, you would have realized that I could have talked on so many other topics. And that was what I decided in the first place. But then I thought I need to have a look at what is the theme of the organizers here. And I had to speak something very innovative, and hence this topic. So this is a picture of my university where I work, of course, along with my colleague, Dr. Srikanth. Incidentally, this institution has given a lot of scope for several things in life, and one such thing is the RX Tech Pharma, which is a faculty startup which was made possible thanks to the kind of policies that we have in our country. So the topic is ascorbic acid-based thin film for nicotine cessation and detoxification. So this is the Faculty of Pharmacy within the university. They are all my colleagues there. And these are my colleagues, my co-directors at the RX Tech Pharma. So cigarette smoking, needless to say, is a major issue in many of the countries. So what does it do? Pulmonary thromboembolism, stroke, myocardial infarction, the destruction of tooth enamel, and congenital malformations in a pregnant woman. I think that's enough to say, and enough reason as to why we shouldn't be encouraging smoking. 6 million people quit smoking. That sounds good, but how they do it is the issue. By dying. So they give up their lives. So that is very unfortunate. Tobacco use causes over 6 million deaths annually. It causes social, economic, and environmental problems, especially in countries like India, and since I'm here today, we include Malaysia. And I will show you a global picture as to how serious this problem is in most parts of the world. Nicotine addiction is the main cause of tobacco dependence. We know a cigarette, apart from nicotine, contains coal tar. And these tar products are just as bad, are in fact very important insofar as the toxicology is concerned, but so also is nicotine. But it is the nicotine craving that causes the addiction. So nicotine is metabolized to cotinine. Around 80% of it is metabolized and accumulates in the body for several weeks. So it remains in circulation for several weeks, causing toxic effects, including cancer. For some time there was a debate if it really causes cancer, but take it from me, yes, we have proof that it causes cancer. There is no effective treatment, especially targeting nicotine cessation. So when we are talking of cigarettes, quitting cigarette, we are talking essentially of nicotine cessation. Okay? And current nicotine replacement therapies, what they do is they introduce more nicotine into the body. I think that is not so desirable, right? So you want the person to move away from cigarettes, you want them to quit cigarettes, and that is they are craving for the nicotine, but in turn you are trying to give more nicotine. So obviously that's not the right kind of a solution. So here is the wonderful big map. You can see in India, 27.2% of the population, and larger parts of Europe and China and the Southeast Asia, it is 44.1%. I know Malaysia is not demarcated here, but you all belong to the larger group of the Southeast Asian countries, and I think it's very appropriate that we discuss this topic here today. So this is a fairly bad scenario, and it needs to be addressed. So we see a huge global potential, okay, in terms of a solution. So what do we have now? We have nicotine replacement therapies which come in the form of a patch which you can stick, or gums, lozenges, inhalers, and sprays. All these products will be supplying additional nicotine. And the common side effects: nausea, throat discomfort, gastric irritation, nightmare, difficulty in sleeping, insomnia, sometimes vivid dreams. Many of those who use these products are not willing to continue with this product, and therefore there is another issue. Even though there aren't the right type of a solution, nicotine replacement therapies, they are also not acceptable by many of those who are smoking. So the proposed solution which we propose is not about supplying additional nicotine. Our experience, that is what I am going to relate in, in commercializing a novel product for nicotine cessation. So this is what happens. When someone smokes, nicotine gets absorbed in the lungs and is distributed throughout the body. The nicotine is metabolized in the liver, and the main metabolite is cotinine. And the nicotine, here we see the nicotine is getting converted into cotinine. Cotinine can be detected in the smoker's plasma up to 8 weeks. Now, what we suggest is that if we are able to reconvert the cotinine into nicotine, that is, we will be recirculating the already available nicotine rather than supplying extra nicotine. So this is the proposal. So recirculation of cotinine to nicotine. Cotinine level was reduced and nicotine increased after 10 minutes of incubation, which I'll go into. So what is the problem or the need? No potential treatment for nicotine addiction. Current NRT, nicotine replacement therapy, provides additional nicotine to the body. And what is the opportunity? With a single intervention, we can treat smoking cessation or nicotine cessation and detoxify the effects of nicotine. So the proof of concept would be nicotine metabolite cotinine will persist in the body for several weeks. It can be recirculated by reducing agents like ascorbic acid. How do we go about it? So we brought out the details of our experimentation in this journal, Advances in Redox Research. Actually, it's the official journal of the Society for Redox Biology and Medicine and the Society for Free Radical Research Europe, and affiliate journal of the International Society for Free Radical Research. Why I put up this slide is it is to inform that it has got a certain credibility. This journal has got credibility, and this is our publication. You can refer it. So this figure is about what happens to the levels of nicotine and cotinine concentrations after incubation with 1 micromole of ascorbic acid for 10 minutes in chronic smokers' plasma samples. So that is picture A, the graphical representation A is of the concentration of nicotine. So before you treat it with the ascorbic acid, it is low and thereafter it has increased. What we want is to recirculate the nicotine, and we can see that after we've added the ascorbic acid, the level of nicotine has increased, meaning that the cotinine has converted into nicotine. And if the cotinine has been converted into nicotine, then the level of cotinine should go down. And so before the treatment, you can see that it is high, but after incubation with the ascorbic acid, it has gone down. So this is the proof of concept that this interconversion is possible by the use of a very critical concentration of ascorbic acid. This had drawn a lot of media attention, and for a startup like us, that is very important. That is the Tamil language. It's also my Tamil language. So the solution actually is about delivering how the ascorbic acid is to be delivered. Okay, you know, ascorbic acid is not very stable. So the challenge was in delivering the ascorbic acid in such a manner that we would be able to ensure that this transformation takes place. So we made a thin film, and 100% of the ascorbic acid was released in less than a minute. To be precise, in less than 30 seconds. So we filed for a patent and obtained the same, and we've also, that is the Indian patent, and this is the filing with the WIPO patent. During this study, we realized one issue. Of all the volunteers, we realized that there was kind of inconsistency in the results that we obtained. In the instance of 3 individuals, we realized that this conversion was not exactly happening. And why was this? We needed to explore. So it's worth noting that 3 out of the 25 selected volunteers who consumed BD is a very raw form of cigarette. I mean, it's not exactly a cigarette. The tobacco leaf itself is rolled and it is smoked. That's called a BD, or other high tar containing tobacco products. So we need to make a distinction between what is high tar content and low tar content. The low tar content cigarettes are invariably designated as light. So behind the name, you will find the word light. Okay. So we realized that this conversion does not happen for those who are smoking the high tar content cigarettes. Okay, so why is this so? This is something which we needed to probe. So, obviously, oxidative stress is an important matter, and these are the 3 enzymes that are involved: superoxide dismutase (SOD), catalase, and GPX, that is glutathione peroxidase. So we wanted to find out as to what is happening to these enzyme levels. We have got results. I'm not disclosing the exact figures, but I will let you know as to what has happened in general. So the study is to investigate the role of antioxidant enzymes in the conversion of cotinine back to nicotine using human plasma. These are the 3 objectives: the impact of smoking on antioxidant enzyme levels, comparison of the effect of smoker and non-smoker on antioxidants, and comparison of the effect of high tar and low tar in smokers. The sample size was determined with the population size of 95% confidence with 95% power. A sample size was determined. 24 volunteers for each group were chosen. Group 1 of healthy volunteers, meaning who are non-smokers, that's healthy volunteers. Group 2, chronic smokers who use high tar content, N equal to 24, and chronic smokers who use low tar content, another 24. So this was the sample size of the study. The finer details are here. This study received the ethical clearance from the Institutional Human Ethics Committee of Sri Ramachandra, and that is our ethical clearance. So volunteer screening. So what happens is, for those who are smokers, we determine the carbon monoxide level. So invariably, the carbon monoxide levels in the exhaled air, breath is more in the case of the smokers as compared to the non-smokers, and it is much higher in the case of those who smoke high tar content cigarettes, and lesser in the case of those who smoke low tar content cigarettes. So the volunteers were screened using a validated and structured proforma. The screening was conducted in South India, and where the participants were interviewed to determine the type and brand of cigarettes they used. That is to find out whether they are smokers of high tar content or low tar content cigarettes. And the exhaled carbon monoxide levels were measured using a validated analyzer, which is called the PICO here. PICO. Then the inclusion criteria: chronic smokers consuming greater than or equal to 5 cigarettes per day, volunteers with no smoking habit for the non-smokers, and those with carbon monoxide levels lesser than 3 ppm included in the control group. Participants aged 18 years and above of both sexes. The exclusion criteria was occasional smokers, pregnant women, and individuals who had consumed alcohol in the last 24 hours. So this is the study design. High tar content means greater than or equal to 10 ppm. Low tar content means greater than or equal to 4 ppm, and control less than 3 ppm. So this is how the volunteers were recruited and divided into groups. So this is what we were able to finally recruit. We had around 81 volunteers, but it's not that everyone could be included in the study. And we had smokers, 21 smokers and 23 low tar smokers and 28 non-smokers. So I said I'm not going to go into the details of fine details of the enzyme-based study, but this is what happened. For smokers who used the high tar content product, carbon monoxide level was high. For those who smoked low tar content product, their carbon monoxide level was increased, but not so much as that of the non-smokers. The percentage carbon monoxide hemoglobin was high in the case of high tar, and it was a little lesser in the case of low tar. Catalase enzyme was decreased in both the cases, but the SOD and GPX was increased in both the cases. The nicotine to cotinine ratio before the incubation was low in the high tar, and it was high in the case of the low tar. That means more nicotine was there. And in the post incubation, it was low in the case of the high tar content products, and it was low in the case of the high tar content and higher in the case of the low tar content products. So what we conclude: cotinine can be converted. Yes, we proved that, back to nicotine using specific dose of ascorbic acid. The conversion is not happening in the case of those who have smoked high tar content cigarettes, which means it won't be useful for them. No point in them taking it. The impact of high tar on levels of antioxidants, there is some impact, but we are not yet clear about what is the type of impact. We are not concluding on that. We will be doing so soon. A fast dispersing thin film has been formulated which can deliver the required amount of ascorbic acid within the given required time. An Indian patent has been obtained. We are looking ahead. We aim to build strategic partnerships for clinical trials and large-scale production and distribution, bringing this health-based focused innovation closer to benefiting humankind. Dual action solution for nicotine cessation and cotinine detoxification. Scalable, fast dispersing thin film will ensure accessibility, and it addresses a critical health gap in developing countries. Supported by the Indian patent and pending international patent for commercialization. Okay, anyway, ideation. For all the glory of Archimedes, I'm not the person in the picture. When Archimedes said he got an idea, he shouted and ran on the street saying Eureka. But anyway, we have a team, so I'll put it presently on the guy who's not here. So that is him. So this is the proof of concept. It's about the IPR filing. We have a company that is registered. We are looking forward to making dollars, millions of dollars. Okay. So thank you all. I know every speaker has a great challenge at 3 p.m. or any time around that time. You know, it's the postprandial stupor. We fight against that. It's understandable. So thank you all for the patient listening.
Thank you, Dr. Suresh, for a wonderful presentation, so informative in a different direction and a sustainable development goal. So I would like to ask audience any questions from you?
Thank you, bro, for your wonderful presentation. I think ascorbic acid is vitamin C, right? So here, many people I have observed, they were using vaping. Vaping is also one type of nicotine, propylene glycol, and different constituents. So whether the vitamin C, why? Because many people here, they were taking vitamin C chewable tablets also they are taking. Whether it will be effective for them, or some of them vitamin C they are taking after smoking.
I tell you, actually, what we realized is that 1 micromole concentration seems to be the key. Okay, at higher concentration it doesn't seem to work, or lower concentration. We are sub-therapeutic for this.
And also, Prof, like our medical students, they are interested to collaborate. Already we have MOU and collaborate for in silico activities as well as medical school. Also, if we have any collaboration in future, it will be helpful for.
We are open for all of this, and perhaps that is why we are here today. We carry home the idea to our bosses, and I think we can see something through. Yes, please.
Are you shy? Thank you, Dr. Suresh. Looking at the topic, innovative oral thinking technology using vitamin C.
I'm not able to get it.
Okay, can you hear me now? Okay, so I said, looking at the topic, innovative oral thinking technology, right? So, looking at that topic initially, I was expecting to see maybe a formulation of vitamin C and also the test of vitamin C. Maybe are some dose that you did test on in order for you to be able to determine at what concentration, at what dose would have led to the conversion of cotinine back to nicotine.
Actually, we did a dose response curve experiment, and then only we decided as to how much would be required.
Okay, then the next question is vitamin C will be used to convert cotinine to nicotine. Now, as far as I understood, one of the issue with smokers is because of the addiction as a result of nicotine. So for how long will this conversion be sustained in order to keep those smokers and not going back to smoking using this your strategy?
So, okay, it is a slightly larger study, okay, where we will have to find out this entire cycle, okay, because cotinine will remain in circulation for even up to 8 weeks, okay. So the work is underway. We will soon arrive at that.
Excellent presentation. My name is Rohit and I'm a student from Master University. I'm just curious, how does your vitamin C compared with non-nicotine drugs that are used for smoking cessation like glucophreon?
Can you repeat?
Okay. There are some drugs in the market today like glucophreon, which is a non-nicotinic drug that is helpful for smoking cessation, and it has been approved by FDA and is currently being used. So I'm just curious, like, how does your
No, we have not done a comparative study. We have not done, and maybe I can't tell of that.
Okay, I have another question as well. In the start of your presentation, you said that nicotine has negative effects in the body.
Yes.
And going on, you also said that the vitamin C converts it back into nicotine. So wouldn't that also
Yeah,
cause more
but
bad
yes,
effects to
the point is the smoker has taken the nicotine. Okay. Now I am not adding new nicotine. Okay. It is only the same level of nicotine that is being recirculated. So either way, the quantity. Only thing is now he will not be smoking more and more. His addiction for smoking. If he had been smoking 5 cigarettes or 10 cigarettes a day, now he might stop with 1 or 2. That is the point. His urge to smoke is reduced, therefore the concentration of nicotine will be contained.
Thank you very much.
Thank you all.
Firstly, please give the token of appreciation to Dr. Suresh. Okay, thank you, Dr. Suresh, for the wonderful talk once again. And the next speaker is, I think all of you know, our dear beloved Professor Ali. So I think even though you know, let me introduce you with what his achievements and which you may not know everything. So what he's doing. So let me introduce Dr. Ali. It's my privilege. So he is a Deputy Dean, Head, School of Emergency Medical Services and Science, FOH NSC, and Head of Department of Emergency Medicine, Anesthesia, Critical Care, Faculty of Medicine. And he is the director also for the Massa Center for Clinical Skills Education and Training.
Thank you. Thank you. Yeah. So, for want of time.
Okay, so let me say, introduce my beloved friend and colleague, Associate Professor Dr. Haji Abdul Ali bin Raja Muhammad to talk on Internet of Things, revolutionizing emergency medicine. Thank you.
Thank you very much. First of all, thank you very much. Assalamualaikum. Salam sejahtera, selamat petang, good afternoon. Yeah, thank you very much for being here. Although I'm a bit disappointed as usual, only 30%. I'm saying that because the team is here. So I can call all up. Yeah, so topic today we have chosen is this Internet of Things. Why? Because it's a medical science and technology conference. Okay? And the Internet of Things, especially in emergency medicine, which is my specialty, and how it revolutionizes your whole of the medical practice itself. Yeah, so it's important, yeah, that you would want to be, yeah, listening to this. One, emergency medicine, define. We'll define first, yeah, we make sure our mind is very clear. Emergency medicine, yeah, it's been defined, yeah, it's an immediate decision making and action necessary to prevent death only further for any patients in health crisis. That's a key word, health crisis, not anything else. Yeah, it's a health crisis. It's a patient demanded, and it's 24 hours. Anytime, day, night, 24 hours, and it's a time-dependent process of initial recognition, stabilization, evaluation, treatment, and disposition. Yeah, and of course, yeah, it involves also not just the hospital building in which the ED is there, but it also involves the ambulance services, the emergency medical services, as well as disaster management. Yeah, this is the emergency medicine. So this is a problem. Yeah, the problem is this: we have got to be always efficient. We have got to always have good outcome. We must have patient safety, and we must save lives. This is the issue. Yeah, and you would note this next 40 minutes or so, this Internet of Things has dramatically changed this. Patient safety is the one of the first 5 causes of death in any country. No death. Yeah, always include medical errors are one of the 5 causes, which most governments want to avoid. Yeah, so once you have this issue, yeah, then this is since the time modern medicine has been practiced. Yeah, and so this is where our IoT comes in. How to make what? How to make sure that we are more efficient, and how to prevent this death. Yeah, and this IoT, what does it mean? It was actually invented by this man, Kevin Ashton. Yeah, he is an engineer, technician, yeah, and with the MIT, yeah, data on the internet that are connected to evolving global civilization. What does it mean? A network of physical objects, devices, vehicles, buildings, and other items embedded with sensors, software, connectivity, which enables these objects to collect and exchange data. Yeah, for what purpose? To interact with us, with you, with me, yeah, with the humans itself, and for what? Yeah. Once you have these interconnected devices, so that you can assist in sorting out our lives. Yeah. So I heard this some time ago. All these words, Internet of Things, purpose-oriented, network autonomous sectors, yeah, FLA, and these are all a lot of words, and a lot of new words are coming now. Yeah, that is Internet of Health Things, Internet of hospital things, Internet of many other things you can call it, device to device, machine to machine, wireless sensor network, and 5G. That's the latest as it is. Yeah, so once you discover this, then we need to see how best it works for us. Yeah, I learned about this, this issue, how it helps us is this. Yeah, it's an endless ways. And this is important for you because you are the next generation. Yeah, and this is where maximum amount of research. You have seen these past 2 researchers have told you how simple things can be done very well, elegant research. The same thing here, yeah, it will reduce cost of care, it will reduce human errors, yeah, any distance, wherever, next door or thousands of miles away, you can connect, yeah, reduce amount of oil, you can need to have to cut down many trees, yeah, diseases, both chronic and acute, can be detected early and improve medication management, yeah, need the prompt medical care, and you get better outcomes. This is what we all want. This is what you are learning for. Yeah. So while doing that, yeah, this is it. You, not his, not me. Prof, we are another. Yeah. 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 You will be involved in all this. And you have already started. Yeah. So when you are doing this, then it's important for you to understand that revolution. What does it mean, revolution? That means a radical change. You will have to make the radical change. And you're going to do, yeah, in complete change in the way we practice medicine. Yeah. And we are going to see how this practice can be changed. Yeah, I'll show you 12 scenarios, current scenarios, where you can make a change and make the world better place. Yeah. So I learned this Internet of Things way back in 25 years ago. Yeah. When I was building this trauma center, I met this grandfather of emergency medicine, the authority in the world. And we had a fantastic 4 hours with him. And he said, when you are building this, Ali, make sure that IoT system, see that the IoT was out only in 1999. He has already said, please make sure you have built it into the system now. This hospital, this trauma center was built 20 years ago. And it will still be effective for the next 50 years. Why? Because this is one of the stand-alone in this part of the world. There are only 3 similar trauma centers in this world. One of these is this. That means, yeah, you can have, you've got fiber optics laid down, you can have 100 cases, ventilated cases at any one time on the ground floor, from pediatrics to adult. Yeah, you can helicopter can land. This is only, yeah, in this part of the world, a helicopter landing or drone for yourselves. Yeah, this is the only one in this part of the world. Not yet. Yeah, so when you are looking into this, you need to see how to build what? Improve patient outcome, streamline process, and enhance the efficiency continuously. Yeah, because we are working in this environment. Times and the situation, limited information, complex logistics. Yeah, and so the Internet of Things will give you real-time data, will give you remote monitoring, will give you automated systems. Yeah, so we're going to see in 12 scenarios currently that is happening in Malaysia and many parts of this developing world, yeah, so that we can make a change. Yeah, number 1 is this. Look at that. This happened in Sungai Petani. This man had a chest pain. He actually had a myocardial infarction at 12 midnight. He went to the emergency department, waited for 6 hours until he collapsed. And he died. Yeah. This is in a developing country. During my time, when I'm a houseman, yeah, when this is going to happen, oh, so sorry lah, we can say. We are also busy, we can say that. But not now, in this age. In this age, this man should be alive today. Yeah. So how can the Internet of Things that is happening around the world, yeah, this is a problem. Poor triage, poor history, poor exam, poor management. How can what is happening in the other part of the world. This, this how internet is. This, you see that? This is in UK. This is in 14 years ago. They have already got you got a number, you got two numbers, one for emergencies, your police or bomber or whatever. You see that one called integrated urgent care. That means you call them, whatever your problem is that will affect your life directly, they'll assist you. That means if this system were there, that man would be alive and so many others would be alive. So this system, is a very simple system, an IoT system. The nurses are trained. It's a dedicated hotline, interact with them, not 999. If you call 999, you know who picks up the phone? Telephone operator. The Auditor General has said 90% of 999 calls are not answered. Do you know that? Know that. Why? It's because of this. Because you do not get the correct information. So this dedicated hotline interact with this thing and uses AI. AI assisted learning. And you see the appropriate level of because it's an educated person. You are going to reduce all these situations. See the problem. When you are looking at it in this way, then you need to understand that our EMS systems and many part of the developing countries, it's not good. Not good. See this here. Since 1995, now it's 2025, 30 years. It's not good. You see, this is in 2020, 84% delayed. So, how are we going to sort it out? By the Internet of Things. How can you do that Internet of Things? This was raised actually in the Parliament. This was raised in the Parliament. What is happening to the ambulance call? And this is a minister who have answered. He said, out of all the whatever, 8 went to hospital. After that, nothing. How many came out alive? You see that? When I mean by alive, statistically, I come out alive, I must be alive for the next 1 month. That is what good outcome means. You see that? 8% does well. How many came alive? There's a problem. Internet, how is it going to help you? This predictive triage. It's already there in many countries. There's already Internet of Things. It's already there with the machine learning and AI. You can analyze patient data, vital signs and all of that, and provide to the operator what to do. So that the operator will not be that, will give him the confidence about what he does. And in our ambulances, none of these are connected. None. They're not connected to the center. Therefore, what you have, you will have poor outcome. And this is, the poor outcome. See that 2015, for the past 10 years, we already know what all the problems are. We already know, nothing new to discover. And we already know this time-sensitive chain of survival. We already know it, how to go about it. And all over many very developed countries, they have already proven this very good, excellent. Just to show you this, these are all Internet of Things. Can be sorted out by Internet of Things. Why? Because this is a textbook and not a research. That means once it comes to a textbook, it is a standard. That means if you go to the court, if you fail, the lawyer can bring this textbook. My lord, look at this. This doctor is useless. He can die say that. Why? Because it's already been truly been established that if you do not do a high quality CPR, if you do not defibrillate in the first 2 minutes, you're going to die. See that you're going to die. Every minute delay, you lose 10% chance of survival. That means our hospitals that come to us, or rather the patient come to us by ambulances, where nothing much has been done, zero survival. See that? Yeah, but the Internet of Things will allow you to do this. How? Number one is, if you go to 3 countries, in Norway, Sweden, fantastic, because 95% people know how to do bite center CPR. And Germany, 80%, Singapore, 60% know how to do CPR. What does that mean? That means they're all interconnected by the IoT. So look at this example. This is Stockholm. If you are in Stockholm, Prof. Rosley is going there on a holiday, he collapses or faints down, immediately a phone will ring. So nearby, their phone will ring. Go to such a place, somebody is lying down on the ground. So he drops this thing and runs to this to manage a patient. And then the second way, there is a man who is fainted, get the AED. The second man will rush, search for the AED. And he says, I can't find the AED. Okay, no problem. A drone is on the way. Start the chest compression. Drone is on the way. See that? Within 3 minutes, chest is compressed, defibrillated, and you get good survival. See, and that's the Internet of Things. So you need to know what is happening around the world. Be able to appreciate your ability to manage. And this AED, as we call, it's there everywhere in the developed world. Right down even in the top deserts, you have got Spain, all the tourist areas, park. You've got in the clothing store, you got the airports, government buildings. Many of the phones in London have been changed. UK changed to defibrillator, as well as alcohol store. They all, wherever a patient is expected to collapse, there's already an AED. So that you can manage in appropriate way. Look at this, Malaysia, 2024. 1 year ago, he says, hey, ensure AED is for all. Where got AED? You see the problem? In this campus, there is 1 AED in every of these buildings. You are safe here. But not anywhere out of these walls. So where is this Internet of Things? That's case 4. Currently happening. What is happening? If you were to ask, if a patient is in the ward, why? If the patient is in the ward, why does he collapse? You see, the patient is in the ward, why does he collapse? I want to listen to this story of this girl. This girl was a MASA MBBS student. After the housemanship, I was going to Selayang Hospital, Seranda Hospital, and she came, prof. I went to okay, prof, and she started crying. She said, every day I'm on call, I'm doing CPR. Look at that. Every day she's doing on call, she's doing CPR. That means the quality of care is not good enough. Why? Because it is clearly established. You can go to B&J. Why do patients collapse? They'll tell you 70 to 80% of the patients have already developed the signs and symptoms. It's already there. When 8 hours before the patient collapses. If the patient now says, I can't breathe, that means 8 hours ago, he is already there where the Internet of Things can develop, can be managed with it. Yeah, remember this. In your study, in the first year, second year, you must already know the cell, especially the brain cell, it dies by the seconds. When there is no oxygen, even for 3 seconds. Glucose, 1 hour. Yeah, it dies by the seconds. Therefore, when you are doing this, then you've got to appreciate the role of this. This is already developed. Look at 2012. It is a standard practice in UK. It is called the National Early Warning Signs. Everybody must know this. Nurses, everybody practice. The charts are there, and everybody is prepared, is alert to this. Yeah, if this can be extrapolated to the Internet of Things, how easy it is. The machine will alert to you 6 hours before the patient collapses. You see that? Yeah, and you will come to learn in year 3 that these 7 are called as the vital signs. That means the measurements of the patient, objective measurements of the patient. Therefore, when you are looking at this, that's where, this Internet of Things, AI, machine learning, all this has been brought together. And be able to enhance your diagnosis, enhance your decision making, enhance the algorithm, give you better and better images with 99% diagnosis. Look at that. And that's where your biochemistry machines and all of that will be able to diagnose all these common diseases where men fail to detect. When you fail to detect. Therefore, this is where huge amount of research is being done. The next thing is, of course, remember this, remember this, where when a patient comes to you, he knows about his problem. Your generation. So they will be coming with the smart wearables, smart devices, that can measure all these vital signs. If a real-time data, if a fall is detected, it's so very easy. And there's machines that are developed to be able to predict and prevent critical events. A patient says, I cannot breathe. In your time, he knows what his problem is. Therefore, you need to be got ready. In 2017, their side is a CEO of Amazon have already said this is an incredible platform. They are already selling it so cheaply. And just 2 weeks ago, this was already there. Apple Watch, they can measure all this. Maybe some of you are wearing it. But the problem is you are wearing it. It's not connected yet. Because you need that connection so that the data can be interpreted out. And somebody does something about it. So, and see, for example, an elderly individual, if you're connected to, say, now many specialist hospitals have connected. Many of the private special hospitals, they are connected. See, if you have to fall elderly, immediately, that the watch will detect, and his blood pressure, his ECG, and all that blood sugar levels are already transmitted. We already know. Now we are going to have high quality treatment, and purpose treatment. So, these wearable systems, wearable body area sensors. Constantly 24 hours is getting connected by the various gateways. And once the data is interpreted through the cloud, without limitless cloud, you are going to get good decisions. And when you get good decisions, you need to make good decisions. Like this, case 5. We often have this problem. Too big a crowd. There's no necessity. There's no necessity for too big a crowd, because if you have the Internet of Things working, that the machine will continuously tell you what to do. And it's a huge cost. Millions of dollars are spent, wasted. Look at this. There's no record, resuscitation record missing for 1.5 hours. How can that happen? See the problem. How can that happen? And you can see this. Doctors do not know how to manage the airways. How can that happen? Because of decision making. Because these important data needs to be contained. And how to contain that by Internet of Things. You can have patient biosignals, real-time data collected, processed, stored, or retrieved, analyzed, integrated, and alarm can trigger anytime and ensure good quality care is provided. These are all the functions of the Internet of Things. And when you are looking at this, then it is important to realize there are many of these more to come by the time you pass out. By the time you become houseman, all this will be automated to you. All this, right off body temperature, recognize blood glucose, hemoglobin, respiratory type, even the environment. How much of oxygen was there? How much of carbon dioxide? How much of carbon monoxide was there in this hall? It's already given to you. It's already given to you by these various sensors, that are there. These various sensors by what you call big data bandwidth. They've got huge. They collect continuously. They aggregate. They classify. They analyze the data, and of course, decisions are advised to you. At the end, you need to press that button. You need to press that button, and you need to know how to press that button. So once you're looking in this, this is what happened during COVID pandemic. For 2 years, it was fantastic for emergency medicine because we know how to manage patients from distance. We started creating excellent focus machines. We call focus, point of care ultrasound machines. They can straight away all go to Robert Bush's, put it on top, you got the diagnosis. This was already tested in China. Many hospitals have already tested it, and they're all going to be marketed soon. And here you have got fantastic ultrasound machines that can give you 99% correct diagnosis. Now, maybe you have to do a laparotomy now. Not necessary. And then you got portable ultrasounds using your handphone. Download the software and then put the machine on top wherever you want. You already make a diagnosis. There's no need for to palpate the liver, the spleen, and all those things. Kalai is upset because he learned so hard how to palpate the liver and the spleen. But for you, it's a reality. So you need to know how to, depending upon the cost. So you need to know how to use these machines. And then of course with the cloud machines, it gives a huge opportunity to develop the technology and facilitate high quality and perform what we want. So these are all the networks are already there, and these are all available now, currently available. And once you got the gateway and you can get all this connected, IT people, people are clever here in this hall will know how to go about it, and this is real. And this, we have already seen some examples. The tailored treatment. In fact, right now, in the next 70 years, there won't be heart attack. That is in the Western world. Here we are still learning. Because we have identified what the problem is. We prevent it here. and we have got no problem here. This year, way back in 2017, MIT is already researching on this. Yeah, so this is very clearly evident. Yeah, that your risk stratification is constantly studied, and the Internet of Things are looking into that. Yeah, just a simple drug. This is a drug we have been using for 70 years, adrenaline in resuscitation and the various activities. Yeah, and how do we know? It was tested in 100 dogs 70 years ago. Yeah, 1 milligram, 1 dose, and we are still using this. Now we are going to, a lot of research is going into various drugs now to personalize your medicine. Yeah, so your prescription will not be standard for all patients. Yeah, they'll all be personalized according to the nature of your system. Yeah, this is by Internet of Things. After collapse, a patient collapses. Yeah, this is already there when, 20 years ago. Patient collapses, you reduce down the temperature to 32 degrees centigrade. Yeah, the patient has got an MI, it collapses, he's not cautious, he's unconscious, push him straight away into the ICU. You put him at 32 degrees centigrade for 72 hours. Resuscitate him. He'll come out well and nice. This is already a standard using Internet of Things in many Western, even Singapore does this now. Yeah, here in GH care they do in a sporadic way, but this should be a standard for all patients. See that? Yeah, so the Internet of Things will assist you in making very strong, good decisions. Yeah, as well as you've got goal directed now. You need to know what are the goals of management of this patient. Yeah, and the machines will tell you how to reach that goal. So it's a goal-directed pressure, ventilation, everything. Even hypertension is a goal-directed. Yeah. So it's important. Yeah, and that even resuscitation itself. Yeah, you can see. Yeah, it is not just now we learn 5 centimeters, but not necessarily optimum rate, depth, and cycle. How? By studying that patient, by scanning their heart, by knowing what is exactly happening to the patient. We tailor to the patient's needs. Yeah. Therefore, you see, it's a dramatic change. What about trauma? We have got the highest in the world, one of the highest in the world. 7,000 die on our roads. Yeah. And Internet of Things can change that. Yeah. For one, that's recently just a few weeks ago. Yeah, you had 15 students. Yeah. Your colleagues maybe died. But why should they die? That's a question. Why should they die? If you apply the Internet of Things, they need not have to die. For example, this is way back in 1983. Yeah, I was trained by Donald Trumke. Yeah, this revolutionized why patients die. It's called, every trauma book will call this trimodal distribution. They die in 3 ways, simple, without very complicated. They die in 3 ways. One, they die straight away, brain crash, C1, C2 crash. But the rest of them, they die because of poor airway, poor breathing, poor circulation management, poor dysfunction neurology management. That means, these students, 7 of them should be alive. See the problem? Yeah, how is that? How is that possible? Yeah, how is that possible? Yeah, you see in Germany. Yeah, this is practiced in Germany. Yeah, when you say golden hour in Germany, there's got no speed limit, you can run as fast as you want. Yeah, then as soon as the accident happened, within 2 minutes, the police is there. 2.5 minutes, ambulance is there. Ambulance comes, assess the patient in 5 minutes, and they say, I need a helicopter for this tibia fracture. Not multiple injury, no, tibia fracture. I want a helicopter, and you are in the resusc room in the next 30th minute. I've seen that 15 years ago. Yeah, that and managed. Yeah, and the patient is out. Yeah, so these are Internet of Things. How this done is all by Internet of Things. Yeah, now you have got fantastic. It's being done now. It is tested now. Yeah, and of course, now we are looking into anticipatory EMS. That means, just like your anticipatory shipping. Yeah, so Prof. Suresh, saw the something on the, what did you see last in the Shopee? What did he check? A bag. He wanted a bag. Oh, very nice bag. He clicks it and stores. Immediately the bag is ready to be posted. It's already there. This is in the system. Yeah, if the bag will arrive, once you click, the bag will arrive in 24 hours. That is what is anticipatory. So the ambulance services are also going to do that now. It's already being done 10 years ago in many cities. As soon as it is predicted, the ambulance will move. Yeah, by the Internet of Things. So the drones, they are huge drones. AED, organ donation is being transported by drones now. Yeah, heart, lungs, liver, they're all by drones. Yeah, because you cannot rely on the flight. Yeah, and as well as you can see emergency supply trucks. This one we tested in all the disasters now. We use drones to transport. Yeah, and of course, disaster, pictures and all that we do that. It's already going to come. Yeah, all the major, Toyota, Honda, China, all the fellas are already flying cars. There's the first thing they're going to make is flying ambulances. Yeah, these people came just after COVID in 2022. They came and showed us. We went to see, my Australian friend went to see. They've already sold 100 of these to Indonesian millionaires. They already bought it. Why? These drones will support patients so very effectively. Yeah, so you have got connected ambulances and enhanced telemedicine. Yeah, so with using all this, they will be able to directly, and instantaneously you can manage patients. Yeah, and this is a, this was in Ireland, 1970s. They used to, man has got an MI, they fax, ECG fax and send to the hospital. Okay, start the that time it was streptokinase. Start the streptokinase. Paramedics are doing that. Now, straight away the video is shown. Straight away the handphone is put there. The ECG, you can put the handphone there. ECG is traced. Immediately down, okay, start. You see how fast, then your system works, because this whole of the internet connected system is there. It's for us to apply it. Case 9. Look at this. This is an assignment last week. This is an assignment last week, year 4 students. He did that. This is a history. He had left-sided body weakness on set one day, need assistance to ambulate, and then went to sleep. In the morning, presented with slurred speech and facial respiratory, gone. No more treatment already. It's already past the 1 hour limit, 3 hours limit, gone. Is permanently damaged. This is already there. How to manage is already there by the Internet of Things. Look at that. There's already how to diagnose, how to make decisions. And this stroke chain, 8 Ds of stroke management, it's already there. In fact, much more better. There are already ambulances with CT scan inside. See that? Ambulance CT scan inside. You push a patient, CT scan, immediately drug is given. how wonderful. That is what Internet of Things will do to you. Yeah, so you need to know how to apply. Yeah, and of course, this is human tragedy. Yeah, when the tsunami came about, we couldn't move. We wanted. There were 50 of us wanted to land there to assist. We were waiting for 4 days to move there. And by the time we arrived, I can still smell these bodies. Still can smell it. When you look at these images, 200,000 of them lying on the seashore. Yeah. And so, well, what do we do? What do we learn? And this was 2004. Now we have got fantastic ways of managing things by Internet of Things. Yeah, we have got Sendai framework. Yeah, we call that, and we have worked with many countries. To develop systems of this disaster cycle. Data research, flexible infrastructure, and quickly early warning systems. As soon as the earthquake starts, your handphones will ring, and straight away you run. And of course, your ambulances, monitoring hospitals will get ready, your ambulance will be mobilized. All these are already available. Drones will be sent, the pictures will be sent, portable. As soon as you land, you got a portable ultrasound. Very quickly, how to mobilize this patient. Myanmar susah lah sikit. They had a recent disaster. Many died because this was not available. These systems were not available for them. So this is a problem. In COVID time, we learned huge ways of managing because of the Internet of Things. We were able to do so well. And this is telehealth is something that came about. Telehealth was something that came about. Telemedicine is so huge in somebody. In India, it is a huge industry. It's not developed that well. In fact, it's only Sunway Medical Center has got the effective one. I remember in 1998 we started one telehealth within GHKL and Raub. It died a natural death in 2 years. So this telehealth is a huge industry which you can move because it's $1 billion business. See that? It's $1 billion business. And there are various systems telemedicine. I remember 10 years ago I met this guy who was trained in States, and then in Chennai, he was doing this. For whom? For various hospitals in South America, various hospitals in India, thousands of miles away. So these are all decisions you can make. 7 types of telemedicine, and then of course various apps you can use. All these apps are available. And of course then the case 12, last 12 is I met this lady. I presented to her. 14 years. This is the emergency physician. This is the standard textbook for all emergency physicians. I met this lady and he said, Ali, make sure you're always up to the best that can educate. But the problem is you have got 165 students in year 2. I've got only 30% of the class, right? You see the problem? So this is something. It's this thing. So internet. We are going into all this. This VR, AR. These are all being tested, already done. See that 2017 they are learning CPR by that method. This is going to come on VR, AR, and all that. Then of course, these are the challenges: data securing privacy, ethical considerations, cost accessibility, integration, interoperability. This is how various companies they need to meet the challenge. But towards the end, the human touch. That's where you have got to find your way of doing it. So it is important to realize yeah, Internet of Things, it has revolutionized. It's not something to predict. Yeah, they've got faster response times, improved accuracy, enhanced efficiency, better patient accounts with a reduced initial cost will be large, but towards the within 5 years it is a reduced cost. So this is where you doctors to be need to know. It's for you to seize the day. It is for you to seize the day. Yeah, and 60% of you are not here to seize the day. That's a sad story. This have never happened during my days. We always had a full class. We wanted lectures so that we can learn from the lecturers. Our previous generation. Why I'm saying is because this is the second time I'm meeting you. First time was a stroke class. The only 30% of you take a profile, sir. We hope we can shout and scream at them. Please buckle up your friends. Yeah, so that you will be able to learn the best that's available. Thank you.
So any questions to Prof. Ali? Prof, Internet of Things, as you mentioned, there's so much advances we have seen, which are what we have not seen so far also. So what do you think Malaysia and to what level in the percentage IoT in different?
In Malaysia, it is a business. It's a number one, it's a political will. Number two, it is a business. Yeah. Number three, it is the people. The people need to demand. Yeah. It's the people need to demand. If I got a class here, 60% are not here, how to demand? You see the problem that we face. Yeah. You need to demand. Because your world is passing by. If you say tomorrow is always there, that's no good. Tomorrow, you must be there, not the world. You see the thing? You must be there to vision your world. The world will always be here. Understand? Yeah? Yeah. Yeah. So you need, they said, this is the only thing that you need to do. Do no harm. But at the end of it, you have got to push the political will. Yeah? You have got to decide. Just a contoh, the trauma center I showed, it didn't come just out, just like that. Yeah, you didn't say that was built during Mahathir's time. Mahathir didn't say, hey, Ali, go and build this thing. No. We found the need. We found the ways and means about it. And we gave a promise, sure, in 6 years, you have one of the best centers in the world. And you got it. And it will still be the best center the next 50 years. You see the issue? Unless you wake up and demand, no, it will be just something else. We are great builders. Do you know that? Do you know that we have got money? Money is not an issue at all in Malaysia. We are great builders because I was challenged by the trauma center when I was in UK with the Donald country there. Yeah, there were about 35 emergency physicians. Yeah, one emergency physician, because when I put all the Internet of Things and all that there, he said, this one vision, UK for life, I still remember his face. Do you have money to build this? Because for them also it's alarming. respected professor, we have built two tallest buildings in the world. That time the twin towers were already built. This is another challenge. That's all. So money is that it is for you to decide what you want. If not, you'll be just another doctor. You see that? Your ambition should be good doctors, good inventors, good people that will save lives. If not, then who are we? Why learn 5 years of MBBS and I'm a doctor, like Chawan?
So thank you, Prof. For wonderful session, inspiring. So I would like to request Prof. Rosli to come and give to Prof. Ali a token of appreciation and souvenir, please.
So thank you to all three keynote speakers for their knowledgeable and inspiring presentations, as well as to the chairperson, Associate Professor Dr. Suresh, for hosting this session. We will now go for a quick 10-minute break. Please help yourselves to some refreshments outside to your right, and we will resume for the second session of oral presentation in 10 minutes time. Thank you.
Jonathan. இல்ல ஸ்டடி ஏரியால பிக்கப் போயிருக்கேன்.
You're going out, right?
It's over, right?
No, we still have like oral presentations.
Everybody go back already?
Huh?
Guys have to balik already, right?
Who? They're leaving the oral presentation. I mean, post presentations.
I guess I'm leaving. I need to go print the poster now.
Yeah.
Hey, my sleep put me here and I'm like, okay, I should be off for faster. I don't come back here anymore.
Some of them already prepared.
It's me. I've always been the last minute.
Have coffee. Yeah. Whoever gave me last time. Okay. Yeah, just copy and paste.
Copy and paste.
Yeah, you put it here and because the presenter will be presenting. So all the authors. That's all you recorded everything.
It's okay, right?
You have to finish in 7 minutes.
That's what I
Yeah,
thought.
that's all. Everything is
I just put in the date and I submit it, right?
yeah.
I just
Yeah.
Shilling? Is Shilling Esther here?
Dr. Samra. Where's your pen drive? Where are your slides? Already gave, huh?
Oh my god, I don't think we should do the whole you do, I do, you do, I do. Or just yeah, I know.
Sam, you gave your pen drive ready?
They gave me back.
Oh yeah, can you put them together again? I didn't it mine. You asked me to add.
They have to give it. No, give it to me.
Like this one to them or how?
Oh, how you want to give it to me? You have to ask me.
I just put in your pen drive. Ready. I just give you the pen. So online is memang tu ni. Never choose the online one. You didn't even have an option to choose, right?
The student with the timer. Student with the timer. Kashmina.
You make some different changes, is it? I need to check safety. I never check anything.
Did you delete it?
Okay, so welcome back everyone. So after the very insightful and inspiring keynote speeches, now let's start our second round of oral presentations. So the first presentation for this afternoon is heart failure in the obese population, overcoming diagnostic barriers with artificial intelligence. Please welcome Danu Rajendra Kumar to present her findings on the topic. Danu, before you start, I'll give you the briefing about the timing. So you have 7 minutes for your presentation. Around 5 minutes, you will hear a bell to indicate that you have used up 5 minutes. So in the next 2 minutes, please try to wrap it up, right? So at the end of 7 minutes, there'll be 2 bells, and then the judges will start their questions. And for today, we have Prof. Rusli and Professor Dr. Ali Abdul Ali as the judges for this session. So over to you, Danu.
Good afternoon to everyone present here. My name is Danu Rajendra Kumar, and I'm a final year medical student from Masa University. Today, I'll be speaking on a clinical issue that is both common and frequently overlooked: the diagnostic challenges of identifying heart failure in patients with obesity. Why is heart failure often missed in obese patients? Malaysia is facing a rising burden of obesity, with over half of its adult population now classified as overweight or obese. This significantly increases the risk of heart failure, especially a subtype called heart failure with preserved ejection fraction. However, in clinical practice, early signs of heart failure in obese individuals are not recognized. The reason is that common symptoms such as breathlessness, fatigue, and ankle swelling are also frequently seen in obesity itself. These signs are often assumed to be related to weight or deconditioning rather than cardiac dysfunction. So, figure 1 here shows this overlap. As a result, heart failure is often not investigated until the patient deteriorates and presents in an emergency setting. So, the objective and scope of the review. This review was conducted with 4 key objectives. First, to explore how obesity-specific factors affect the clinical presentation of heart failure. Second, to examine the limitations of conventional diagnostic tools, including physical examination, beta natriuretic peptide testing, electrocardiography, and echocardiography. Third, to evaluate patterns of diagnostic delay and misclassification described in recent literature. And finally, to assess whether artificial intelligence could support earlier recognition of heart failure in patients where standard investigations are inconclusive, particularly those with heart failure with preserved ejection fraction. Now, moving on to the methodology of the literature review. A structured narrative literature review was carried out using PubMed, ScienceDirect, and Google Scholar. Search terms included heart failure, obesity, diagnostic delay, and artificial intelligence. 6 peer-reviewed clinical studies published between 2019 and 2024 were selected. These focused either on diagnostic challenges of heart failure in obesity or on the application of artificial intelligence in heart failure detection. Articles were excluded if they were non-clinical, case reports, or commentaries. And figure 2 here outlines the article selection process. So, obesity, the mask that hides heart failure. Diagnosing heart failure in obesity is particularly challenging because many symptoms overlap. Fatigue, exertional dyspnea, and lower limb swelling are all classic features of heart failure. But they are also common in obesity due to decreased mobility and vascular changes. On physical examination, signs like elevated jugular venous pressure or a third heart sound may be difficult to detect due to the body habitus. In addition, initial investigations like beta natriuretic peptide testing and echocardiography are often underutilized in this population, especially if symptoms are assumed to be weight-related. So as shown here in figure 3, these overlapping features lead to diagnostic ambiguity, causing delayed recognition and poorer outcomes. So why standard diagnostic tools may miss heart failure in obese patients? Conventional diagnostic tools are often less reliable in obese patients. Echocardiography, our go-to imaging tool, may produce low-quality images due to soft tissue interference. This makes it harder to assess ventricular filling or identify subtle diastolic dysfunction, which is key in heart failure with preserved ejection fraction. Beta natriuretic peptide is a hormone that is secreted by the ventricles in response to pressure and volume overload. BNP levels help confirm heart failure, but in obesity, these levels are often falsely low due to increased clearance by the adipose tissue. Electrocardiography, that is ECG, may show low voltage QRS complexes or axis deviation, which can obscure early cardiac strain. And here, figure 4, it compares the reduced sensitivity of these tools in obese versus non-obese patients, reinforcing the need for additional diagnostic support. When the usual fails, can artificial intelligence unmask the hidden heart failure? This is where the artificial intelligence may offer added value. Machine learning models trained on thousands of patient records and can detect patterns that aren't easily visible in a single investigation. These models can analyze ECG waveforms, echocardiograph clips, and electronic medical records, even when some data is limited or of lower quality. So for one example, is the Mayo Clinic's AI-enhanced ECG tool, which was able to identify asymptomatic heart failure with over 85% accuracy. Another study showed that artificial intelligence could detect heart failure with preserved ejection fraction from a single echocardiograph clip, offering early insight in the cases where traditional evaluation might be inconclusive. So the last slide. It's not that we're not looking, it's that we're not seeing clearly. AI may help change that. So in conclusion, the early stages of heart failure in obese individuals are frequently missed, not because of rare presentation, but because the symptoms are easy to misinterpret and the tools we rely on often perform suboptimally. Heart failure with preserved ejection fraction is especially underdiagnosed in this group due to normal appearing BNP levels, unclear echocardiograph findings, and low sensitivity ECGs. This has significant implications for healthcare systems like ours, where obesity is on the rise and resources are finite. Based on this review, I propose three main recommendations. First, integrate validated artificial intelligence tools into diagnostic workflows for patients with high body mass index. Second, improve clinical awareness of how obesity can obscure heart failure. And third, encourage research into AI supported diagnosis, especially in low and middle income settings. And these are my reviews. Thank you. Over to the judges for questions.
Yes. The first question is, why choose narrative review when can do systematic review meta-analysis? The first question. Second is that, is there a possible role of prophylaxis for for obese candidates, given that AI can support the diagnostic decision? Two questions. The first one, why narrative review?
Yeah. A narrative review because I was able to review more than 6 literatures here, and I was able to check if all the literatures had the same conclusion. If AI is better in diagnostic future, or if the traditional methods work better. So in conclusion, I think AI can definitely be a supportive measure for the diagnostic measure.
But the question is not that. The question is that why a narrative? Because narrative review is an inferior form review. It should be systematic review, a meta-analysis. Because narrative review will lose the ability to do a systematic what do you call this a way of looking at the data, right? That is why in published literature, you always go for systematic review meta-analysis, either one or both, yeah, but not narrative. Okay. The second one is that prophylaxis. Since you found that there's possibility of maybe again maybe a high incident of failure, asymptomatic, right, in obese individuals. So question now is there a role for prophylaxis?
Yes, and I think mainly the prophylaxis would be awareness first of all for the obese patients, because in obese patients, fatigue or feeling tired, it is always usually thought to be just obesity related and not heart failure related. So clinicians may just misdiagnose and say it is because of obesity. Using AI can make the diagnosis better, and it can easily detect early stages of heart failure.
Yes, AI is surely it's got our machines of input. But my question is there any issue in the clinical examination itself? Like, for example, a simple clinical examination of treating disease. It's a class, it's got huge classification. So, is there a weakness in the paper that you have read? Did you find weakness in the papers that the clinical examination was not properly done at all?
Actually, I did not find any where the clinical examinations were not properly done, but I can say the clinical examinations were usually just said to be obesity related. If there was fitting edema, instead of sending for further investigations and evaluations, the doctors or the diagnosticians just said that to be obesity related. So that is where the AI.
Yeah, that's why the question arises. If you take a careful history within a obese patient who might or might not have a failure, you can get it up on the history. So in that way, yes, you rely on AI at any one time, but your clinical history taking has got to be sharper. And that is what I would like to see. Was there a failure in the clinical history taking?
Not as far as in these literature reviews, I didn't find any of them. Thank you.
Thank you, Danu. So we next move on to the second presenter for this afternoon. So let's welcome Shilling Esther, who will be discussing the role of neuroendocrine markers in digital behavior. So her presentation is titled as Evaluation of Serum Dopamine and Ghrelin as Biomarkers Associated with Addiction-Linked Behaviors in E-Gamers.
Good afternoon, everyone. Good afternoon, the organizers, my students, my fellow students. I want to thank you. I'm so honored. This is my first conference, and I'm so happy to present for you. I'm going to talk about evaluation of serum dopamine and ghrelin as biomarkers associated with addiction-linked behaviors in e-gamers. Okay, these are my contents. This is the background of the study. E-gaming is an uncontrolled act in which there is an involvement in gaming over a long period of time, in a day, weeks, and months. There has been increase in internet gaming, particularly in online gaming, which has affected addicted gamers' behaviors in ways including aggressiveness, lies, emotion instability, and indifference. Okay. Dopamine is a neurotransmitter which helps in transmission of signals in the brain and other vital areas. Dopamine was synthesized. It influences the reticular activating system, which regulates wakefulness. The disruption of sleep pattern is a major factor in sleep deprivation among gaming addicts. Ghrelin is a hormone produced by specialized cells that line the stomach and pancreas. It is also known as hunger stimulator. It is associated with appetite, learning, memory, and growth hormone. It plays a vital role in reward-based regulation by interacting with dopamine signaling in mesolimbic circuits and neuroendocrine pathways. So these are my objectives to evaluate the serum dopamine and ghrelin as biomarkers associated with addiction-linked behavior, and I have other objectives to describe the demographic profiles of the gaming and control group, to measure the dopamine and ghrelin levels of e-gamers and control group, to determine the association between the serum level of dopamine in e-gamers and control group, the association between the serum levels of ghrelin in e-gamers and control group, and to determine the correlation between dopamine and ghrelin in e-gamers. So these are my materials, my method. These are the flow charts of the study. I actually distributed some questionnaires. I got from the Google responses 108. And then finally, for the blood sampling, 58 persons were present for the sampling method. For the normal participants, I got about 27, and for excessive, I got about 18. Then the pathological gamers, I got 13. The ELISA method, 50 microliters of each dilution standard was added into each well, covered and incubated for 90 minutes at 37 degrees centigrade. The liquid was discarded and 100 microliters biostimulant detection was added to well, incubated for 60 minutes and at 37 degrees centigrade. It was aspirated and washed for 3 times. Another 100 microliters of HRP streptovin was added, incubated for 30 minutes at 37 degrees centigrade. It was discarded 5 times, and then 90 microliters of substrate reagent was added, incubate for 15 minutes at 37 degrees centigrade. 50 UL stock solution was added, and then the plate was read immediately. Okay, these are my results. These are the profiles of e-gamers and control group. We have the normal group, we have about 46.6%, and we have the excessive, we have 31%. Then the pathological gamers, we have 22.4%. These are the subject distribution for each gender. As you can see, we have the normal, the excessive, and the pathological gamer for both male and female. These are the characteristics for the control and for excessive, for control and pathological, and for excessive and pathological, their p-values. Okay, this is the standard curve for dopamine. It was iris square 0.9814, and this is the characteristics of gamers. Yeah, I actually used the talking multiple comparison test. Okay, this is the standard curve for dopamine. R square is equals to 0.9814. And then this is the standard curve for ghrelin. The R square is 0.95. Okay. These are the standard error and standard and the mean for the serum level of dopamine and ghrelin in e-gamers and control group. Okay, this is the analysis. It was analyzed using the graph, prism, the statistical analysis of dopamine level in control, and gamers results were analyzed using the talking test. Okay, this is for dopamine and this is for ghrelin. Okay, I have 4 points in my discussion. I have the involvement of dopamine as the reward neurotransmitter in e-gaming addiction. I have the involvement of ghrelin as the hunger and motivation hormone in e-gaming addiction, and I have the serum dopamine levels in normal and excessive gamers. And finally, I have the correlation of ghrelin dopamine interaction in e-gamers. Thank you.
So we move on to the judges.
Okay. Shilling, the first question is classification. How do you classify these the groups? Normal, excessive, pathological. In other words, what is your criteria? Inclusion, exclusion criteria. How do you classify them?
Years, 18 to 35 years were actually for the inclusion, and those who are below 18 were excluded, and those who had like some inflammation, they were also excluded, you know. Yeah.
But age cannot be used to classify, because this is classifying their gaming, you know. We have into normal, you know, and then you have excessive, pathological. It has to be based on maybe the time they spend on the internet, no, on the gaming. That should be the way you classify. If somebody have not done any gaming, that will be normal. Somebody have done certain hours, example, maybe that will be considered excessive. Somebody who go beyond that, maybe pathological. That's how you could classify. You know, you cannot use age. It must be based on how excessive is the pattern of gaming. That's how you classify them. Number one. Number two, basically is that you did the analysis, right? The analysis, you are comparing 3 groups. Okay, 3 groups. You can do ANOVA actually. You can do ANOVA. You don't have to do 2 keys. This is for post hoc multiple comparison. You don't use that. You can use ANOVA. One-way ANOVA. Okay. So that analysis is wrong actually. It should be ANOVA. Correct? It's ANOVA. Just to help you retract your right paper, don't put 2 key. 2 key is for sharp test, 2 key test. This is for post hoc multiple comparison. If you do a test and then post hoc after that you compare between other group between the A and B and C, A and C. Yeah, that is post hoc. But initial comparison must be by one way ANOVA because they are comparing more than two groups. Two groups you use t-test, but three groups you must use an ANOVA. Okay, this one. And then the third one basically is that, so can you really honestly conclude at the end of the day that that ghrelin and dopamine are actually accurate biomarkers of gaming? Can you use that?
Yes,
On what basis?
because you know, it's dopamine is actually a neurotransmitter,
Uh-huh.
and it has its way of sending signal.
Okay.
So I think it correlates with uh, ghrelin.
Uh-huh. But no, the question is that for you to conclude, you must exclude some of the confounders, when you compare across like three groups like this, there you have failed to exclude confounding in the study. You know what I mean by confounding, There are many other factors that may have raised dopamine and ghrelin level, not necessarily gaming. So can you tell us, apart from gaming, is there anything else that can raise this level? Any other factors you think could raise the level of dopamine and ghrelin?
Apart from the addiction,
Apart from addiction. There must be in it.
I think drug abuse can actually.
Exactly. Yeah. So in other words, So in other words, there is possibility of other factors which are not included. So just by using a simple ANOVA, we will not be able to distinguish. Right? Yeah. Thank you.
Yeah. You see, your first slide itself, very short. Your slide itself, we're not happy. I'm not happy with the definition. When you say addiction, there must be a definition. The word definition of addiction. Just put up the next slide. Next slide. Next slide. See, it's this is uncontrolled gaming over a long period of time. You've not defined it. It's very loose. What is the word definition of being addicted? That you got to be clear.
Okay.
I'm not clear in this.
Okay. E-gaming definition is a repetitive and a steady abuse of gaming over a long period of time, like days, weeks, and even months. Yeah.
Okay, thank you, Ms. Schilling. We'll move on to the next presentation. So I call upon Dr. Sambram Samdeshi to present his research on perception of medical students on anatomy teaching resources and their influence on learning outcomes at a private medical university in Malaysia. To remind you again, you have 7 minutes for your presentation. At 5 minutes, we'll give you a reminder. One bell.
Good afternoon, everyone. My name is Samar Samdeshi. Today I'm going to present my topic, which is perception of medical students on anatomy teaching resources and their influence on learning outcomes at a private medical university in Malaysia. Okay, just to give a background about my study, anatomy is essential to develop a competent and safe medical practitioner. So in today's landscape, there has been a shift from traditional teaching methods to a more active teaching methods where they incorporate virtual dissection, 3D models, and virtual microscopy. And there is a challenge nowadays since integration of the curriculum, there has been a reduction in anatomy teaching hours. So there's an inadequate knowledge that among junior clinicians, and this generation of students, they're known as the digital natives since they have a different approach to learning, and so we need to evaluate their views as well on how they learn so that we can provide proper learning methods and allocate proper efficient resources. So there are a lot of studies to assess the preference on what methods they prefer, but very little to ask to compare them with learning outcomes, and that's what I have done in Malaysia especially. Okay, my general objective will be to determine medical students' perception on anatomy teaching resource and their role in learning outcomes. My specific objectives will be to look at the socio-demographic variations and whether they have any preferred teaching methods, and whether with these preferred teaching methods are they different or are they statistically significant, and also the learning outcomes, how are they affected. So I'll be doing a cross-sectional study where online survey questionnaire will be administered to all medical students from year 1 to year 5 in Massa University. And this questionnaire I adopted from a previous research of 2021 and modified it and included the histology part as well. So the questionnaire has 3 parts: demographic part, one to ask the students to rank what resources they like. Then the third one will be using the Likert scale there to assess the 12 learning outcomes, both in cross anatomy and histology. After getting my ethical approval, we went on to validation testing. So content validity was validated by 4 expert panels consisting of anatomists, medical educators, and public health professionals. And also face validity, we did a pilot study consisting of 10% of our sample size, which showed that the internal reliability front-back alpha was 0.965 for the Likert scale questionnaire. Moving on to the data analysis, after we sent the form through the Google form and then we compiled it to SPSS, we did a descriptive analysis. We took the frequency percentages, means, and standard deviations. For the inferential analysis, it was a non-parametric test as it was mostly ordinal data. So we have Mann, Whitney, Yu, Friedman's test, and the Coxon signed rank test. The results, we had 170 participants in total. We had an equal number in preclinical and clinical phases. Preclinical as in year 1 and year 2. And the next group is year 3, 4, 5. And we had majority of more females and Malaysians. So when comparing gross anatomy preference, like which gross anatomy, out of the 4 gross anatomy teaching resources, which one they preferred, cadaveric prosection came as the top, followed by plastic models, and then online multimedia resources, with the last being textbooks and atlases. This was significant. We did a Friedman's test, and it became significant, where the cadaver prosection outranked all 3 of them. And in the histology part, we compared light microscopy to virtual microscopy, and there is a slight difference, but it was technically significant because of the Coxon signed rank test, where the light microscopy was the preferred method. And we also compared the demographic data towards any of these rankings, like either whether the preclinical or clinical phase, they prefer one kind, but no, there's no statistical difference between them. They both have equally ranked them. Moving on to the learning outcomes, we asked the students to rank all 12 learning outcomes in a Likert scale. I've listed all 12 of them. You can see that cadaver prosection has number 1 in almost 8 of the learning outcomes, while 3 of them has your online multimedia resources. These ones favor towards more self-directed learning, so I think they prefer more for their own time. And for the histology learning outcomes, here, in contrast to other previous studies, light microscopy has more favorability, and only 1 where independent study is involved, that is where digital microscopy has come into place. And overall, we can see that cadaver prosection they have follows the same trend in learning outcomes, and light microscopy has more ratings during the Likert scale. But when you compare histology learning outcomes, it was not statistically significant, as the difference was quite less. So discussion-wise, the cadaveric projection is more favorable because they can do manipulative and hands-on experience. One contrast to other studies we have is the plastic models that outrank the online multimedia resources, and we think that it's because of curriculum emphasis, because these other universities they have focus more about remote and distance learning, so virtual classroom has become more important for them. Histology, our university, this is the contrast, that light microscopy trumps the virtual microscopy, and that is the contrast done in various studies. That is because, again, various studies, they have said that the virtual microscopy is more preferred. But if you look at the performance, virtual microscopy has more performance, but they have said that more satisfaction is guaranteed by the light microscopy. And there's a meta-analysis done that showed performance of light to virtual. They've said that pathology, virtual microscopy is definitely useful, but if you go to just basic histology, there's no statistical significance between the light and virtual microscopy. We had few limitations, like this is conducted only in our university, so there's a limit on generalizability, and also there's no performance. It did not measure examination, so it's not a subjective matter. In conclusion, we asked our faculty members to focus on traditional methods such as cadaver and light microscopy to engage the students more, and also a blended approach to cover the whatever is not missing natives that we have the other one. Thank you.
Thank you, Sambram. Okay. So first question basically is that we need to see the questionnaire actually, because why? You didn't share with us the questionnaire. Because how many items in the questionnaire? There was you say you adapted from 2021. How many items in the questionnaire? Sorry, 78. Yeah. Because why I asked you, because when we do analysis, we don't do one by one the item. We do factor analysis, factor. So this is to improve. You are going to go to publish this paper. You have done face validity, okay, content validity, okay. Even content also you get maybe a couple of statistics there. The third one is that you have to do also this we will call this factor analysis, both exploratory factor analysis and confirmatory factor analysis. EFA, CFA, must do. Very important. So when you do that, those 78 items will then be composed of components. They call it latent construct. So when you argue, you argue not on each item. You argue on the construct. Maybe out of 78, you end up say with 5 or 6 construct. Okay. So the construct is the one that you have to use in your argument. Yeah. Okay. The other one is why in your study you use not parametric test and not parametric test? No. What's the main reason we do that? There's a bigger reason to that. Why? Because your data is not normal. Yeah, you must say that, no? You cannot simply go to no. Because it's better to use parametric, but it's not normal. But again, there is possibility we can transform the data into normal data. But again, sometimes not useful because when you transform, difficult to interpret. Yeah. Okay. Thanks.
In your study, year 1 to year 5. Yeah, year 1, what group you have got? You see, we like to know whether this, when you say use the word experiential, use a few words likely. Yeah, that's what we like to see the question. And What is likely? You cannot put in your own words. Yeah. And the other one is when you say year one, who are they? I can understand year 2, 3, 4, they're all gone through anatomy. Year one you have included, they may not have gone through anatomy completely to experience. Mhm.
So they have at least one semester, almost 6 months of
It wouldn't be because you are comparing with somebody year 2, 3 who have completely gone through the whole this thing. Year semesters and all that would not be easy. They probably will need to exclude the year one. Year 2 onwards. Yeah, that you would have to put there.
So now we move on to a study on alternative therapy with a presentation titled Role of Hypnotherapy in the Treatment of Osteoarthritis. A comprehensive review by Devi Priya.
Good afternoon, everybody. Good afternoon, dear panel and the audiences. Today, my topic I'm going to present about the role of hypnotherapy in treatment of osteoarthritis. It's a comprehensive review. Okay, so first, osteoarthritis we define as a prevalent form of arthritis, which is depicted as the articular cartilage breakdown that will contribute to pain, stiffness, and also diminished mobility. So this is actually a very chronic and also complex condition because it's a major disability globally, which affects the older individuals as well as though it impacts the younger individuals. So we look at the risk factors that also involved in this. And the diagram here, it shows that chronic pain in osteoarthritis, it actually has the mechanism that takes place in 3 ways, which is the peripheral nociceptive mechanism, central sensitization, and also an inflammatory pathway. So the reason why hypnotherapy we are doing in this particular research is because first you need to know hypnosis. It's actually a state of consciousness which is involved, focus attention, and reduce peripheral awareness that enhance characterized by the capacity for response to suggestion. So that is actually technique, but hypnotherapy is actually a clinical application of the hypnosis itself. So a little bit about the pathophysiology about osteoarthritis. It's a deterioration of the articular cartilage because of chondrocyte damage that will cause the degradation product to be released in the synovial fluid that will activate the pro-inflammatory cytokines, activates the T cells, B cells, macrophage, and it will amplify an inflammatory response that will lead to osteophyte formations, which will subsequently lead to acute and also chronic injuries that will cause the disease progression. So we know already there are non-pharmacological approaches that has already been existing. Patient education, physical activity, assisted devices, and also physical therapy. So under physical therapy is where you can tailor them into rehab programs. And second, we have the pharmacological approaches, which are the topical NSAIDs, oral NSAIDs, intra-articular injections, and also opioids that are used. And then surgical interventions as well, which is total knee replacement and arthroscopy. So on top of that, why are we suggesting for adjunctive therapy is like hypnotherapy, and then we also have other adjunctive therapy like acupuncture, transcutaneous electrical nerve stimulation. So why we are using hypnotherapy here is because this is a physiological intervention which will modulate the pain perception that will offer a holistic mind-body approach. So this study, this is actually a narrative review which will consolidate data from randomized controlled trials, systemic reviews, neuroimaging studies, and clinical evidence. So what we are going to explore in here is the pathophysiology of OA, the standard treatments, as well as the mechanism and the outcomes of the hypnotherapy intervention. So from 19 papers that I've reviewed, so what is clinically and also been proven here is that hypnotherapy, it significantly reduced the OA-related pain and as well as stiffness. It improves the mobility and range of motion that has been reported, and it mainly decreases the dependence of pain medication. So it works in actually 4 ways. First is the neuroplasticity. So why neuroplasticity is because chronic pain, the brain will actually develop a maladaptive pattern. So hypnotherapy will actually cause a reverse in the maladaptive circuit. That is where it will form new neural processing pathways. So this shows one of the mechanism of how it works. Second is endorphin release, which means production of the endogenous opioids. So endorphins are our body's own natural painkillers. So hypnotherapy will actually reduces the stress. When you reduce stress, it will subsequently reduce the inflammation. That will cause the endorphin release, and also it can reduce your pain. Third is reducing the inflammation, as I explained. Stress reduction will also reduce the inflammatory cytokine activity. So in this, it will produce 2 types of pro-inflammatory cytokine, which is the IL-6 and the TN factor alpha, which are both responsible for the pain perception. That is why when hypnotherapy is there, you reduce the stress, it subsequently reduces the pro-inflammatory cytokines. That is why the mechanism here actually works. Fourth is the cognitive reframing, which is changing the individual's perception about pain, reducing the fear and anxiety. So based on this evidence base that from this 90 articles that have been reviewed, what it shows is, first thing, it will enhance the pain tolerance. That means it will lower the pain perception. At the same time, what is the outcome is, patient will have decreased reliance on NSAID or opioids, because we know it has a long-term side effects. So that is why. Second is it improves physiotherapy compliance. So it will actually encourage, motivate the patient to engage. So there is greater adherence to exercise programs. So that is a prevention. Physiological well-being, it will help to alleviate the depression, anxiety, and stress. So patient can have improved mood, reduced physiological distress. And fourth is it will reduce the joint stiffness, which will increase the knee flexion range. So for conclusion, hypnotherapy, it actually contributes into neuroplasticity, which is one of the mechanisms that I've explained. The body's natural opioids, which is the endorphin release. Third is the stress biology and the cognitive flexibility to relieve the osteoarthritis pain. Hypnotherapy is an effective complementary approach to the management, which will target both the physical and the physiological aspects that is comprised of this pain. So while it's actually promising, but we need a wider integration into clinical practice that requires standardized guidelines, better awareness, and access to trained professionals. So further research and increased awareness among the healthcare providers can actually facilitate into introducing this as an integration in the mainstream of pain management. So what can be done in future work? So we can conduct longitudinal studies on long-term follow-up and benefits of self-hypnosis training, evaluate the impact of institutional intervention like technology-based accessible delivery like telehealth, virtual reality enhanced hypnosis, and as well as develop more neurophysiological mechanism studies which will tailor the interventions by identifying the neural markers that are relative to the responsive. That's all. Thank you.
Thank you, Diva Priya. Diva or Diva? Diva, yeah. My comment is the same, because what you did was a comprehensive review versus narrative review. Okay, and I always say many times, narrative review is not really useful in publication. Very difficult to publish, and therefore it tend to lack evidence, because in terms of level hierarchy of evidence, you must go to systematic review. Okay? Remember that, no? You want to publish, you must go system review and or meta-analysis, number one. And number two, if you are doing this in the way you describe, this very much qualitative description. I would rather develop a qualitative study here. You do a focus group, what we call this interview or discussion, get a group of people with osteoarthritis, and you get a narration of their experience. And then plus, if they have undergone hypnotherapy, then you can also compare those individuals who have not gone through hypnotherapy and those who have gone through, their narrative may be different, right? And that is better evidence for you. then you publish it as a qualitative study. That you can easily publish it because it's not done yet, no. But here I think that the problem is that you are trying to do what you call this, a review. The review, I said many times, no, narrative view is not useful because it's not there's no evidence there. The evidence is it can be contested. So you must be trained in systematic review, meta analysis. But there are training in even YouTube as when they train, you do it. Then your paper become improved. Otherwise, do a qualitative study. Okay, thanks.
Yeah, exactly. See, because your the thing is hypnotherapy in the treatment strategy, but you are concentrating on pain. No, so I would like to see define pain. Where is the pain scale and all this? Yeah? Only then you can objectively say, hey, he has improved. Because it's a subjective, experiential thing. No, so as mentioned, it has got to be qualitative. This is what it isn't.
Okay. Thank you, bro. Thank you, everybody.
Thank you, Ms. Devi. So now we move on to the next presentation, which focuses on maternal health. So I invite Maisha Mejabin to present her topic of anemia in pregnancy and its association with antenatal care.
Good afternoon, everyone. Thanks for being here. I'm Maisha Mezavin. Today, I'll be presenting my research on anemia in pregnancy and its association with antenatal care, which I did in Bangladesh. So let's see what is anemia in pregnancy. If the hemoglobin level of pregnant woman is less than 11 milligram per deciliter, then we can say that the woman is anemic. And what is antenatal care? Antenatal care is the health care which a pregnant woman receives from conception until childbirth. So anemia in pregnancy is quite common, and the prevalence is quite high in Southeast Asia, which is nearly 48%. This type of study has been done before in Bangladesh as well, but those have always focused on the rural areas. That's why my study focused on the urban area, Dhaka city, which is the capital of Bangladesh and has better facilities than other rural or urban areas. The general objective of my study was to determine the prevalence of anemia and its relationship or association with antenatal care among the pregnant women in Dhaka. And the specific objectives were to determine the prevalence and to measure the hemoglobin level of women in 3 trimesters of their pregnancy, to determine, to identify the dietary habit and lifestyle of the pregnant woman, and to assess the relationship of iron folate supplements intake and anemia, as iron and folic acid both are necessary components. Let's see the methodology. So my study was a cross-sectional study, descriptive one, which took place in Dhaka, and we collected data from 3 government hospitals of Dhaka, which are Azimpur Maternity Hospital, Mohammadpur Fertility Center, and Dhaka Medical College and Hospital. And we had a structured questionnaire to collect the data about the socioeconomic status, the lifestyle and diet of the pregnant woman. Anthropometric measurements were taken, such as height, weight, and body mass index, and biochemical data were collected from the medical reports of the pregnant woman. Let's see the findings. The left pie chart shows the number of antenatal clinic visits, and we included women who were in their 3rd trimesters and who who were between 15 to 45 years old. That's why the number shows a little bit higher. 46% of the participants visited the antenatal clinics 4 to 6 times. 37% of them visited more than 6 times. And the second chart shows the stage of anemia. Here, it shows that anemia is highly prevalent and 59% of the total study population were anemic. 34% had mild anemia, 19% had moderate, and 6% had severe anemia. And we did chi-square test to check the association, but in our study, we couldn't find any association between the antenatal care visit and stage or presence of anemia, as the p-value is greater than 0.05. But we found the association between pregnancy trimester and the stage of anemia. Women in our study were more anemic in their second trimester of pregnancy. Here in the discussion portion, the middle portion shows another study result done in Bangladesh, which is in Joshore, a rural area. The prevalence is almost the same as ours, which is 58.9%. That means that though Dhaka has better health facilities, but the prevalence is as high as the rural one. And there are some limitations, like we couldn't do any biochemical test on ourselves, as it was a self-funded research, and we couldn't do it on a larger population due to time limitation, as it was a part of my academic research. And there are some future recommendations, like as there are other factors of anemia other than antenatal care, they should be focused as well to reduce the high prevalence, and further studies should be done to improve the situation and to bring intervention. These are the references I have used. Thank you.
Thank you, Masha. All right. You tried to do your best in the study, but again, I understand you're still undergraduate student or postgraduate, yeah. Because there's a big gap in the study. I would easily sit down you and go through in terms of study design, sampling size, sampling method, and above all the questionnaire. I like to see how you derive the questionnaire. Is it your own questionnaire you took from somebody else? Do you validate? No, if I go through 1 hour lecture, but I wouldn't go through. I just suffice to say that you need to go really deeper to the study. It's not like this. You cannot publish it this way. And then because even antenatal, say, association between antenatal care and anemia. What are you talking about? You're talking only about the visit, number of visits, isn't it? Talking about visit. I thought you're talking about some of the procedure in the care. So these are not clear. So in future study, you really have to sit and think carefully about designing the study. Even though you are doing it for the first time, but there is a need to be very detailed, because writing research, this come under the ambit of research methodology, which is the queen of research. If you fumble in this, all the results are gone. Okay, so I've been teaching for many years about this methodology. Right? Very important to sit down, look carefully into the study. And later on you will understand why I make a point, because these are the tool of research. You must really accomplish, especially the questionnaire. We like to see also how you derive it, because without the questionnaire, I cannot see. And then things like ethics clearance, do you get sampling without clear? You just take the hospital. Are you doing purposive sampling? Why? Are you doing cluster sampling?
Random sampling.
Cannot be random. How do you randomize? You need to know also how you randomize it. People say randomize, but in reality, it's not randomized. Always purposive. So this thing we need to sit and perhaps even go through courses in methodology. Thanks.
Thank you.
Basically, that's where the weakness is. You see, when you say Dhaka city, there are more than 10 million population. Yeah, and you say 480. The hospital doesn't not fit. And it does not correlate well with saying, okay, the city population is anemic. It can't. No? It needs to be better studied.
Thank you.
Thank you, Prof. So now we move on to the next presentation, which will be a case report on acute myeloid leukemia presenting with gum bleeding and bruising in a previously healthy middle-aged male by Roshwin. Over to you, Roshwin.
Thank you, Doctor. Good evening to everyone present here. My name is Roshwin. I'm a final year medical student from Masa University. Today, I'll be talking about a case report on acute myeloid leukemia. Okay, so this is my table of contents: the introduction, patient history, physical examination, diagnosis, and investigation management. Finally, the conclusion. So just a little bit brief about acute myeloid leukemia. It is a clonal hematopoietic stem cell disorder. Especially, it is characterized by increase in myeloblasts in the bone marrow and peripheral blood. And in Malaysia, according to recent reports, the incidence of all leukemias combined is only around 2.9 per 100,000 population. So it's quite a rare disease to come across. And a typical presentation is cytopenia-like symptoms. So they'll have fatigue, bleeding, infections, and organ infiltration. So patient history. So Mr. F is a 47-year-old Malay gentleman who presented to the hospital with lethargy, recurrent fever, easy bruising, and gum bleeding for a period of 2 weeks prior to admission. The history of presenting illness shows that he was having progressive lethargy for 2 weeks despite adequate rest. He reported having fevers during the evenings, but it did go away with paracetamol and came back the very next day. There was a significant loss of about 5 kilograms in a period of 1 month without any significant exercise or diet change, but the patient did mention he did have loss of appetite, so it could be because of that as well. He noticed his gums bleeding when he was brushing, and he did not have any contact with sick individuals or any recent travel history, headaches, or insect bites. So other history is not really significant, nothing much to be known over here. No family history of malignancies, no known medical illnesses, never been admitted to hospital. So this patient is a very healthy individual. Okay, moving on to the physical examination, we divide it into general and the specific systems examination. In the general examination, the patient was alert conscious, oriented to time, place, and person. He was on nasal cannula with around 2 liters per minute oxygen and had an IV cannula in his left arm with IV drip of normal saline with ceftriaxone. He also had multiple petechiae and ecchymosis over the lower limbs, and his gums appeared swollen and with a little bit of blood. Apart from that, there was no other significant findings. Moving on to the abdominal examination, going over a superficial palpation, there was no abdominal tenderness, but on deeper palpation, there was hepatosplenomegaly to be present. And this is the way we talk about the swelling, so size, shape, surface, consistency, and all of it points towards the fact that the patient is having hepatosplenomegaly. And on percussion, we were able to find that the patient was having an enlarged spleen extending up to 9 centimeters below the left costal margin, and the size of the liver was mildly enlarged around 14 centimeters. Auscultation was normal. And laboratory investigations, the most important thing that I want everyone to see is the patient was having pancytopenia, and white blood cell was very high, markedly elevated. So look at it, it's 368 in 10.9 liters per minute, whereas the normal range is only around 4 to 11. Everything else was reduced. Patient was also having anemia, neutropenia, and thrombocytopenia. Other laboratory investigations was the peripheral blood smear showed patient was having Auer rods, myeloblasts, which were numerous in number, and dysplastic neutrophils. Bone marrow aspiration and biopsy also confirmed the patient was having Auer rods, myeloblasts, and hypercellular bone marrow without proper cells. And they also did the Philadelphia chromosome in hospital Kuala Lumpur, but it was absent in this patient, so it's not chronic myeloid leukemia. Other investigations they did were all deranged, especially the coagulation profile the liver function test. This could be because of the bone marrow infiltration into the organs. And then the results, according to the World Health Organization 2022 diagnostic criteria, if the patient is having more than 20% myeloblasts in the peripheral blood or bone marrow, and any specific genetic abnormalities, even if the blast count is less than 20%, they can be diagnosed with acute myeloid leukemia. So the patient results, he had our rods present, myeloblasts and dysplastic neutrophils. Therefore, he is having acute myeloid leukemia. So final diagnosis is AML. Now the management, the first line management that they did in Hospital Kuala Lumpur is to stabilize the patient. His vitals were monitored. That's why he was given oxygen. And he was given also ceftriaxone, which is a broad spectrum antibiotic to cover for his neutropenia, and supportive IV fluid, nutritional support, and patient counseling, because that's very important in all diseases. And finally, the patient was transferred to Hospital Ampang, which is the hematological malignancy site center in Malaysia. So they would give the 7+3 cytarabine plus daunorubicin management chemotherapy, which is specific for a specific subvariant of AML. And if there's recurrence, they go for allogeneic stem cell transplantation. So the conclusion is that AML can present subtly in many patients. And just by doing a full blood count in a patient, we can identify whether the patient's having some kind of issues and send them to further workup. So whenever a patient presents with lethargy or tiredness, we shouldn't take it simply. We should listen to the entire history and look for other constitutional symptoms or signs of malignancy. These are my references. Thank you very much.
Before I pass on to the judges, I want to ask a question myself first.
Sure, Prof.
What is so unusual about this case that you wanted to present?
Okay. Basically, so this patient, if you look at acute myeloid leukemia, normally it presents in the 6th decade of an individual's life, according to many studies and reports. But this patient was around 47 years old, so he's having an earlier presentation. And also he was a completely healthy individual before getting this. No family history of malignancies and no work history that indicates he came across any exposure to toxic substances or mutations. And still he came up with just simple symptoms like lethargy, there's simple bruising. So I thought this case would be important because one, it's a very rare case in Malaysia, and two, it's also a good learning point for medical students.
Okay, just yeah.
It's not very rare, and that's a common presentation. It occurs AML occurs in that part to so as far as I feel, it's like the routine presentation of an AML patient. So nothing unusual about it.
Yeah, because when you do a case report, normally we look for some unusualness about the case, not something that's a regular run of the mill. But okay, but since you have reported it, just my other question is that is there any antecedent factors that could contribute to him developing? Because you say there's no family history in it, yeah. Anything else? Anything that in the antecedent history, prior history that could actually account for the AML? Any possibility, some exposure somewhere that he got this?
He did mention he was working in a construction site. So maybe he came across chemicals or paint substances that can cause mutations in the genes. If he's not properly protected. So maybe it could.
What is his job actually? What is he working as?
He was working as a contractor.
Contractor.
Yeah. So
what possible exposure? These I'm not asking about occupational medicine, no?
Yeah.
What possible exposure could contribute to leukemia in general? What substance you think in the workplace could contribute to leukemia?
Usually substances like benzene,
Yeah.
solvents.
Benzene way solvent, this is the solvent.
Yeah.
So what kind of job you think as contractor possibility that on a chronic basis is exposed to this kind of substance that could provoke leukemia?
Yeah. Paint has benzene in it.
Paint, yeah. Where else got benzene? A lot of benzene. Where else? petroleum. You know, you go to gas station, no? Gas station. When you put petrol, no? These are all benzene, with benzene. That's why you should not you should never stay close to the when you put the petrol away, because there's a benzene there, and benzene is a known carcinogen, and the carcinogen and the thing that it causes leukemia. You know, so that's why if there's no family history, you try to exclude the genetic factors, right? It could very well be occupational or environmental. Okay.
Is he vaping?
No.
Have you asked the question?
Yeah.
But it's not. I would like to have a better, you're presenting only one case. There must be a better clinical examination of the abdomen. You said spleen was this large below the costal margin. Was it smooth surface? Was it rough? Was it irregular? Was it tender? These are important questions I want to know. Because you said it's unique. Maybe it's unique because it was presented in the emergency department. Yeah, that could be the uniqueness of it. But you see, yeah, because it's a single case, you've got to be thorough. Absolutely be thorough. Leave no room for getting stabbed by the pathologist. Understand?
Yes. I was anticipating a question from Prof. Sudha actually, so it's okay.
That's all.
Okay, thank you. Thank you very much.
Okay, so next we go on to a futuristic take on diagnostics. So the topic is AI meets the heart, revolutionizing cardiovascular diagnosis from genes to ECG. Are there two presenters? Okay, so it will be presented by Nimalendran and Sonia.
Good evening, everyone. Good evening, doctor and scholars. So myself, Nimalan.
My name is Sonia Rai. We are third year medical students from Masa University.
And we will be presenting
AI meets the heart, revolutionizing cardiovascular diagnosis. AI meets the heart, revolutionizing cardiovascular diagnosis from genes to ECG. Cardiovascular. Cardiovascular diseases remain the leading cause of death worldwide, responsible for nearly 17.9 million deaths per each year. One of the greatest challenges in cardiovascular care is the lack of early warning. Many patients remain completely asymptomatic until a serious event like a heart attack suddenly occurs.
Unfortunately, standard diagnostic tools such as routine ECGs often fail to capture breaks or subtle abnormalities that occur intermittently
before major cardiac events like myocardial infarction.
This challenge is even more significant in rural and under-reserved areas where access to timely healthcare is limited. Why this research?
Recent advances in wearable ECG monitoring devices and artificial intelligence present an opportunity to change this model of care. Single-lead ECGs in wearable are not designed to replace 12-lead ECGs, I agree. But to complement them through continuous long-term monitoring, we can help to resolve this issue, I trust. While previous studies have successfully used wearable devices to detect arrhythmias like atrial fibrillation, there's limited research on using continuous urine-based ECG monitoring combined with genetic risk profiling to detect silent ischemic changes before a heart attack occurs.
This is where our study comes in, aiming to fill the gaps. Primary aim of our study is to evaluate the feasibility of using continuous home-based ECG monitoring integrated with AI analytics and genetic risk assessment to detect early signs of cardiac abnormalities in high-risk but asymptomatic individuals.
Our approach focuses particularly on rural population where healthcare access is more limited. This supports telecardiology models, ensuring timely care even in resource-limited or geographically remote population. What is the key technology, Sonia?
We are using wearable ECG devices designed as a minimalistic smartwatch or skin patches, which patients can wear comfortably throughout their day. The device continuously records real-time ECG data and transmits it to a secure cloud platform for analysis.
Importantly, if the device detects significant abnormalities, such as ischemic changes or arrhythmias, it automatically triggers a direct call to a dedicated medical hotline. Trained healthcare professionals then review the data and advise the patient on the next steps. Whether urgent care is needed, further evaluation is warranted, or monitoring can safely continue at home.
This closed loop system ensures early detection can translate into timely clinical actions.
About our study design, this will be a very prospective feasibility study, enrolling 100 asymptomatic individuals who meet our inclusion criteria. Firstly, genetic high risk. Confirm pathogenic variants like endo, PCSK9, LDLR, APOB. For example, PCSK9 and APOB are implicated in familial hypercholesterolemia. Endo is associated with atherosclerotic burden and myocardial infarction risk.
At least one cardiovascular risk factor such as hypertension, diabetes, dyslipidemia, obesity, smoking, or familial history, and residents of rural areas with limited healthcare access.
Patients with known cardiovascular disease, recent cardiac intervention, or severe comorbidities will be excluded from this.
The ECG data will be continuously analyzed using AI algorithms trained on validated data sets. The algorithms are designed to detect ST segment deviation, repolarization abnormalities, arrhythmias, and other subtle ECG changes suggestive of ischemia or early cardiac instability.
Our AI system will be evaluated using standard performance metrics such as sensitivity, specificity, positive predictive value, and ROC curve analysis.
Our primary endpoint is the detection rate of clinically significant ECG abnormalities.
Speaking about secondary endpoints, it includes the rate of false positive alert, patient adherence to device usage, outline response times, and preliminary estimates of cost effectiveness. Speaking about ethical consideration, we need to do so because it's a 24-hour monitoring. We take ethical considerations very seriously. All participations will provide informed consent, and the study will follow ethical guidelines, including GDPR and HIPAA for data privacy. An institutional review board will oversee all of this and is private and confidential. Also, in particular, I can say that the primary ethical concerns include data privacy and ownership, informed consent, risk over surveillance, and also anxiety. Speaking about future perspectives,
If successful, this model could pave the way for a proactive, personalized approach to cardiovascular care, particularly for rural and under-reserved populations, by identifying individuals at risk before symptoms occur. We hope to shift from reactive treatment to a cardiac event to true prevention. In the future, integration of AI, continuous monitoring, and personalized genetics may allow for even more accurate risk prediction and targeted intervention.
in summary, our study explores a novel combination of genetic risk profiling, wearable ECG technology, AI analytics, and a real-time clinical intervention. This approach holds promise to close one of the biggest gaps in cardiovascular care, early detection in asymptomatic high-risk individuals. I would like to take the privilege to talk about Madhav, who passed away 1 year back due to being an asymptomatic patient in MI. So I believe that this kind of approach will focus on asymptomatic patients because not every time ECG will be perfect on point, I trust. So this might help in elevating the cases and diagnosing quickly. So that is from us. And Sonia would like to end with a quote, I guess. Okay, let me finish. Time is muscle, but for silent art, time is data. The sooner we catch it, the more heart we save. So the presentation is now open for discussion. Thank you.
Thank you. Thank you. Yeah. Yeah. Okay. So My question was simple, no? The idea was it's fantastic because you're thinking about to detect any what call it deviation from normality, ECG, so on, sorry, cardiac condition. But the one important thing we have to always to consider what are the practical practicalities. Example, no? Somebody detected so what in wearing a smartwatch. The question is who and where is it going to be taken to for treatment and so on. So you must know individual can be fitted with all these wearable devices, but at the end of the day, how do we ensure that wherever that any what do you call this condition that require treatment occurs, how do we ensure these individuals are quickly attended to? You saw the presentation by Prof. Ali today, Internet what IoT, Internet of Things. We need that kind of a seamless what do you call this connectivity, between the patient and the hospital providers. Without that, then it becomes just an idea. So how do so therefore my question to you is that how do you take care of this kind of practicalities, and what are the pros and cons of this what call this technology that you mentioned?
Speaking about practicalities, I would like to say nowadays this kind of smartwatches comes with an app. So what we can do is attach the smartwatch to the app, and the data, because these apps will be connected to the portal of nearby hospitals, and every time an abnormality is detected, the watch will give them a signal that they need to visit the hospital, and the nearby hospital also will be alerted along with the address of the patient, because this will be an example. Now every iPhone, iWatches have the medical card. Similar to that, just that to ensure that this enhances the how to say alerting the hospital and immediately the ambulance. Because nowadays there's been a bigger problem. Even taken to my mom's case, she was having the heart attack 4 hours before, but just because every time she visited the hospital after her first event of cardiac heart attack, she was her ECGs was normal. So suddenly one day, after a year, she got similar chest pain. She thought it's a normal gastric pain. So she wasn't alerted, and we also wasn't alerted. Being a medical student, even I wasn't alerted about this, because being a cardiologist telling ECG sounds normal, for a medical kid is normal for me too. But then somehow it got altered in some ways. And maybe if this kind of ideas is approached, I could have saved my mother. So same kind of idea. Immediate alerting in myocardial infarction is very important, because once you develop a cardiac arrest, nobody can be saved. So that's the thing. Speaking about pros and cons, yes. Uh, as we can have tachycardic when we are having a panic attacks as well. That's the reason we have included the genomic research here, where the patients like, can you hold the phone for a while? Yes. The genomic research, like myself, I'm a familial high-risk hypercholesterolemia patient. So my mom is also a familial high-risk because my generation is being diagnosed with high cholesterol patients. And even myself, I've been diagnosed with a stroke 1 year back after my mom passed away. Really, yes. So I just recovered. So this kind of genomic researchers help to prevent cases much earlier. Like if I've been alerted with this, maybe I would have been taking care of my food along with it. And maybe in some unfortunate circumstance, if I get to know that I'm having tachycardic, and I would say prevention is better than nothing. So that's the idea. Speaking about cons, yes, we would be very particular about the cons. And there is advantages and limitations as you see. So we'll focus on the exclusion criteria, and we'll emphasize on the pros as well, just to save lives.
So the question is that which hospital has done this? Have you have any hospital?
Okay, about myself, according to my situation I gone through, when I was first diagnosed with stroke, I know it's a TIA, but the medical doctors there couldn't say it's a TIA because there wasn't any timely diagnostic. Even being a medical kid, I told them that just take an MRI scan or a CT scan at least. They told me you are too young to get a stroke. And then the next day I was diagnosed with stroke. I was in ICU, brought to PPUM nearby hospital. The doctors were like quite I would say disappointed with the. I don't want to mention which hospital I was firstly went, but quite disappointed with that hospital. And they told me if you have timely diagnosed, you would have avoided this. And then I was given a 1 day BP monitoring watch. So that's why it triggered me when I was taking this case. Okay, maybe why not getting this watch after getting diagnosed, going through all the physiotherapy and getting sick? Why not you do that earlier so that this thing goes on? And it's not like every day is gonna take your ECG in your so that the privacy is not disrupted. But maybe once a month, because as we all know, in myocardial infarction, the atherosclerotic events don't happen in one day. It at least takes months, weeks, at least. So maybe the heart might give a 1 second signal which can identify and alert them. Okay, now it's time for you to go to the hospital. So that's when you can avoid this. What do you say? Missed out of checkups and stuff. And also, this can help the hospitals to focus on patients who really need it instead of patients who confusing it with panic attacks, patients who are confusing just because like, okay, I'm paying, so I need to get my thing now. Yeah, some kind of that.
Let me summarize.
Sure.
Your presentation part of it, there's a confusion between what you say and what you presented. Yeah, it doesn't say confusion.
Yeah.
See, AI is excellent that you have discovered. This watch, if I wear, this watch, yeah, this watch I watch must have connection to my uncle. Yeah, to my uncle or whoever is responsible. That means if I falls off, and that is what this is made of. So once it finds there is a system, yeah. Once it falls off, immediately my uncle's phone rings. Immediately he calls out, what's happening? And straight away he gets triggered. That is what this is. Yeah. See, now you have got the health care. You get Sunday Medical Center, they can monitor you throughout. Yeah, if anything happens to your ward, to your child, yeah, they will straight away treat it. So those are the things. Yeah. If you go to a government hospital, wherever it may be, know that 20% will have normal ECG, 20% will have cardiac enzymes in normal. That's where the whole problem of diagnosis is. Because if you go to a non-clever doctor, with 70% are clinical the problems you are facing. Okay? You will not want to generalize. Yeah. But yes, it is good for you to have all your family members should have because it genetically runs in your system. Yeah. But no, what the difficulties you are facing, that's because you lost the wrong reason.
Thank you, Doctor.
Thank you. Thank you, Nimalendran. As this looks like a proposal for a future study, maybe you can do a study and you can see what are the results and how further you can improve this. So now we move on to the next presentation on anatomical studies from Ms. Kelvinda Kaur.
Okay, thank you everyone and good evening. So my study for today is the prevalence of anatomical variation within the ethmoid sinus among the Malaysian population. This is a CT scan study. We look into the introduction first. Ethmoid sinus is an air-filled cavity which is present in the ethmoid bone between the eye. It has an intricate anatomy. This is highly important in FESS surgery due to the potential complication that can arise due to the proximity of critical structures, which can cause cerebrospinal fluid leak, orbital nerve injury, and orbital floor damage. The variation that is commonly noted in the ethmoid sinus is the agonasa cells, Heller cells, O'Reilly cells, and also the Kiros classification, which is defined by the olfactory fossa depth. During the literature search, we noticed there is a gap that despite nations having a diverse epithelial composition and also a distinct craniofacial anatomy, there is lack of substantial data that is present on the ethmoid sinus for these variations. For the general objective is for us to assess the prevalence and also the distribution of this variation among the Malaysian population based on the CT scan, and for specific objective is to determine whether there's an association between the gender and also ethnicity with this variation. For research hypothesis, we also want to see if there is a significant association between the ethnicity Also the gender with a specific type of variation which is present among the Malaysian population in the ethmoid sinus. For methodology, this was carried out post of the ethical approval by the HUKM and also MASA Ethical Board. This is a cross-sectional study in which we employ purposive sampling. Secondary data, which is the CT scans, were collected from the radiology department of the Hospital Chancellor Tuanku Muklis between the time period of January 2023 to July 2024. After inclusion and exclusion criteria, we left with 167 CTPNS, which includes 334 sites, right and left. The cells that were interested from the CT scan were Aganasa cells, Heller, Onady, and also the height of the olfactory fossa, which should be defined by the Kiros classification. Demographic data collected were age, gender, and ethnicity. As for sample size, we take into consideration based of the proportion based on the Malaysia Statistics Department. Prior to the whole study, we conducted a pilot study with a sample subset in which we is to measure the radiologist reliability of this method, in which we use Cohen Kappa to check the intra and intra reliability statistics. And based on that, we got strong to perfect agreement, which shows there's a possibility of reproducibility and consistent in the reading. After that, we conducted the full analysis, which would include descriptive analysis and also inferential statistics that include the chi-square test. As for the result, I would show you some CT images that were used during the study. This is the Aganasa cell, the anterior-most ethmoidal cell. This is the Heller cells, which is present inframedially to the orbital wall. Onady cell, this is superolaterally to the sphenoid sinus. And also the olfactory fossa depth, which is used to see the olfactory fossa height. We have type 1, type 2, and type 3. We use to measure from the fovea ethmoidalis to check or measure the height. As for the result, we use a chi-square to see whether there's gender, there's any association between the gender and also the variation. As we can see, for the gender, we can see the most common in male and also female is the Aganasi, followed by the Heller and the Onady cell. It's slightly higher for the females in Onady cell. As for Kiros classification, we can see type 1, type 2, type 3. Type 2 is the most common, followed by type 1 and type 3. Despite we can see some difference, we did not find any significant association within the gender and the variation using the chi-square test. As for ethnicity-based analysis, we can see that Aganasa cell is most common for all the major ethnicity in Malaysia, followed by the Heller and the Onady cell. Despite Indians being the minority, we can also see they have the highest prevalence for Onady cell. As for Kiros classification, we can see type 2, which is most common, followed by type 1 and type 3. We also can see here that on the left side of Kiros, we can see Indians being the minority still have the highest prevalence. Despite all that, we did not find any significant association between the ethnicity and also the variation. As for discussion, we can see that Aganasa cell is the most prevalent. This is aligned with the other data from globally. Kiros type 2, which is also most common, which is also consistent globally. But then we see lower prevalence of Heller and Onady cells compared to other studies globally. We did not find any significant association, whereas some global study found that there is significant association between ethnicity and gender. This could be because of the ethnic craniofacial diversity, now inclusive of environmental and genetic factors that could cause the anomachical development. And also due to the variation in the CT protocol, the sample size taken, and also the criteria, the inclusion and exclusion criteria. Despite these studies align with the global finding, but it also emphasized that should have importance for the ethnic specific population of this variation. As for conclusion, this study reinforced the need of routine CT PNS because we have high prevalence of this variation. And despite, as I said, is aligned with the global trend, but we should also highlight that this formulation is specific because we don't have the local data. And it also creates and establishes a baseline formulation analytical data and supports for future research and guidelines. Despite we have a multi-ethnic representative, which is our strength, but due to the limited sample size of certain ethnicity, we therefore we did not find a real association, so we would probably recommend for a bigger sample size. And also we only relied on the CT images. I think that in future study they should have correlation between the clinical and the surgical outcome. And these are my reference. Thank you. Yeah. As for clinical signification, we know that these structures are close to the optic nerve and also the internal carotid artery. And due to this, it could cause damage and cause maybe blindness or etc. And severe complication also is close to the cranial fossa due to the Kuros classification. We can also cause cerebral spinal fluid and complication during the FESS surgery. Yes. 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 So as for exclusion criteria, these patients are actually referred by the ENT clinic to the radiology department. So exclusion criteria include pansinusitis or any ethmoid sinus that has that we were unable to read. So basically, we only included clear ethmoid sinus. Any pansinusitis and all were excluded.
Sinus patients. We would like to know what are the differences between the acute groups. Because it also it's a very good research. I thought this was already been done before. But if it's not been done, then it's good research. But the issue is you need to make sure you've got a wider number. And have a good filter. Otherwise, it does not give you a good filter.
So yeah, as for the numbers, that's why we recommended. But due to time constraint, we could not have a bigger sample size. But we have tried to have a representation according to the Malaysia demographic statistics for each ethnicity. Thank you.
So we have reached the final presentation of today. So I invite Alia Nasir to present her research on a public health concern about empowering nurses and strengthening resilience for disaster preparedness and management.
Bismillahirrahmanirrahim. Respected professors, teachers, dear students, ladies and gentlemen, Assalamu alaikum. It is an honor for me to present here today from Pakistan and Masa University student. The main objective of today's presentation is to inform national and international stakeholders level to improve and advocate for disaster preparedness and help policymakers to set priorities, allocate resources. I hope that this presentation will add the weight to the argument for action on the health performances regarding health preparedness, especially for the nurses, and overall strategy for disaster reduction through collaborative approaches. So this is a proposal for future research. As we know that disasters are increasing, the frequency of what is disaster? Disaster is a major event that disturbs the ecology of the area, the communities, the overall local capacity. So according to the emergency event database, they include the disasters with 10 or more casualties, 100 or more people affected, declaration of national or international emergency like we had during the COVID, or any epidemiological pandemic or epidemic diseases in the area. So there are different types of disaster: man-made disaster and man-made disaster and natural disasters. So in natural disasters, you don't have, right? A geological disaster includes earthquake, mass movements, volcanic activity, hydrologic floods, landslides, meteorological storms, climatological drought and global warming, biological infectious diseases, epidemics, and extraterrestrial impact the space. So these disasters are increasing in frequency. If we see the data of 20 years, from 1819, it was reported 4,212 number of events of disaster. So it increases from 4,000 in 10 years. It increases to almost double. So the frequency of the disaster are increasing, and it has the economic impact on the disasters as well, on the overall economy. And if we see the effects on the population, it affects the 4.3 billion population, and the casualties or the mortality is almost 1/4 of the mortality. This among all these disasters, 40% of disasters are flood affected disasters, and you must be experiencing this flood disaster in Malaysia also, and Pakistan is also prone to flood area. So these the frequency of floods are the highest, and the lowest is the earthquake. Earthquake is the 8% of the disaster. But if we see the mortality, the highest mortality is because of the earthquake. The highest mortality is because of the earthquake compared to other disasters. So the flood and storms are affecting 99% of mortality, but they damage the infrastructure, the quality of life of the people. So this increasing impact, increasing frequency, and about 74% increase in the major disaster events. This calls for the action that disasters are just not in statistics, are just not numbers, but they affect people, families, and livelihoods. So when they affect families, livelihood, and everything, the ecosystem, it affects the achievement of global goals defined by United Nations, WHO, and in which our national ministries are signatory to achieve those. So in disaster, almost all the 17 sustainable goals are affected, because they affect on the health and they affect on the economy. So they lead to poverty, they lead to zero hunger and all these things. And then it also calls for the action of collaboration, partnership, and ecosystem. The life below the sea also affected. When the life below the sea affected, all the fishermen and all the this is like a web of cause situation. So in this situation, what can be done? Because human development, sustainable development, and universal health coverage cannot be achieved without combating the climate change and without initiation of disaster preparedness. So why disaster preparedness focused on the nurses? Because research proved that through nurses care and also highlighted by Professor Dr. Ali's presentation that it brings better patient outcome, increased nurses' confidence, collaborative care approaches, mental health support, policy advocacy, and attention to vulnerable population because nurses are not working in the hospital, they work in the schools, homes, communities, and different roles as occupational health nurses and so on. So, evidence around the world shows that nurses' presence in a disaster can reduce the death percentage from 50 to 70%. So the role of nurses in the healthcare system is also increased. For more than around 60% of the workforce overall from the health is nurses. So nurses preparation is very important and nurses deliver 80% of hands-on practice care to the vulnerable. So positioning the nurses on the disaster preparedness and resilience is very important. Here, invest not only invest on the sustainable development goal too, but also focus on the other goals as well. As WHO highlighted that other team members can leave, but nurses not leave and leaving nobody behind because they provide the care 24/7. So WHO, IC, and International Conference of Nurses, American Nurses Association, and United Nations Disaster Risk Reduction also recommend nurses to be prepared for the disaster preparation, and they have identified the role to promote health, prevent illness, alleviate suffering, and restore health at the individual, family, and community level. And this call action that disaster, public health disaster cycle also prevent and mitigation, like when the community, when the nurse work in the community, they can motivate, educate, aware the community. Because I have experienced, I worked as a community nurse. There was a disaster, there was a warning sign that you have to complete evacuate, but they didn't because they were not aware. They don't want to lose their money. So, and all the cycles in preparedness, they can prepare the community, they can respond in the trials and providing the care and in the recovery and rehabilitation phases. So, at all levels. So, because nurses are prepared during their curriculum, the holistic approach of care, nurses are prepared for the case management, leadership management course, cultural health society, and all these courses are taught to the nurses to provide holistic care. So there are key barriers that ignorance, even though policies are developed but not been implemented, structural education challenges and so on. So here is a gap in the disparity between advocacy and implementation, nurses' lack of knowledge, regional and institutional inconsistencies. So there is a bridging gap through institutionalizing the disaster preparedness, like MASA are not preparing the nurses and other healthcare professionals for the disaster. In my country, we are also not preparing. So let's think and act to have such a great impact on preparing for the disaster. So these are successful studies like Japan, Australia, and USA provide the disaster preparedness and they have better systems and better outcomes. So, and there is a call for action that we have to develop the curriculum, take the initiative, and call for consistent funding and collaborative research. So, I would like to conclude that and take home message that investing in disaster preparedness today is not just a life-saving approach. It is a cost-effective commitment to protecting communities and healthcare system and achieving sustainable development goals and universal health coverages and ensuring the future. Thank you.
Okay, Alia, based on this proposal, what would be your action plan to develop your study, because it is part of your PhD,
Yes.
So this is a proposal. So in the methodology, among other things, what are the component that you must emphasize? Is it merely quantitative or quantitative or both?
Prof, I am planning to conduct this as a mixed method sequential study. First, because we don't have the assessment tools also to assess the situation of how prepared they are and what they are prepared. So my study will focus on the development of instrument to assess the preparedness and readiness, because only preparedness will not help unless they are ready to be in the field. So my study will be on the development of instrument. There is no instrument found specifically focusing on the nurses. So first I will take the qualitative component, in which I will take the stakeholders, the healthcare professionals for the qualitative data, that what they think should be the assessment tool for the nurses, and I integrate as literature search with that quantitative study, the results of that qualitative, and develop a questionnaire, a tool for the assessment. After development, I will do the phase and content validity, and then pilot test among the students. And then after successful development of reliability and validity of the instrument test, then I will assess among the healthcare professional, especially undergraduate nurses.
Thank you very much, Dr. Alia. You see, you have presented well is about public health needs for nurses, strengthen resilience for disaster preparedness and management. So, as far as this mentioned action plan, what does empowering mean? It's where you need to think about.
Yes.
Yeah, you need to think about and properly perspectively put it in, because nurses play a huge role in support in the hospital as well as in the pre-hospital care, yeah, in the field. So how are they going to support? So you need to think about, yeah, the risk assessment, and then of course the 2R 2Ps. 2R 2Ps. Yeah, that is two P's prevention, yeah, as well as yeah the no promotion. 2P, that means 2R means response, yeah, the yeah, response to our response as well as no recovery. Yeah, so you need to look into how to go about it, and then of course you need to look at trauma care as well as you need to look at the psychological first aid. That's where nurses play a huge role. Yeah, so that's what we would like to see here. Not how well it is. This is very good as an introduction. But when you say empowering, that means they must have knowledge to apply to the victims. Okay, so
in the cycle where I have the international roles of ICN and all these things integrated with the disaster cycle, they like in the mitigation, nurses have to be empowered, the warning signs and all the things, the plan to take the action to aware the community that what is the significance of warning signs and all these things. And then yes, yes.
Thank you,
And thank you
Alia.
for allowing me this time additional.
So
Thank
that
you.
concludes our oral presentation for today. So heartfelt thanks to all the audience and the judges for your patient listening and engagement. And thanks to all the presenters for the insightful presentation. So we conclude today's session. So we hope to see you tomorrow. Sorry, tomorrow at 8:30 a.m. So for another day of insightful, lot of serious presentations.
Thank you very much.
Oh, whose iPad is that?
What else? Stop it.
I can't believe you guys did that. என்னப்பா வாங்குறதுக்கு வேணும் உடனே ஓகே என்னப்பா வாங்குறதுக்கு நீ ஆங்கடி வர
Bye bye.
Hello.
Bye.
Bye. I might come or I might not.
Oh,
Thanks. Thank you. Now,